ठीक है ना? और बोलो बढ़ाओ। ठीक ठीक ठीक। अजी भाई देखिए सर बताइए। इसका वॉल्यूम चिक 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 हेलो टेस्ट आ रहा हाँ हेलो टेस्ट 1 2 3 4 5 चिक 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 बैठ जा साइलेंट अभी 2 मिनट चिक 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 1 2 3 4 5 6 8 हेलो चिक 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 हेलो टेस्ट 1 2 बता जल्दी आ रहा चिक 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 1 2 चिक 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 1 2 3 4 5 6 8 हेलो चिक 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 हेलो टेस्ट 1 2 बता जल्दी टेस्ट हैं अब मैं साइलेंट सुनाता हूँ शुक्र करो ओपन बाहर बंद करके देखिए वैसे हेलो चिक 1 2 3 अब सुनिए हेलो टेस्ट 1 2 3 4 5 8 9 10 हेलो गुड मॉर्निंग हेलो हाउ आर यू एंड दिस गुड मॉर्निंग हेलो चेक 1 2 3 4
check, 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 check. Hello, check.
to one and all present here. It gives me immense pleasure to welcome you all to this live robotic arthroplasty session. To make this session more interactive and engaging, we are going to have a short quiz. We encourage the PG to participate actively. Think of this as a collaborative learning experience. Now, I would like to call Dr. Dev Jaiswal and begin with the quiz. Thank you.
Good afternoon, everybody, respected seniors and the PGs present here. So we will start with the PG quiz now. So I will first tell you the rules of the PG quiz. So we'll accept that. Participants must be registered, so registration done already. Teams will compete collectively, no individual scoring. The answering rules, questions will be asked to all teams, open to all. Teams must press the bell or buzzer, or if bell is not there, you can raise your hand as well. The team that buzzes first gets the chance to answer. If the team fails to answer, the question will pass to the next team. No discussion with audience or the teams is allowed. The quiz master's decision is final and binding. So time limits, standard question without an image will be, you'll get 10 seconds for that, or in case of image or case discussion or a case question, you'll get 20 seconds. Time will start after the question is read. So scoring will be, if correct direct answer will get 10 points and correct pass answer will get 5 points. There's no negative marking. Scorekeeper's record is official. Conduct no use of mobile phones or reference material, no prompting from the audience. Teams must answer only when called. Any unfair practice will lead to disqualification. In case of a tiebreaker, we'll have a sudden death question will be asked. First correct answer will win. And Quizmaster's authority, Quizmaster may modify rules if required. Quizmaster's ruling is final. And most important rule, let's enjoy the quiz. So let's, so if the teams can come forward. Yeah. We have five teams, yes. Amritsar, 3 from Iaa-Nhs Jalan, 1 from Joshi, and one from Wardha. Yeah. First team, GMC. GMC Amritsar can come and sit over here. NHS Jalandhar can sit here. Joshi Hospital can have a seat here, over here. A team from, individual from Wardha can sit here. And GMC Jammu can come and sit here. कोई नहीं let's provide them with the bells. Okay. You can check the bells whether they are working or not, please. Okay. Time. Yeah, explain. Yeah. Okay, so we start with the first question. Name of the technique to reduce hip dislocation with ipsilateral femur shaft fracture? So for this you'll get 20 seconds and your time starts now. So we are very friendly, so we will give you a hint as well. Who rang the bell? Aaa-Nhs Jalandhar. Okay, if you can tell me.
Stimson.
Yeah, it's Stimson's gravity method. So the scorekeeper can give 10 points to Aaa-Nhs Jalandhar.
Who is the scorekeeper?
Haripriya. So moving on to the next question. Arthroscopic finding in the image below. So you'll get 20 seconds for this. Your time starts now. I'll give you a hint also. So this is more common on the lateral side, and on MRI you can. Okay. Who pressed for first? You.
Bucket handle tear of meniscus.
No, it's a wrong question. So we will. It will be. It's a wrong answer. It will be passed to the other team, which has rang the bell.
Parrot beak tear.
No, it's a wrong answer. So anyone else wants to try? I'll give a hint that we see a bow tie sign in this in three consecutive images in the MRI.
Discoid meniscus.
Discoid meniscus. Correct answer. So GMC Amritsar gets 5 points for this. Moving on to the next question. Sir, if they can. Yes. So moving on to the next question. What is the sequence of repair, replantation of the following structures after amputation of a hand? So your time starts now for 20 seconds. Please, somebody should try this at least. The answer is all there on the screen. You just have to try. Okay, GMC Amritsar, please tell me the sequence.
Sir, bone repair,
Okay,
bone fixation, then
please
then,
tell first. Bone
then extensor,
okay, extensor tendon then, flexor,
then nerves,
nerves,
then artery, then veins, and then skin.
okay. So it's not the right answer. So we would pass it if anybody wants to try. Who wants to try? Okay, Vardha wants to try. Please tell me the sequence.
We'll start with bone.
Okay,
Then we will fix the flexor tendons.
okay,
Then the extensors.
okay,
Then we'll fix the veins.
okay.
Uh,
Sorry, Vardha, you're going wrong. So that's why we'll stop here and no more passes, because obviously somebody will end up saying the correct answer. So the okay, someone else wants to try for a chocolate, no points. Aaa-Nhs Jalandhar, try at least.
First bone, then extensor tendon, then flexor tendon, then artery, then nerve, then vein, then skin.
Okay, it was close, but it's wrong. Okay, so the answer is first is bone, then is extensor tendon, then is flexor tendon, then artery, vein, nerve, and skin. So moving on to the next question. Name 3 methods used to assess external rotation of a femoral component in THR. And your time starts now, 20 seconds. Could you please start the time, 20 seconds? I will give you a clue. So these are a few lines that we use. Who wants to try? GMC Amritsar, please
Sir,
try.
by seeing the white side line and assessing.
By seeing the white side line, okay, that is one.
Okay. Then sir, assessing the epicondylar axis.
Transepicondylar axis, okay.
And
It's not a complete answer. We have given 3 things there. You can try at least.
yes,
Anyone else wants to try?
white side line वो हो गया and sir, by placing the jig intramedullary that jig 3 degree external rotation for by
Anyone else wants to try?
Anterior referencing.
So here, okay, fine. Nobody gets point for this. So here we have 3 lines. One is the white side line. The other is the
transcondylar axis, transepicondylar and transcondylar.
That you have already told. The last one, the most posterior one, is the posterior condylar axis. Okay. So we will move on to the next question. Name the sign and the condition.
Anteater, that collision between the calcaneum and the navicular, anteater sign.
Yeah, it's the correct answer. So GMC Amritsar gets 10 points for this. It's anteater sign and tarsal collation. Okay, so moving on to the next question. Name the procedures done for shoulder instability as marked. Any 3.
Sir, remplissage.
No, you have to tell which one is what.
Okay. सर क्या नाम था उसका नीचे वो कोरोकोइड को उतार के लगाते थे.
Please start the time.
Latarjet. Latarjet.
Okay, A is Latarjet.
Then sir, D is remplissage.
Okay, that's not remplissage. You can still try. There are 5 things. You have to say any 3.
Okay. Then the putty plat C is.
Okay, anyone else wants to try? Okay, so we'll give you the answer. So the first one is Latarjet, the second one is Bankard's, the third one was Magnuson procedure, the fourth was remplissage, and the fifth was posterior glenoid osteotomy. So moving on to the next question. Name the main structure hindering the reduction in this specific condition. And your time starts now, 20 seconds. No hinting from the audience, sir. Okay, so the answer is it's a capillary lesion. So here the volar plate hinders the reduction. Moving on to the next question. Please identify the pathology. And the time starts now. And okay, who was the first one? GMC. Okay, GMC Amritsar. Please tell the condition.
Sir,
Tell the full complete name.
avascular osteonecrosis of the left hip with involvement with the head collapse, grade 4 Fickett-Arlett with the acetabular changes.
We will pass on to some other team. Who was the second one who had rang the bell during last time?
Yes.
This is avascular necrosis of the left femoral head along with loss of contour, and it is a grade 4 avascular Fickett-Arlett grade 4 avascular necrosis.
Okay. Let's stop there. Okay, NHS Jalandhar had rang the bell. Okay, I'll give you a clue. Okay, say the answer.
Leg cow Perthes disease.
Okay, leg Perthes disease. And we are lucky that the classification was given from our professor from KMC Manipal, Dr. Benjamin Joseph. So we will move on to the next question, which is related to the same question. So the question is, name any 3 head at risk signs in the same pathology. For that, you should know what is Perthes disease first. So the time starts now, 20 seconds. It's a long question in cold orthopedics. Anybody? Okay, so the answer is lateral calcification, lateral subluxation, gaze sign, metaphyseal cyst, or a horizontal growth plate. Moving on to the next question. Name the index. Okay, GMC Amritsar.
Salsalvati. In Salsalvati ratio.
Okay, it's wrong. So who wants to try? Okay, NHS Jalandhar wants to try. Please tell.
Blackburn Peel ratio.
Okay, it's wrong. Anyone else wants to try?
Sir, it starts from D. नाम नहीं आ रहा उसका यार.
There's only one left. So okay, so we'll give you the answer. The answer is Catton-Deschamps index. So we'll move on to the next question. So you have to tell the sign which is common in the X-rays shown below. So this is the first X-ray. This is the second X-ray. This is the third X-ray. One peculiar sign you can see, everybody can see.
Sir, images एक बारी दोबारा दिखाना.
Okay, I'll show you the images again. This is the first X-ray. This is the second X-ray. And this is the third X-ray. Who wants to try?
Telescope is there?
No. Who wants to try? NHS? Do you want to try? Yeah. It's a boys question, yeah. Shubhang sir has given the clue. It's a boys question. Seen only in men.
Sir, seen in avascular necrosis of hip. And
Okay, leave it. Anyone wants to try? Anyone from the audience wants to try? So it's called John Thompson sign or Throckmorton sign. So in that we see the male genitalia pointing towards the side of the injury or the pathology. So please identify the congenital deformity. For this you'll get 20 seconds. Starts now. Please start the time, 20 seconds. So here the little finger actually deviates towards the radial side. So you've gotten the clue. Anybody wants to try? Okay, the answer is clinodactyly. So the next question, I suppose, as soon as you see the question, you will have to press the buzzer. So please identify the suture pattern. Okay, so please tell me what is the suture pattern. It is one of the strongest sutures that we put in tendon repairs.
Krakow's method.
It's called Krakow suture. Okay, NHS Jalandhar gets 10 points. Okay, next question. In DHS, tell the measurements of short barrel length, long barrel length, and Richard screw thread length. Okay, the time starts now, 20 seconds. I know mostly you're not seeing DHS these days in your hospitals, but then from exam point of view, you should know this. Who wants to try? GMC Amritsar?
Short barrel, 37 centimeters.
Try at least. Okay, fine. The answer is long barrel is 38 mm, short barrel is 25 mm, and the Richard screw thread length is 22 mm. So moving on to the next question. Name the sign and pathology. Please press somebody. I think Jammu has. Jammu has done. Please tell me the sign.
Sunburst appearance.
Sunburst and seen in?
Osteosarcoma.
Okay, GMC Jammu gets 10 points. Okay, moving on to the next question. Name the sign and diagnosis. Your 20 seconds starts now. Who pressed it? Okay, firstly I'll give a clue that it's seen in a nerve injury. Okay. Okay. Jalandhar has.
उसके बाद पहले.
Okay, Jalandhar, please tell me what is the sign?
Yes, ulnar nerve injury.
Ulnar nerve injury, and what is the sign? You can't give half the answer.
Warten-Burgess sign.
Huh?
Warten-Burgess sign.
It's called Wartenberg sign in ulnar nerve injury. Okay, moving on to the next question. Which facial compartment of the lower leg is most commonly affected by compartment syndrome? 10 seconds for this. Okay, who's pressed first? GMC Amritsar is pressed first. Please tell me which compartment.
Anterior. And
You can't press the bell and start thinking after that.
Sir, a posterior compartment, deep.
Okay.
Posterior
Anyone
compartment.
else passed on to other one? Who pressed the bell? Jalandhar had pressed it. Please tell me which other compartment.
anterior compartment.
Okay, the answer is anterior compartment, and it just gets 5 points as it's a past question. So moving on to the next question. Diagnosis. Your 20 seconds starts now. Who pressed first? Okay, GMC Amritsar pressed first. Please tell the
Osgood-Schlatter.
Okay, it's an apophysitis of tibial tubercle. It's called Osgood-Schlatter disease. So GMC Amritsar gets 10 points. Next question: a magnetic MRI of a 21-year-old female basketball player who felt her knee give out while playing. So which is the injured structure here? And your time starts now. 20 seconds. Okay, I'll give you a clue that you might not get Lachman positive here. So, who pressed the bell first? NHS Jalandhar, you want to try, please?
Medial retinaculum.
Okay, anyone else wants to try?
PCL.
Okay, wrong. So, okay, we have had our passes. So, I'll tell you the answer. It's medial patellofemoral ligament injury. So, we'll move on to the next question. So, the most important structure that resists anterior translation of tibia in ACL deficient knee. Is it? Okay. So, you get 10 seconds for this. We already have a buzzer. Who wants to try? Okay, please tell Jammu. Okay, the answer is posterior horn of medial meniscus, and Jammu gets 10 points for this. So moving on to the next question. Which of the following is the main stabilizer of elbow to valgus stress? You get 10 seconds for this. So Amritsar has already pressed the bell. Please,
Transverse
Amritsar.
oblique ligament, component of the ulnar collector.
Okay, we will pass it to some other one. Okay.
Anterior oblique component.
Okay, so GMC Jammu gets 5 points for this. Moving on to the next question. Name the test. Okay. Okay, fine. We'll start again. Don't press the bell. Okay. Name. Anyways, let's be honest. Who was the first one?
We are the first one.
Give Vardha a chance, okay, please. Okay, Vardha, please.
LASIK test.
Okay, it's not Lesige. Someone else wants to try? Only one team will get a chance.
Bragard's test.
Yeah, it's called Bragard test. So it's not Lesige because Lesige is actually passively lifting up the lower limb, and when you stretch when you dorsiflex it, it's called Bragard test, and when you compress the calf, it's called. Okay, it's okay. Next question. A 9-year-old girl sustained an injury as a result of fall. Classification system used for such fractures.
Delbet.
Okay, GMC Amritsar gets 10 points. It's called Delbert classification. Please, if somebody can check GMC Amritsar's bell, it's not functioning. Okay, we'll move on to the next question. Name the deformity, you get 20 seconds. Okay, GMC Jammu wants to try.
Congenital vertical talus, CVT. CT.
Okay, other team will get only one chance. Who wants to try?
Rocker bottom feet.
No, so I'll tell you the forefoot has gone into abduction and the calcaneum has gone into valgus. You got the answer already. So it's calcaneovalgus foot. Okay, going on to the next question. Yes, sir. Placement of screw in. Okay, who has pressed the bell? GMC.
Internal iliac.
Please take care of who presses the bell first.
Internal iliac artery. So it's not the right answer. Someone else wants to try. Okay, Jammu wants to try. Please tell.
External iliac vein.
Okay, that's the correct answer. Jammu gets 5 points. Moving on to the next question. Resection of two little distal femur will have what effect on flexion extension gap? GMC Amritsar. You can't press it and then think. Okay, who pressed? Who was? NHS, please try.
Decreased extension gap.
Decreased extension gap. Okay, that's the correct answer. Please don't do this. That you press the bell and then you start thinking. Don't do that.
सिर्फ ऑप्शन पढ़ने में टाइम लगता है.
हाँ तो बजा क्यों रहा है? चले भाई पढ़ के बजा दे. Okay. Okay, moving on to the next question. Plane of dissection in Watson-Jones approach. NHS Jalandhar, you want to try? Please tell. Firstly, tell what is Watson-Jones approach.
Anterolateral approach, and plane of dissection is between gluteus medius and
Tensor fascia.
tensor fascia.
Okay, that's the correct answer. Okay, fine. So NHS gets 10 points. Okay, the next question. What is the most likely mechanism of failure for patellar component shown here? So time starts now, 20 seconds. By the way, the broken path, it's called something that we'll be doing tonight. We'll be having tonight. It's called PEGs. GMC Jammu wants to try. Please tell.
Tension.
Okay. Other team will get one.
Not working. Shear.
Yeah. The correct answer is shear. NHS gets 5 points. Moving on to the second last question. Name 3 heat stable antibiotics that can be used with bone cement. NHS Jalandhar. You have to name 3, not 1.
Gentamicin, vancomycin, and tobramycin.
Okay, that's the correct answer. NHS gets 10 points. Moving on to the last question. What is buffered complex? Okay, if nobody knows, we'll pass it to the audience. Audience, somebody wants to try? Any scopy surgeons in the house? Okay, so I'll tell you the answer. It's a normal anatomical variant seen in 1.5% individuals. Buffered complex consists of a cord-like MGHL and an absent anterior superior labrum. So you can confuse it as something. Now you can tell at least. Okay, it's okay. You can read about it. Thank you. Okay, we were not expecting this from Jalandhar, but then NHS Jalandhar has gotten 65 points. Joshi has got no points. GMC Amritsar has scored 50 points. GMC Jammu has scored 30 points. And Varda has scored no points. So we have a winner, NHS Jalandhar. Yes, yes, sir. Motivate them. Second prize goes to. And the second prize goes to GMC Amritsar, and the third prize goes to GMC Jammu.
Okay. वो दो मुझे फर्स्ट कौन आया? I would like to request Dr. Rakesh Rajput to please come and present a token of appreciation to the winners of this live quiz. I would like to request NHS Hospital Jalandhar to please come. Next, it is GMC Amritsar. So we have the third winner is GMC Jammu. Thank you, everybody. It is my pleasure to welcome you all to this live surgery workshop organized by the Division of NHS Orthorobotics at NHS Hospital, a field that is rapidly transforming precision, planning, and patient outcomes. Every advancement in orthopedics ultimately serves one purpose, that is better outcomes for our patients. Robotic-assisted surgery has changed how we look at our joint surgeries, the way we plan, execute, and evaluate procedures. Today's live surgeries will help us see these unfold in real time.
Today's workshop provides a unique opportunity to observe complex orthopedic procedures in real time, allowing us to appreciate both the technical skills and clinical decision-making involved in modern surgery. Robotics is no longer a concept of the future. It is a part of our operating rooms today.
NHS Orthorobotics has been at the forefront of using technology to benefit our patients under the leadership of our Director and Head of Orthopedics Department, Dr. Shubhang Agarwal, and we have been doing successful robotic surgeries since 2019.
Today, you will be seeing cases performed by experienced surgical teams with open discussion around technique, challenges, and decision-making. So let's get started with the workshop.
Today we have faculty from all over the country. It is our privilege to welcome Dr. Rakesh Rajput from Kolkata, President, Indian Arthroplasty Association, who will also be performing today's robotic total hip replacement. Dr. Nilesh Shah from Mumbai, who will be performing robotic total knee replacement. Dr. Ashok PS from Chennai, who will be performing robotic unicondylar knee replacement. Dr. Manit Arora from Fortis Hospital, Chandigarh, who will be performing today's reverse shoulder arthroplasty. Dr. Miten Sheth from Mumbai, who will be performing robotic total knee replacement, along with Dr. Shubhang Agarwal, NHS Hospital Jalandhar, who will be performing robotic total knee replacement. We would also like to welcome Head of Orthopedics Department, Dr. Vijay Goni, PGI, Dr. Sudhir Garg, GMC Chandigarh, Dr. Bobby John, CMC Ludhiana, Dr. Rajneesh Kark, DMC Ludhiana, Dr. Rajesh Kapila, GMC Amritsar, Dr. Amandeep Pakshi, GMC Patiala, Dr. Anupam Mahajan, GMC Mohali, Dr. Ranjit Chaudhary, GMC Bilaspur, Dr. Tarun Goyal, AIMS Bhatinda.
Adding to the list are other star doctors, Dr. L. Tomar, President, Delhi Orthopedic Association, Dr. Harpal Singh, President, Punjab Orthopedic Association, Dr. Hariom Agarwal, Secretary, Punjab Orthopedic Association, Dr. Devinder S. Lal, President, Jalandhar Orthopedic Association, Dr. Rajesh Saggar, Secretary, Jalandhar Orthopedic Association, Dr. Atik Vasdev, Head of Orthopedics, Medanta Hospital, Delhi, Dr. Deepak Joshi, Senior Robotic Surgeon from Kolhapur, Dr. Narendra Parmar, Senior Orthopedic Surgeon from Navsari, Gujarat, Major General Dr. Ghai, Senior Orthopedic Surgeon from the Armed Forces, Jaipur, Brigadier Chetan Sood, another Senior Orthopedic Surgeon from the Armed Forces, Delhi.
And all the renowned and senior faculties from various parts of Punjab and Chandigarh who have honored us by accepting our invitation and taking out time from their busy practices to be here and participate in the scientific program, all with one aim, that is how to benefit the patient and progress the science of modern arthroplasty. Before we begin, please join us in welcoming Dr. Shubhang Agarwal, Dr. Naveen Chitkara, Dr. Sandeep Goyal, Directors of NHS Hospital, whose commitment to a clinical excellence has shaped the hospital's surgical programs. We sincerely thank the directors for their support and vision. Now, I would like to thank Dr. Shubhang Agarwal for both hosting the event and opening the doors of the operating rooms to share their expertise. It is a privilege to welcome you, sir. I would request, sir, to please come on the stage and give an overview of the course. Thank you.
A very good afternoon to you all. So I would just like to welcome all of you and thank you, a big thank you to the faculty which has traveled all the way from across the country and Dr. Rakesh Rajput for inspiring us to continue this course every year. And I think we are getting ready in the OT. So can you connect me to the OT first? I would like to confirm if they are ready with the positioning, or how long will they take to start. In the meanwhile, we have strived so far to stick to the theme robotics, because throughout the country there are many conferences which do conventional surgeries, conventional discussions and all. Of course, the role of conventional discussions surgery cannot go away, but the idea is that with the speed that the technology is taking over our lives, we will, if you don't use some sort of technology in your routine daily practice, you will become obsolete sooner than later, and you will phase out purely for the lack of relevance in the practice which will be in the next few years. The AI you see on Instagram, China showing robots doing kung fu and all those things, and you don't know what's happening. And the other side of it, as replacement surgeons, we should feel a little threatened. The biological genetic therapy that is coming in with genetic modification and nanorobos going into the bloodstream and repairing cartilage and repairing medical lesions. But the only thing that keeps you going is that there is enough misery already in this world, and if there is no new disease, there is enough work for us for the next 20 years at least, to prepare people who are already damaged. And I would like to take this opportunity to learn from the seniors who are here, and we are all here to share our experiences, and we hope to have a good time discussing the scientific advancements and learning from each other's experiences in this. Thank you, and welcome to the course. So are we connected to the OT? Can you hear us? Dr. Manit Arora is there in the OT already for the first live surgery. Are you going to announce?
We would like to begin straight away with the first live surgery of the show, reverse shoulder arthroplasty. The patient is already in the OT. The surgery is being performed by Dr. Manit Arora from Fortis Hospital, Chandigarh. The anesthetists for the surgeries are Dr. Pooja Agarwal, Dr. Harleen Sandhu, Dr. Jashanpreet Singh. Thank you, Team Ortho in the OT. I request the moderators, Dr. Nilain Shah, Major General Dr. Ghai, Dr. Imroz Jindal, Dr. Inderdeep Singh, to please come on the stage and moderate the live surgery. I would like to request Dr. Rakesh Rajput sir to please come on the stage and say a few words. Please, sir.
So thank you everyone for asking me to say a few words. Thank you, Shubhang. Since the inception of this course, I have been involved with this, and I have kept Shubham encouraging. I was actually upset last year that he couldn't make it. So this time I said, there's no way you're not going to do this. And here we are here. So there's a saying that Zindagi lambi nahi badi honi chahiye. But Shubham, tera stage thoda zyada hi bada ho gaya aaj. This has gone really high. But I think we shouldn't waste any more time. So I represent the Indian Arthroplasty Association. It's an association which has been there for a very, very long time, more than 40 years now. And our senior persons, many of them actually know more with us, but their teachings and their techniques are still being practiced with all of us. And I would request all young members, if you want to be pursuing the art and philosophy of joint replacements, whichever joints they are, you need to join, because we are not only involving ourselves with hips and knees, we are also with elbow, shoulders, ankles, and soon I think a lot of hands will be involved. So if you are interested, please join Indian Arthroplasty. You just need to click Indian Arthroplasty on your Google search and it will take you to the web page, and it's all done through the web page. It's very easy, 2-minute jobs, and you are a member of Indian Arthroplasty. This gives you a platform to actually, propel your career also. And last year, Shubhang missed out, he was away. So we got Dilbans, who is another surgeon from Jalandhar, into our executive committee from North Zone. So all of you are welcome. We have some young surgeons who are representing Indian Arthroplasty from different zones. We have an IA Connect, which means we connect with Tier 2 and Tier 3 cities where programs are being held. And then there are associations, like this one is associated with IA, and we lend ourselves to, one of our members will come here and support you as much as we can. So it's a big association, and we've got big heart. We welcome all of you, and I hope that this conference, like the last ones before, will be as successful. Thank you, Shubham.
So, can the OT hear us? Can somebody acknowledge, can they hear us? Are we audible in the OT? Could you switch off the OT camera? Once you've braved the patient, then probably you can come live. I just waited for that. Actually, so, Dr. Manit, am I audible? Dr. Manit, in the operation theatre, am I audible?
There must be that big speaker there. Are we audible in the OT? So good afternoon, Dr. Manit. Dr. ID here. Hi, we can see you, but we can't hear you.
Your speech is muffled, Dr. Manit. Your speech is muffled.
Thank you.
So we can hear you now, Dr. Manit?
Yes, can you hear me now?
Yes. All good, all good. Welcome to Jalandhar.
Thank you. I'll show you the patient.
Yes, perfect. So we wanted to know about the patient history here.
Can you see the screen?
Yes.
Camera.
Camera.
This is a patient that had a rotator cuff repair 10 years ago, and they're coming with pain, disability, difficulty with ADLs, and if you can see the X-ray. So, what do you think about this X-ray?
The OT light is coming in our way.
OT light is coming in the OT light.
Cameraman, you need to adjust, brother.
Can you take this without the OT light?
Actually, the handle of the Dr. Manit, hi, Shubhang here.
Hi, how are you?
Very well, thank you. Yeah, that's good.
Yeah. So, can you see the X-ray? Everyone?
Yes, yes,
So
we can
please,
see.
Please comment on it. What do you think about the X-ray only? And this is important for everyone in terms of, obviously it's a failed cuff repair, happened 10 years ago. 10 years she was doing well. Recently has developed pain, disability, difficulty with ADLs. So what do you think about the X-ray?
We need to comment.
Any comments from anyone?
So, audience, anyone?
When was the rotator cuff repair done?
Dr. Shubhang can tell us.
10 years, 10 years.
10 years ago?
Yep.
10 years ago, not done by us. We were scared we won't have a case, but she just landed up and she was in severe pain, and we thought that she's a good candidate. What do you say, Dr. Mani? Is she a good candidate,
Yeah,
right?
she's a very good candidate, so that's what I'm trying to say in terms of her X-ray. Anybody can just comment on the X-ray, forget the history, forget everything. What do you think about it just looking at the X-ray by itself?
No, there is evidence of acromioclavicular arthritis. There is sclerosis of the glenoid, a small osteophyte probably around the inferior lip of the glenoid. So obviously it's a degenerated joint. Would be most importantly would be most post-traumatic. And yes.
Just what do you think about the X-ray itself? That's it.
The proximal humerus, the head of the humerus is riding high. It's
Very good. So there's
yes, there is superior migration of the.
which is a negative finding for revision rotator cuff repair. So in the setting of superior migration, we know that rotator cuff repairs do poorly and revision rotator cuff repairs do horribly. So again, it fulfills what we want in terms of a reverse shoulder. What about the osteoporosis? So she's clearly got a lot of osteoporosis going on in her shoulder. She's got superior migration of her head. You can see the implants in from the last surgery. What do you want to comment about the implants? Are they in a good position or not? Just from the X-ray?
No, it's difficult to comment only on one view.
It's just one view, but you get an idea in terms of the entry point of the implant.
So most likely it was a single row repair which was done.
Is the angle good that they put it in initially? I don't know who did the surgery.
So again, the angle was meant, it is not, if you are talking about the dead man angle, that still doesn't hold very good, but seems to be okay.
Yeah,
Again,
so overall,
yep.
this was a decently done cuff repair.
Yes.
And it survived 10 years, right? So now after 10 years, she's 76. She had the cuff repair when she was 66. But at that time, her bones would have been better. Her quality of the cuff would have been better. So now the next most important thing for us is let's look at her MRI. Can you see the MRI? Can you look here, please? Can you point it here? Babu,
It's not very clear.
look here. Onto the MRI. So can everyone see the MRI films?
Yes, yes.
Yeah. So what do you think about the MRI? Dr. Ivy, sir?
Yeah, it's retorn, its cuff has retorn and it is almost retracted maybe to the glenohumeral level.
Yeah. So some
so
key findings here. Superior
there-
migration, there's a lot of osteolysis around where the implants have been. I hope there is no history of fever or any other symptoms. The cuff is massively retracted. This is a pate 3 cuff. And if you go to a Y view, which is a very important view in terms of figuring out whether you want to do a rotator cuff repair or a reverse shoulder. So on the Y view, this is the Y view. So can we see this? Can you zoom in, super zoom in onto this? As a possible way, just onto this last one. Rupesh, can you move your thumb to one side so see the screen and see what is there? वो उस पे लगाओ क्या मुझे दिखेगा ना कि क्या है? Yeah. So can everyone see this and this? This is the Y view, right? So you can see the scapula makes a Y shape, and here you want to look at the muscle. So at the top of the Y, you want to see how much muscle is fitting into that Y. So you draw a line across the top of the Y. If your muscle bulk is more than a line, so that means you've got decent muscle mass, which means decent mobility of your cuff, which is prognostically good for rotator cuff repair. If your muscle bulk is below the tangent line, it means that there isn't that much mobility, isn't that much play, so you're going to struggle with a rotator cuff repair. And of course the Guttaglia classification and how much fat atrophy it is. So I don't know if you can see from there, but this is a Guttaglia 3 and tangent positive. So pate 3, Guttaglia 3, tangent positive, failed cuff repair with superior migration, arthritis, osteoporosis. This is as perfect a patient as you can have for a reverse shoulder.
Dr. Manit, would you like to comment upon subscap on the same Y view, the one you were commenting? The subscap also seems to be, yep, yes.
It is retracted as well.
There is complete retraction.
Subscap tear, SS tear, IS tear. The only thing that's really alive right now is the TM, the teres minor.
Yep.
It's evident there's a complete retraction of the repaired RCT.
Same matter. So can we look here now?
Can the camera now focus on the patient?
So can you tell us your plan now?
So this is the position that we want the patient in. So it's a V chair position.
Cameraman, can you, we can't see the patient, sorry to interrupt. Cameraman, please focus on the patient.
Okay, so this is how we're going to, can you look there?
No, we can't see the patient. Yep, yes, perfect.
Okay, so remember,
Can the cameraman please zoom down on the shoulder?
Yeah, it's on.
Yep. So the anatomical markings?
yeah, alright. So you can see this is the AC joint. This is the thing that's bobbing up over here. Then I'll feel for the coracoid process. I'll mark the coracoid process. I feel the deltoid bulk, and I can feel under my thumb, I can palpate the deltopectoral groove. So I want to go right down this groove like this. Okay? The way that we're traditionally taught to do a shoulder approach is like this. Okay? And we must develop a habit of migrating away from this approach and going straight down. Nothing's going to happen here. I've done 500 reverse shoulders. Nothing will happen to the axilla. We always worry about the axilla infection ऊपर आएगा. It really does. I've had 2 cases of infection over this time, and it doesn't migrate up. So felt the coracoid process. I can feel the deltopectoral interval just under my thumb here. And normally this is how big we would want our incision and our approach. Of course.
What will be the inferior, Dr. Manit, what will be the inferior extent of your approach?
So it's about 7 to 8 centimeters down from the tip of the coracoid. And you can see the axilla is here. So that's the axilla, and quite far, about 4.5 to 5 centimeters from the axilla. So I'm not that worried about transition of the axillary bacteria into my skin incision, but I don't want to do this and then end up coming inside to this.
So basically you stick to the deltopectoral approach.
Correct.
Always.
Correct.
Is that all? You do that always, or are there any indications when you differ?
The deltoid split, because the only thing that a reverse shoulder relies on is the deltoid. Why do we want to touch the deltoid when it's the driving force for the reverse shoulder.
And even when you revise your glenoids, even then you stick to the delta pectora?
Correct.
Okay.
Okay. Should we inject it?
Just a word from the anesthetist. What's the Dr. Manit? Dr. Manit, can you hear us? Just a word from the anesthetist. What's the anesthesia that she's given? And what's the blood pressure? So basically, you're keeping the systolic low.
So what MAP are you aiming at, ma'am?
The systolic blood pressure is 90, the diastolic blood pressure is 56, the MAP is 60.
Perfect.
So that's a good BP.
Yeah, that's absolutely
Yeah, yeah.
perfect. Just the most ideal BP for an arthroscopic shoulder surgeon.
or per se any shoulder surgery.
Plastic can tolerate a little more.
Plastic can tolerate a little more.
So what we're going to do, sorry about the delay, what we're going to do is get lignocaine area and just superficially inject it into the skin, subcutaneous tissue, before we take our incision. Yes. Feel free to make maximum noise.
So what will be your plan?
So the important thing to see here while we're setting up is you want to check that you can go into full extension, because when you're going to be breathing, we need full extension of the arm, right? And you want to be able to manipulate it into IR. So I've got it set up so the scapula is completely off the edge of the table. So if your scapula is on the table, it hinders the mobility of the glenohumeral joint as well, because there's two joints there, it's the glenohumeral joint and the scapulothoracic joint. So your scapula must be completely off the lateral edge of the table to allow mobility. Often what happens is we take them to the edge, but the scapula is still constrained by the table, so that when you go into extension, it's not really going to allow you to have that extension. Then you get stuck inside and provide. Okay, so lignocaine area, okay, can everyone see that? Alright, so we just the smallest needle possible, we'll inject it into the skin. Pink color needle, okay, see that? Let's put just a mop and a skin knife, please. Yep, thank you. Skin knife. Yep, yes. Alrighty, so can everyone see?
Yes.
Okay, I'll start. I'll start. I'll start. Okay, so the next part is I just dissected the subcutaneous tissue, and if you can see here, I've got the deltoid on the left and I've got my pectoralis in my finger on the right. So, and you can see the vein just there. Do you see the vein hidden in the fat?
Yes.
Can you see this?
Yes,
that's the cephalic vein.
Yeah, I'll just show you. That's the vein. That's the deltoid. Where the bleeding is coming from is the vein. Yeah, can you see that? It's in the fat.
The camera has to has to go between your hands.
I think cameraman.
The camera has to go between your hands. Now it's better.
He should come from
more
your shoulder.
More to his left, yes.
So the next part is that I take my index finger of my right hand and I sweep the deltoid away from the humerus. So I've got my index finger of my right hand, it's slipped underneath the deltoid, right? And I'm sweeping it off the humerus, up and down, right? So I'm going up to the humeral head and down here. Then I'm going to put in my first retractor, which is a subdeltoid retractor. Akash. Mota. Like me. Yeah. Where is it? अभी निकाला है? नहीं, वो strike. मोटा strike. Very good. मैं थोड़ा सा इसको वो दे दोगे आप मसल रिलैक्सन हल्का सा थोड़ा टाइट. Okay, so I've got my light focus करेंगे थोड़ा सा इधर. The light cannot come from the back. इसको आगे से आएगी. Okay, so do you see this? Now I've got the deltoid retracted away. Now my left index finger goes behind the pectoralis major and sweeps and creates a pocket there. So under my right angle retractor. And sometimes when you do this, you feel that the pec is very, very tight, even after muscle relaxation and everything. You can safely release the top half of the pec. Yeah, that's good. In the novice area.
Your pectoralis, Dr. Manit, in trauma, in post-traumatic surgeries of pectoralis would be very handy for you to identify.
Yes, it's important to identify because you have to repeat the same steps for every single surgery. The next part, you can see the clavipectoral.
Yeah, correct.
You see that?
Yeah.
Now, with my left index finger, I'm sliding up the clavipectoral fascia and I put it on top of the coracoid. Can I get the small spike now? So you take this in your hand. Very good.
So effectively, you're trying to expose the superior glenoid.
Correct. The humerus. Yep. So
That should be the humerus head.
can you see? Hey, no, come on. Do it properly. Left hand, right hand. Okay? There you go. So can you see that now?
No, he's shifted. He's gone too left. Yeah, now it's better.
Yes,
Absolutely.
Now we can see.
Yeah, that's the clavipectoral fascia.
Yes. So this is my conjoint tendon. I've got one retractor sitting above the coracoid. I've got my spike retractor pushing the deltoid out of the way, and this person is holding the pectoralis with the right angle retractor. Okay, the next part is we'll get an artery and scissors, please. So now I'm going to incise the clavipectoral fascia and scissor. Okay, very good. So here I'm staying on the lateral edge, just going up. Okay? So I've got my conjoint tendon separated. So can you see that? Now with my sweeping index finger, which is apparently everywhere, so I sweep the conjoint tendon away. Okay? And I can also feel the axillary artery there. So it's about 5 centimeters, 6 centimeters down from the inferior part of the coracoid, and it sits just under the conjoint tendon, and you can feel it pulsatile, right? And your musculocutaneous nerve is also going to enter in the same region. Small right angle retractor. Good. Okay? Now the important part is, leave this. Now the important part is the right angle will go where my finger is and retract. Okay? Retractory is to perform gently. So it's very important, strong hand, weak hand. Okay? If he puts too much tension on this, he'll damage the musculocutaneous nerve. So the pec hand has to be strong to allow me to see. The conjoint hand has to be soft, just so that I can look inside. Okay.
In other words, you'd avoid putting a home hands here.
Yes.
You'd rather prefer using a right angle retractor.
Now can you see this? Can you zoom in and show this? What is this, audience?
So we can't see. Cameraman has to come from your think left shoulder.
Is it from behind me and just show this?
Okay, is it the long head of biceps?
No.
Or the three sisters maybe?
Three sisters.
Yeah.
Very good. So for the gold medal, for the gold medal, why are they called three sisters? Why not three brothers?
So you always fall for sisters.
Why are they called three sisters? There's a reason behind it. Suction. Okay, can you stop? Yeah. So now I'm just going to cauterize the three sisters. You can put a clip as well, and there's a small ascending branch which goes up. So cauterize that as well. So I've cauterized them here. That's it. I'm done. Okay. Now I want another spike, medium size. Okay. Yeah. So now this is my third spike. It's going to be my superior subdeltoid spike. Yeah. And you can come out with this. Okay, so can you see inside now? So I can feel the biceps, artery, scissor. Can you see?
Yes, we can see.
Yes.
It's a beautiful view now.
Okay.
Yeah.
So here I'm just incising the fascia, and you can see the biceps just there. Okay? So I'll incise the bicipital fascia now. Do you have a proper artery to policy sharper? Okay, so I'm just above the biceps. I'm going to incise its fascia and expose the biceps. Okay. Okay, so can you see that? That's my biceps just there. Do you see that? Does everyone see the biceps?
Yes, yes.
Okay, now we cut it. That's it. ठीक है? आगे कैसे बॉन्ड करूँगा? Stitch दो. Now the next part is we're going to tag our subscapularis. ठीक है? So, बाबू. Bad boy करने का. All right. So subscap. I'm going to tag the subscap just with a simple ethibond. ठीक है? Cut करिए. Cut it. ऊपर से. Very good. Hold this. शाबाश. Cautery दो मुझे. Okay. So now we want to peel away the subscap or whatever is left of it, so we can access the joint. ठीक है? So right next to the biceps, I'll start my incision.
So Dr. Manit, for biceps, you just leave it like this? You just do a tenotomy?
We'll do a tenodesis at the end of the procedure.
Okay. Would you like to tag it before? I mean,
कहीं नहीं जाने वाला.
Okay.
वो इधर ही रहता है. Okay. Can you hold it with one hand? Vertically towards the ceiling. Vertically towards the ceiling. ऊपर ऐसे. Very good. ठीक है? So can you see here I'm entering the joint slowly, slowly. Okay. And this is just the remnant of her this. एक सेकंड ये पकड़ोगे? Yeah, good. So you need to come up. नहीं बहुत है. Too many people is negative always. Yeah. Okay. So can you see that the head already wants to pop out? This is just the superior capsule. This is not cuff. So can you see the head is naked ऊपर से?
Yes.
And I'm just releasing the biceps. There we go. And whatever remnant tissue is left here. Okay. So can you see that the head is out? Oh, wonderful. निकाल दिया. ऐसे.
So the anchors were
ये
at
पकड़ो
perfect
इधर आके. ठीक है. So do you see this? Comments on the head, please.
So I think these are the entry points of the anchors.
Where? Yes, just here. But you can see that, you know, from an arthritis point of view, it's probably a diffuse grade 2 arthritis, right? It's not a severe thing. There's not big osteophytes here as well. So I'll feel my bicipital groove again. This is my lesser tuberosity. This is the greater tuberosity. This is where they've put the anchors in. And from the top of the bicipital groove, I go 1 centimeter back, 1 centimeter medial, and that is going to be my entry point. And that usually corresponds to the highest point of the humeral head as well, except in cases of malunion or severe arthritis, where the entry then. Yep. हिलना मत. Okay. So we've made our entry starting point for our reamer. This is the entry reamer, and can you see the position of the arm? Very important.
Cameraman, zoom out, please.
Yep. 90-degree angle, right? And he needs to push it in slightly. So one hand goes under the elbow, one hand here. अच्छे से पकड़ो. Good. And just slide, push in. If you hold it like this, what happens is that when you ream, you may go one side or the other side, or you may come out the front as well. So it's important to get the humerus vertical.
So what system are you using?
This is Zimmer Biomed Comprehensive Reverse.
Okay.
Lowest 10-year revision rate in the world. Okay, so then we do sequential reaming. Okay. Until, so it's just like a hip for all hip surgeons until we get cortical chatter.
6, 7. So are you planning a non-cemented stem or a cemented stem here?
Uncemented, mostly. We'll see once we cut the head how much metaphysis is there.
So how is the feel like?
I don't want to commit to anything until I see it. Okay, so here I've got some cortical chatter and I stop at 2. The marking will be at 2.
Okay.
So
is this when you put your retroversion guide?
Yes. So this is my retroversion guide. It's going to come on. Now the important points, retroversion guide, when you're putting it on, is the boom corresponds to the LT. And your version corresponds to the forearm axis. Can you see that?
Yes.
Yes. Now I've set it at 20. Again, it's another topic. किस केस में कितना करना चाहिए? Should it be anatomical reverse shoulder or non-anatomical reverse shoulder? But just for the purposes of this demonstration, 20. Now my cutting block comes on. Okay, so now you tilt it like this. So can you see how we've changed the angle of the arm for the cut? I've maintained the version, but I've taken the arm into flexion to allow the cut to happen. Yeah. Okay. So I'm locking this, and this is a 145 cut. Yeah, ठीक है. All right.
So where do you want your jig to be? I mean, how much cut do you want?
So, because it's set at 2, so the cut will automatically get set based on the entry. If you sink this, you'll get a lower cut. If it's too high, you'll get a higher cut. But basically, we want all of the cartilage to be gone, just like a hip. So for hip surgeons, it will be much easier to do reverse shoulder as compared to knee.
So you just want to be subchondral, right?
Yes, subchondral.
Yeah.
So all the cartilage will be gone. Now, important retractor, this is the Fakuda. Okay, can you see this?
Yeah.
This is going to protect my posterior structure. So pec इधर है, very good. और इसको आप हटा सकते हो, ठीक है? इसके बदले ये रखो. And this will protect my conjoint for the cut. And ये green आएगा हाथ में या नहीं? Too many hands? देख ले अगर आते होंगे ना. ठीक है. Saw. Yeah. So next part we do the saw. Yeah. And so again flexion for the cut. Okay. Osteotomy. Cutting block goes off. Osteotomy comes on. And that's my head out with the anchor as well. Can you see? And we'll see if there's another anchor here, somewhere maybe in here. We can dig that up. Yellow. Alright, so that's my head cut done at 145 degrees. And I'm done for the meantime for my humerus. Ye chhod do. Everything comes out. Back will go up. Yeah. Rupesh Babu, isko pakdo. Aise. Right hand. Ye wala, left. Deep suck. Deep sucking. Deep suck. Back up हो जाओ. थोड़ा सा मैम वर्टिकल कर देंगे. नहीं, मेरा वाला retractor. So, just want to show you something very important. Can you hear me? Can you see me?
Yes.
Okay. वो मोटा वाला posterior retractor दे पहले. थोड़ा सा हो जाएगा मैम. Yep. नहीं. Spike वाला. Yeah. So this is the retractor that comes in the set. ठीक है. Very bad retractor, because when you put this posteriorly and the person levers in osteoporotic bones, what happens? Your assistant is going to put too much pressure, and then you'll end up with a fracture of the posterior glenoid. So this is a retractor designed by me. It is a modified Iaa-Nhs retractor. Okay? So you can see, I can send it to whoever wants. Okay? So it's got a curve to fit into the glenoid, and this is a non-rasp surface for grip. Okay. So this is going to go posterior. Yes, perfect. Hold it with like just this much force. बस. और ये वाला हाथ इधर. Wonderful. Anterior though. Now you need to come to this side to show the glenoid. This is the anterior. It's smaller, but again we need to be careful that we're not putting too much pressure. Yeah. So you can leave the green now and just hold this. Yeah. Gently. ना लीवर नहीं करने का. Gentle. आराम से. और मुझे वो दे दो. Superior spike पतला.
So cameraman needs to come
Cameraman,
from
you need to
again.
come from this side somehow.
Yep.
Yeah. So that you can see the glenoid. Yellow. ये पकड़ो. That's it.
Just a question, Dr. Manit, just a question. No, we can't see now.
Can you see now?
We can see you now. We can't see the glenoid now.
That is a horrible thing. Can you थोड़ा सा ना वो देखो.
I just have a question, Doctor.
Can you see the glenoid now?
Yeah, we can. Partly we can.
Beautifully.
I just wanted to ask you, why don't you use a Fukuda now?
Fukuda?
Yeah.
It's too big.
But then Fukuda has 3 sizes.
Yeah, but it's still too big.
Okay.
And the handle is too bulky.
Ji.
So वो interfere करेगा. When I'll drill, I'll show you. Okay, so can you see this? I've got my glenoid on view here. ठीक है? Caught it. So, yep, just.
So what structure is this? You were just holding it now?
This is part of the subscap.
Part of the subscap.
I just really थोड़ा green को pull करो ना. Yep. Yep. So this is now just whatever the remnant of the inner part of the subscap is, which is my IGHL and MGHL. I'm releasing that. Now I'll peel off the biceps, and this is the remnant cuff tissue. Can you see this? Just there.
Your hand is in. Yeah. Now.
You can see that.
Yes.
Yep. That's the remnant cuff posteriorly. So probably a part of the IS. The IS for ID. Yeah. Suction करिए. Very good. ठीक है. So you can see the labrum here.
Yes.
Yeah. So now we'll start peeling away. You don't need to be aggressive with this. Not too much needs to be done. थोड़ा नीचे यहाँ पे सक करो ना. मुझे base देखना है.
But inferiorly, you want to completely expose it.
Correct. So you can see here. Now I know where my inferior part is, and now to identify where I want to go, you can drop a line down the center, a line across like this.
Correct.
Where the two intersect is going to be my entry point. So there's a guide for it as well, if you want to use the guide.
And your entry point would be a little towards the inferior side.
Anji?
Entry point would be more towards, would lean more towards the inferior angle.
Yes, because the central screw must come out of the anterior vault.
Correct.
Not posterior. Suction करते जाओ साथ साथ थोड़ा सा. Drill दे दो. Yep. Guide. नहीं. So this is the guide. So you can use this as well.
We can't see
if you're at the inferior part. Can you see that? Oh.
Your hand is coming in the way. No.
Is that better?
No, cameraman needs to be more proactive towards just.
Can you see that?
No.
Yeah.
Yes.
Okay.
Yes.
So the inferior part corresponds to the inferior part of the base plate. So I can put it here and just make sure that I have got no bone underneath. So I'm at the absolute inferior edge of the glenoid.
So, so any tips for improving the glenoid vision?
Andy? Yep. Reamer? What about it?
So I just want to know, to get the tips, how to expose the
Look,
glenoid.
I think you can see it's a very good view of the glenoid.
Yep.
The glenoid here is completely exposed. So the retractor, the humerus is being pushed back by that retractor as well.
Yes.
Anteriorly, gentle on this hand, and we've got that
on the top.
If you can get the camera a little more on the top, from above your head.
ये देखिए wobble हो रहा है. ये देख. See that? It's
And the guide you have inserted, what angle was it, or it was a free hand?
Can we fix this? वो ना eccentrically ream करेगा फिर. You'll end up creating a big crater.
Dr. Manit, what was the angle of the guide?
So this is at a 10-degree slope. So if you can see that, you can see how it's going 10 degrees up. है ना?
Yes.
10 degrees superiorly. So we've got 10 degrees inferior tilt now on the base plate.
Okay.
इसको ना टाइट कर दो, वरना ऐसे वॉबल करेगा ना, it'll make a big defect. So the most important person as an assistant is him, because every single time you would have seen he wants to look inside, right? The natural tendency of man is to look inside where we don't want to look, right? So every time he does that, he relaxes, and every relaxation that comes means again we have to re-tension it. So it's very important that you have a non-doctor as your posterior assistant, because he'll be least interested in ki kya ho raha hai. Yeah, ठीक है, better than before, whatever. Okay, so this is my reamer now going on. Just get a wash as well.
So we can see the posterior margin of the glenoid. Can cameraman show us the anterior margin as well? Can you ask him to show?
Careful with the retractor, I was slipped now.
Yes.
So, Dr. ID sir, can you please tell me when we should stop reaming for the audience?
I think you will be a better person to tell this. You can feel the good bone. I mean, how the feel of the bone is. Or the reamers are the old ones.
Alright, now traditionally we've been taught to get an inferior smiley face so that we're entering the subchondral bone. Let me show you a trick that I have been using where you don't need to do that, and we've done it for like the last 100 cases.
We need a little better anterior retraction.
Anterior?
Yes.
Yeah, just slightly.
We need a better anterior person, period. Not a Rupesh.
Or maybe a small retractor to hold the subscap.
Abhi theek hai?
The
No, inferior margin is not clearly visible, and we have the small cuff of tissue in between.
I think it's the camera that needs to move
camera
a little
probably needs to
bit.
come from above your head.
Just base plate de dena iske baad. So can you see this? So what I'm doing, I'm creating drill holes all around the glenoid, and this is going to help with my integration.
So you'll be happy not to take the cartilage superiorly.
Yeah, so the superior cartilage should be intact, but superior cartilage should be intact. The inferior part should, so when you've got a reamer, can you see my hand? So this is the glenoid, right? Now if you've got centric reaming, can you see that?
Yes. Yeah, we can see.
I have parallax error. So, yes, this way, that way. ये better है, ठीक है. So अगर I've got concentric reaming, when I ream, I'll get red everywhere. But because I've got 10-degree inferior tilt, when I ream on the 10-degree inferior tilt, so I'll get red subchondral bone at the bottom and pure white cartilage at the top, which is known as the smiley face. And if you look here, can you see the smiley face?
No, he has to zoom in.
Yeah, we saw that when you just reamed. That's very nice.
So we've got red at the bottom and we've got white at the top where we've made the holes. Hole de bhaiya, matlab.
So if the assistant on your right,
so can the camera turn 90 degrees to the left anti-clockwise? It will give better orientation to the audience.
just pull on the green threads.
Yeah. So can you see?
We can see you
इसका
again.
स्क्रीन दिखाओ ना. मुझे जो आप दिखा रहे हो वहाँ पे I want to see that. Yeah. Can you see the base plate? एक second.
Yes, we can see.
See the base plate?
Yes.
Yes. Okay. So it's got a tantalum mesh. All right. This is going on. Hammer. Yeah. Here we go. Suck. Okay. So that's my base plate in. Central drill. I need to pull out this central screw now. Yeah, guide wire. Okay, ये पकड़िए, ठीक है. This is a very important instrument. This is the Murad. Can you see that? Now this checks the seating of the base plate with the glenosphere. So we put it on. Yeah, you just don't leave it. ठीक है, ये green पकड़ लो थोड़ा सा. कि जो subscap है. Yeah. Let me push the subscap away for you.
Yeah, just that's right. If you could just get that out of the way.
Yeah. Can you see now?
Yes.
एक आर्टरी दे दो मुझे.
Yeah, that's what we wanted.
एक आर्टरी देना. Yeah, very good.
A little bit more of retraction. Yeah, that's it. Exactly.
Yeah.
Yes.
Okay.
Now
So
please
now-
mark. Now please mark the inferior glenoid.
Yeah.
Just point towards the inferior.
देना मुझे वो,
Could you just
आगे
swap,
देना
please?
वापस. So suction करो. Suck. Good.
We need
This
to know
is-
how inferior have you gone.
This is the inferior most edge
Yeah.
of the glenoid. So I am bang on the inferior edge. This is the anterior part. I am bang anterior, bang posterior, and superiorly I've got a little bit of clearance, that's fine. Okay, now centrally suck, central suck. Central screw mein suck.
How do you orient your base plate and your peripheral screws?
Good. Now take this out. Now see the murad is going on top, and just see the way it's going to sit. Do you see that?
Yes.
So that means my base plate and glenosphere union will also be like this. Just hold this gently like this. Very good. Okay. Central drill though. Good. So my central drill goes on now. Okay. Second cortex. Yep. Hold this. Now don't pull this out like this. Okay. Wiggle it out. Wiggle, wiggle, wiggle. Depth gauge. If you pull it out and you haven't got good fixation, the base plate will come with you. So I feel the second cortex. So that's a 25 suction. And एक artery लोगे. Central suck, central suck, central suck. Yep. Okay. मुझे screw दे दो.
So Dr. Manit, can you tell how do you orient this base plate to place your peripheral screws ideally?
So the central screw will be in the center only.
No, the peripheral screws. I want to know the how will you place it?
So the superior screw hole, एक second ये निकालना please. Superior hole points to the biceps, inferior hole points to the triceps.
Okay.
The anterior part and the posterior part, they can vary a bit. You just want to feel is there good bone underneath them, which I can feel.
Perfect. Thank you.
Yellow, please.
What's the length of the inferior most screw?
अभी वो किया नहीं sir, अभी drill नहीं किया.
Usually what's the length of the inferior most screw?
25 to 30 के बीच में.
So you prefer a 25 or if you measure 30 you'll still go for 30?
Whatever I measure I'll put that only.
Okay.
Okay, अब क्या करना है, ये आर्टरी लो और इसको फर्स्ट होल में डालो और दबाओ. This is very important because अभी तक आपका base plate is just press fit. So now I'm locking my base plate in. As I do that, I'm creating significant torque. Now that anterior artery is very important so that the base plate doesn't spin while I do this. Okay, artery comes out, central suck, central suck. And then again, I'm going to check my seating. That's good seating. I'm happy here. ठीक है, ये लो और मुझे वो दो inferior locking. Okay. So what is the most important screw to put? The one that I'm putting inferiorly. ठीक है. And then superior, then posterior, least important anterior. Okay, 25, 20, 25, 30 भी दे सकते हो. 30 दे दो 25.
That's exactly why I asked it, because that's usually you know what size you need.
I would want
you
more
don't measure.
than less. Yep, just hold it like this.
So all are locking screws?
All locking screws here because I've got very good fixation. I don't want to compress it more with a compression screw because then I'll end up medializing my base plate. If I medialize it, then I'll have to lateralize on the glenosphere.
Yes.
So because she's a thin lady, I don't want to lateralize too much on her glenosphere because then it'll...
ID, there is a question from the audience.
It'll jut out.
Yes.
Okay, artery अब वापस आएगी बाबू.
Sorry?
Artery वापस उसी जगह पे.
So there's a marking on a bit.
Good.
There's a marking on.
Sir.
Dr. Manit.
हाँ जी.
So there is a request from audience that if you measure the screws depth with the depth gauge, it will be easier for us to understand.
वो देना 30. It's literally just you just have to open the screw. Yep, good. $30. 25 last है.
So the blue screws are all locking screws,
Locking
right?
screws, yep. And you can feel the base plate sit now. So I'm really pushing all my body weight, but the base plate does not want to go anywhere, which is good, hopefully.
Sir, 25.
25.
So standard glenosphere.
Yes, so we'll take a standard glenosphere, ठीक है, and BC offset पे कर देना. Good. Okay, solid. Artery though. Okay, important thing about offset. So you can see here I'm at the inferior-most part of the glenoid. What if my base plate was slightly higher? Maybe I've done an error and I've gone a bit high. How do I compensate? How do I compensate?
So you can compensate on the glenosphere side.
Correct. So I can go inferiorly on my glenosphere. I can use an inferior offset glenosphere. What if I've gone too much medially with my base plate? How do I compensate?
So that again, a lateralized glenosphere will help you in that. You
A lateral offset
yeah.
glenosphere. Yeah.
So again, these options are not available in all the systems.
Most of the systems will give a lateral option.
Yeah.
A few of the systems will give an inferior option.
Yep.
And the comprehensive system gives both options.
Yeah.
So can we also see if it's possible to
can
the
we
way
see-
they are setting the
Yes,
rotation?
please show here.
Cameraman.
यहाँ पे दिखाना.
Yes.
कैमरा इधर कर दो इस पे. You will need to come here so that it can look down. उनको just दिखाना कि how you set BC offset. नहीं दिखेगा वहाँ से. You will need to move a little bit, है ना? That उसको आना पड़ेगा ना थोड़ा सा इधर. We can't.
We can see. We can see that.
Yeah. So can you just वो लगा दे उस पे और फिर मैं दिखा देता हूँ. Lock कर दे. So on this is the glenosphere offset setter, and here we're putting it at B to C, which gives us 3 mm of inferior offset. And that's a standard that we use for everything. Okay, so can you see this here? Yes?
Yes.
No, now
Yes.
back to this, yeah. Yes, Padu? Yeah, can you see this?
Yes.
So there is less superiorly, more inferiorly.
Yeah.
So it's an inferior offset of +3. That means I've given +3 mm more inferior than superior. Okay, suction. Okay, hammer. Yep, yellow. And remember, this is not a TKR, so gentle, gentle, gentle. No big hammering, no smashing it in. There's no cement here anywhere, hopefully. Yeah, gentle taps, and then I'm feeling the fit. Is it locked? Yes, it is. ये press fit है. The glenosphere is press fit into the central screw. So some systems have a central screw. Out with everything. Yeah, take this out. शाबाश. और इसको निकालने के लिए internally rotate करके. ठीक है? Okay, back down, ma'am, please. Okay, +300 दे देना. शू लायो ना? शू है ना?
आकाश +300.
शू है ना? ये पकड़ लो ऐसे. एक राइट एंगल चाहिए और एक और राइट एंगल चाहिए. So can you see this? This is our initial incision. Deltoid on this side, pec on this side. Are we going too slow? Do you want me to speed up?
We can't see. Yeah, now we can.
Are we too slow? Do you want me to speed up?
I think we are on time.
Okay, take it. Yeah, just a right angle इधर आएगा. नहीं, आप इधर आ जाओ. So I've got the pec out of the way, subscap in the hand. Now I'm going to pull the deltoid, right angle retractor. Very good. नहीं, ठीक है, कोई बात नहीं. Yeah, so you go on top of the GT. Very good. And lift. Lift.
Can cameraman focus, please?
So you are coming in the way of me. Just a bit. इसको ना GT के पीछे जाने दो. Good. Okay, so that's my humerus. Just hold it like this now. Arm. Very good. Okay, suction. So this is, I'm back to my initial cut where I've done my reaming. Look. So the last broach we did was 10 mm. So we're going to start at -2, which is 8. And again, I've got the 20-degree version parallel to the forearm axis. And like a hip, lateralize, lateralize, lateralize. थोड़ा suction कर लोगे साथ में ये splash हो रहा है. Yep. So just keep pushing in, pushing. Very good. Lateralize. I'm lateralizing now. Suction करना. अंदर भी. Good. निकाल दो. This is 9. So that's good. Next 10. And I've got good metaphyseal bone. So no cementing.
Okay, so you are going for non-cemented one.
Non-cemented.
Perfect.
Yep. So I've got it lined up at 20. Tap, tap, tap. Gentle taps. Not a TKR. And you can see stability. Okay? I cannot displace it with rotational movement. And out. Okay, 10 का stem दो और +300 चाहिए मुझे. Washes दे दो. Saline and bank mix wash.
Do you prefer putting up some amount of graft in the metaphyseal bone?
नहीं sir, it's good अभी. ये अच्छा है. मतलब this is good amount of for a shoulder.
There is no toggle.
This is a good enough metaphysis for a shoulder.
So both the ankles are out?
Yeah. Who knows? One is out.
One is
the
out,
other
okay.
one is not in view.
Okay.
Even if it's inside.
So leave it there.
It won't make any difference. If we go finding it, we'll destroy the metaphysis.
Yes, makes sense. So you are going to use a mini stem?
Yes, sir. Mini stem. Uska, Rupesh, what is the length of the mini stem? 84. 84 mm mini stem. The standard is 122.
The proximally coated or it's a porous stem? It's
Proximally coated stem. I will just show you Abhi.
Yes.
So it's +1. So we've gone 10. So it gives you +0.5 peripherally. So +1 हो जाएगा.
Okay.
So this is my stem. Can you see that? Proximally coated, distally polished, slightly tapered, conical fit. Okay? And this is where the metaphyseal engagement and incorporation and integration is going to happen. So I've got my 20-degree version parallel to the forearm axis. I'm lateralizing it as I put it in, and gentle tap, 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 tap. Okay? That's it. Okay? Now the next most important step is you want to see that is there any bone that's going to interfere? Is it higher than the topmost part of this? Yes, there is a bit of bone here. I need a nibbler and then a rasp. Yep. Okay, so I'm nibbling away a part of this LT, which I don't need that much of, and I'm making it so that the highest point of my humerus is going to be the top of this. So you can see circumferentially around it, I'm clean. I haven't got anything which is going to prevent the seating of my tray.
Okay.
Out. Tray liner. Ma'am, time कितना हुआ since we took incision? It feels like 4 hours. 150? 150. Okay. 245? Yep, tray liner. So again, we've gone very, very slow just to demonstrate. Alright, tray liner comes on. Okay. Yep. Impactor. Tap, tap, gentle taps. Yep, very good, very good. Bas, okay. Now my pec comes out, deltoid will come out.
So what was the size? What was the size of the liner?
Yeah, this is the smallest size because I felt it with my hand, but you can use a trial also.
Okay.
So this is a shoe, very important instrument to have in your arsenal. The shoe, so I have taken my arm into extension and I've taken it into complete adduction. Can you see the gap here between the glenosphere and the posterior part of the humerus?
Yes.
Now the shoe is going to slide in that gap. Now you need to hold it exactly like this without rotating it. Okay? Just relax. Don't let it come out. And I'm taking it into flexion and I'll slide it out. Nikal do. Yep. So that's it. All done. Just right angle ले लो एक.
So you never do a trial reduction before putting all these? The
When
final
I started,
implants?
sir, I used to do a lot of trials.
Okay.
Yeah.
So with your experience, you are
Yeah.
getting away from the trials.
Yeah. So you can see it rotating there. Let's see how much impingement free abduction. Very good. I've got full external rotation. I've got near full internal rotation. Again, why do patients struggle with internal rotation? Do you want to see? I can
Yes.
show you why. So a lot of people will come to you कि internal rotation नहीं आ रहा after a reverse, right? This is why. So as I take it into internal rotation, do you see what's happening?
Yeah.
What happens?
So
It's
there's
hitting
an
the
impingement.
conjoint
Yes,
tendon.
yes.
So some people advocate doing a conjoint lengthening or a release, but studies have shown no difference in outcomes when you do that for internal rotation. But that's what limits internal rotation. See that? Now the test for stability is a shuck test, longitudinal traction. I've got no movement there. I take the arm into ABER, abduction external rotation, and I take it into extension internal rotation. Stable to both. I've got no edge loading. I can't get my finger in there. It's nice and tight. Now the next step will then be to repair my subscap back on top of this. Okay? So I'll do some release. I'll stitch the subscap back to the lesser tuberosity to cover my prosthesis, and that's it.
So you always repair the subscap? So whenever possible?
Generally, I would want to repair a subscap when possible, unless it's very retracted or very shredded, and then I would not.
Okay.
And what about the biceps tendon?
I'll do a tenodesis, so I can see my biceps. See
Yeah.
here, it has not slipped down. Artery denum.
We can
So
see
you
the
don't need to tag
we can see
it.
the tip.
It's not going to go anywhere. It
Yeah,
cannot go anywhere.
yes.
Yeah.
And subscap you
You see the biceps?
Yes.
That's right.
So I'm going to stitch the bicep to the surrounding soft tissue.
Soft tissue.
Okay? And the subscap, so we can see here.
So you repair
it's-
it in internal rotation?
Now see this subscap very tight. We'll do a little bit of release, see if it comes. If it doesn't, I'm not bothered. I'll leave it because I've got a very stable prosthesis here. It was hard to go in. It's not coming out.
Perfect.
You repair the subscap in internal rotation?
In flexion, 20 degrees flexion, 20 to 30 degrees of external rotation. After doing an adequate subscap release, I'll check how much mobility it has. If it's free and comes out to the LT, I'll repair it using a transosseous stitch. So I'll get a free needle, take a couple of bites and stitch this down. Okay? Or sometimes when I know I want to do a subscap repair beforehand, so before putting in my stem, I do 2 drill holes and pass a free tape through that, so I can do a X-box repair.
Correct. Presently your arm is in neutral position?
No, so it's in 20 degrees of flexion and 20 degrees of external rotation.
Okay.
Okay.
Thank
So,
you.
Thank you
a
for the fantastic
wonderful surgery.
Yep.
Yep. Thank you to everyone, the team and NHS and Dr. Saab.
I think he
and-
deserves a big
and-
round of applause. Flawless.
Yes, and they've been a very good support staff and helping and giving me little tips. So thank you so much, and thank you so much for inviting me.
Thank you, Dr. Manit, for a beautiful demonstration. There's one quick question from the audience, if you're okay to take it.
Yeah, sure.
Is there any difference between the principles you applied just now and principles in doing RSA for trauma?
Yes, so in trauma cases, starting off your planes are gone, but you have to stick to the same dissection. And the thing that helps us a lot in figuring out where we are in trauma is the biceps. Find your biceps. So use the biceps as your key. It will tell you whatever is medial to it is the LT, whatever is lateral to it is the GT, and release the biceps only after you've done a complete exposure. Often you'll see the ball will go subcoracoid, right? Next question, how do you take it out? ठीक है? जब ball आपका subcoracoid जाएगा, subscap कभी नहीं फटेगा. So it is the part of proximal humerus fractures. So find the subscap, tag it, use it as a lever, then dissect the subscap from the ball, and then in the ball put a spike or a corkscrew and then lever it out. If you try to pull it just like that, subscap usko resist kari jayega and it won't let it come out. So you'll struggle for half an hour, but you have to peel off the subscap. Subscap aap release karoge tabhi ball will want to exit. And if you've got, I've done some cases where the ball is bilkul hi axilla mein chala gaya. So I put a finger from the outside into the axilla, I lift up the ball, and then with a spike I'll gently do a levering technique just to bring it out. But again, सबस्कैप रिलीज करने के बाद ही.
A big round of applause for Dr. Manit Arora from the audience here, and thank you. And thank you, Team NHS in the OT.
Thank you everyone.
Thank you, sir. That was an excellent demonstration.
You'll do it.
I would request Dr. Shubhang Agarwal and Dr. L. Tomar to please come on the stage and honor Dr. Major General Dr. Ghai and Dr. Inderdeep Singh.
Too tight.
Thank you so much, sir.
Now, I would request moderators for the session 1, which is on the talks, reverse shoulder arthroplasty. I request the moderators, Major Dr. Arvind, Dr. Atik Vastev, Dr. Jatinder Singla, and Major General Dr. Ghai to please come on the stage and moderate the event. Also, I would request the speaker on the scientific session to kindly be ready to come on the stage afterwards.
Actually, I moved to Jaipur now.
I know, I came to know. You met last at Fatigue's conference, no?
Ji.
I just told you moved to Jaipur.
Thanks, Shubhang. May I request Ravi, Dr. Ravi Gupta, to please come. He's going to speak on indications and contraindications for reverse shoulder arthroplasty. Nice to meet you. Vadiya hai.
Good afternoon, and my gratitude to Shubhang and his organizing team for giving me the opportunity to be here. Can you project this laptop? Okay, thank you. So I'll be talking about the indications and contraindications, and I'll give examples of each. So he's a 63 years old shopkeeper from Ambala who injured both the shoulders. And this is the X-ray. You can see the head fragment is very small, so the screw purchase will be a problem. And these are the CTs of the left shoulder. So osteosynthesis should be our first preference, but since the head fragment is too small, so osteosynthesis is likely to fail. This is the right shoulder. So in this case, we did on both sides reverse shoulder, and that is the function at 2 years. Earlier we used to do hemiarthroplasty in these cases, but in hemiarthroplasty, the function of rotator cuff is very, very important, and it has been seen that in a large percentage of cases, the tuberosities, they don't heal well, so they don't get a good function. So this is the role of tuberosities and cuff if you are doing an anatomical shoulder or a hemiarthroplasty. In a shoulder, if you are doing an anatomical shoulder, if there is no rotator cuff, when you pull the deltoid, the humerus tends to go up, so there will not be any rotation. And this hand shows the rotator cuff. When there is a rotator cuff, the humerus will rotate rather than going up. So reverse shoulder has a mechanical advantage. You don't need a rotator cuff for its rotation. So this is another case. Actually, he underwent a rotator cuff repair. It was a massive rotator cuff. He underwent somewhere in Delhi, but the patient belonged to Patiala. Then he came to us. And if you look at on your right side, you can also see the osteophytes. So once you plan a repair, you should see all those things. So we did a reverse shoulder replacement, and the patient is, having a good pain-free shoulder. So the second indication is a rotator cuff which is not repairable. The first was a 4-part or a 3-part fracture where osteosynthesis is not possible. Now we come to the third indication, osteoarthritis in the elderly patient, especially when there is a glenoid bone loss. Earlier people tried anatomical shoulder in these cases where the rotator cuff was good, but then they saw that the loosening of the glenoid was very common. So that when they shifted to reverse shoulder, so then the results were much better. So this is another indication of osteoarthritis in the elderly. It may be an osteoarthritis or it may be an rheumatoid arthritis also. But if you are treating a rheumatoid arthritis, because sometimes the bone is soft in rheumatoid arthritis, so you should be careful when you are implanting the glenoid base plate. Now the fourth indication is if there is an anatomical shoulder, as you see on the left side, and there is a loosening of the glenoid. When you want to revise, when the reverse shoulder was not there, people were revising it with the anatomical shoulder. Now the best function is if you are revising the anatomical shoulder, then you should use a reverse shoulder. So this is the fourth indication. Now the tumor surgeons, they are doing resection of the proximal humerus, and most of the times the tuberosities are gone with the resection. Again, in those cases, as I mentioned, the function of tuberosities is very important for an anatomical shoulder. So reverse shoulder is the best implant for such cases. Now we come to that people are, talking about reverse shoulder should not be done in patients younger than 60 years because there were concerns about longevity of the implant. But all over the world, many people did it in younger patients also. If we look at the data of Australian National Registry, the revision rate at 7 years in different age groups was not very different. More than 75 years, it was 2.7%, and 55 to 64 years, it was 5.7%. So it is not a really contraindication, but you should be careful that we don't misuse it in younger patients where the rotator cuff is good. But it is also known that if you do any arthroplasty in younger patients, the revision rates are higher even in anatomical shoulder and not only in the reverse shoulder. So why to blame the reverse shoulder? Now this meta-analysis on Younger patients, reverse shoulder arthroplasty in patients aged 65 years or younger. It also concludes that reverse shoulder is a reliable procedure in patients aged even lesser than 65 years. But I am not preaching that we should do it in all the cases. Where the rotator cuff is good, then we should try to prefer the anatomical shoulder. Now we come to the contraindications. This is one of our patients who had a locked dislocation of the shoulder, this elderly lady. And because of the persistent locked dislocation, there was loss of glenoid. So there was an insufficient glenoid. So we planned for reverse shoulder, but on table we found that the glenoid base plate was not possible to be fixed. So we repaired the anterior glenoid with the help of the graft taken from the head, and then we did the hemiarthroplasty. The patient is doing quite well. The other contraindications, like in any arthroplasty, active infection, non-functional deltoid. That's very important because deltoid is the main source which is giving abduction to the shoulders. If the deltoid is not working because of any reason or axillary nerve palsy, then it's contraindicated. So in summary, there is a posterior glenoid wear in osteoarthritis, that is an indication, 3 to 4 part fractures, tumor reconstruction, failed anatomical shoulder, and if there is a glenoid loss or deltoid deficiency or infection, they are all contraindications. So in younger patients, people are using it, but I am still very cautious in using it in younger patients. Thank you very much.
Thank you, Dr. Ravi. I think that was summarized pretty well. Are there any questions?
Dr. Ravi, I think you kind of brought out most of the things, but the dilemma that we all face at times is that, the 55-60 group, where this is a 4-part fracture or even a younger at times, and the Hurtle criteria are all saying it's going to be avascular, but still you have to fix. You can't always replace. So how do you approach such cases? The dilemma is about replacement and fixation, and the fixation is likely to fail. Painful joint for 2 years, 3 years, and then eventually you land up.
So I always talk with my patient that these are the problems in this fracture. The likelihood of failure of fixation is there, but it will preserve your own shoulder. So if I fail after the fixation, there is an option of replacement later on, or the second option is we go for replacement straight away. So if the patient is willing for 2 surgeries, I prefer the first option, and if he says, okay, I want to preserve my shoulder, I'll go with the osteosynthesis.
But that dilemma will always persist of whether to go in for a staged procedure, whether to go in for 2 procedures, or whether to go in for a definitive procedure, because one of the contraindications of a subsequent definitive surgery in the form of a TSA is low-grade infection or infection. So you try fixing it and the patient lands up with infection, then you've left him for no way. So one school of thought also, the paradigm dips more towards going in for a definitive procedure to start with, but then at the cost of probably a revision in times to come.
But I have quite a good number of patients where the fixation was done somewhere and they failed, and I converted them to either hemiarthroplasty or reverse shoulder. So they are all doing well.
I think the way you put it, it's always better to discuss with the patient and give them options and let them decide what they do, and just document that.
That must be documented.
What I do is I try to fix the tuberosities very well, so that at least the tuberosities heal, and at least he doesn't have a reverse. He gets a anatomical shoulder or a total shoulder, and reverse is left for the second stage.
So if we have young surgeons sitting in the audience, then the teaching always will be to go in for osteosynthesis.
See, I have another lecture, hemi versus reverse shoulder in younger patients, and the last line in the summary is, I am married to tuberosities.
Pardon me, come again?
I am married to tuberosities. So I am just saying what Dr. Sood said.
Thank you, sir. Thank you for very lucid presentation, as expected and as always. Thank you, sir. We now request the next speaker, my co-chair, Dr. Arvind. Arvind is basically an arthroscopy trained surgeon. Of course, he does trauma, he does joints, and he's just finished his study leave in arthroscopy and with the overseas visit as well. So he's going to speak on the patient selection, risk factors for poor outcomes.
Good evening all. It's a privilege standing here in front of the two of the stalwarts of orthopedics and armed forces, Ghai sir and Sood sir. So carrying forward from the previous speaker, Ravi sir, so we know the indications and contraindications for the reverse shoulder arthroplasty. Now we'll be looking into something finer details as to within this subset, what are the patients or what kind of patients with particularities can result in poor outcomes. So as we know, the use of total reverse shoulder arthroplasty has increased to a greater rate, and now the trend, even the aging population and an expanding range of indication has given us the opportunity to use reverse shoulder arthroplasty in much more regions, apart from the initial indication of rotator cuff arthropathy. So, but the general consensus in all the literature that we had and from our personal experience is that the reverse shoulder arthroplasty definitely shows a better functional outcome in almost all the cases, all the indications that sir has just laid down. But at the same time, in that particular subset of patients, there are certain characteristics that can distinguish, that can give rise to slight amount of changes in the outcome and the range of movement. So let's go through some of them. So this is one systematic review which I have used as a guide for this presentation. So a few of the personal factors include age. It has shown that higher the age is associated with better post-operative ASCS scores after reverse shoulder. But at the same time, it is shown that the higher age was associated with a decreased post-operative range of movement. But here, one thing I would like to do is, even though this is what I found in the literature, I've tried to go into the details of the level of evidence so that we need to take all these comments and all these findings from these studies with a pinch of salt, because not all of them stands, it's not very, convenient to the logic. For example, this particular evidence that the higher rate has a negative influence of range of movement following a reverse shoulder has a very low quality evidence. Similarly, with the higher age leading to better shoulder function has got a very low quality of evidence. Similarly, few studies have shown that the male sex is associated with a lower post-operative improvement when looked upon by the patient PROMs. And then it's also showed that there are actually conflicting studies showing the post-operative range of movement based on the gender. But again, this evidence particularly is low to very low in quality. Then this is one of the parameters, the patient selection parameters, which has shown moderate evidence, which includes the patient height. It is seen that the greater the patient height, better is the post-operative outcome, even though the exact cutoff for this height was not elucidated in the particular literature. So, but there is a moderate quality evidence showing that there is a better patient experienced shoulder function after reverse shoulder with higher patient height. Does dominance of the hand has any role in the poor patient outcome? There are few studies which show that there is the dominant arm is associated with a better range of movement as well as the functional outcome. However, this particular evidence is also very low quality. Certain things like the disorders, the diagnosis of the indication was rotator cuff arthropathy, or was it primary osteoarthritis? Two studies we could find which shows that the cuff arthropathy is associated with a better post-operative function. However, one study showed that the cuff arthropathy has got a better functional score, has got a lesser score as compared to the primary osteoarthritis. Not much significant evidence here. Does prior surgery play a role? Of course, it's shown that the patients with prior shoulder surgery has been associated with a lower post-operative functional scores. Comorbidities. This is the region where it's showing that, it's been giving us mixed signals. There is a particular paper which shows that the comorbidities such as hypertension, diabetes and depression are associated with poor post-operative outcome, as the common sense would suggest us. But there exists one more paper which shows that the presence of hypertension was in fact associated with a better patient outcome. The reason unknown. Yeah, what about the pre-operative functional score and the post-operative functional score? As the logic would suggest that the patients with better pre-operative assess score was associated with better post-operative care. But there are studies which was found in this review of literature which showed that there is a subset of patients with better pre-op ASS score which showed poor improvement after the surgery. However, the quality of evidence was suggested as low. Pre-operative range of movement is also one of the considerations to be taken into while selecting the patient for reverse shoulder arthroplasty. It was seen that when looking for the forward flexion, abduction and external rotation, a better pre-operative range of movement was usually associated with a greater post-operative range of movement. However, this range of movement pre-operatively and post-operatively had nothing to do with the functional outcome of the patient as measured with the PROMs pre-operatively as well as post-operatively. The visual analog score, the pre-operative pain score, what does it have to do with the surgery? The higher the pre-operative VAS score was associated with actually better post-operative functional outcome in the score. As we would think, suggesting that the patient was suffering a lot pre-operatively, which after the surgery, the patient related outcome measures were much better in them. Few other studies showed that in study conducted from 2015 to 2018 with minimum of 2-year follow-up, they added few more parameters to this, like the presence of primary osteoarthritis, the availability of private insurance, and a higher preoperative AACS score was associated with excellent outcomes post the surgery. However, some of the poorer outcome measures were the patients who have workers' compensation status, the preoperative diagnosis of depression, cuff tear arthropathy, preoperative substance abuse, especially opioid use, a higher number of allergies were associated with poor outcomes. Here what I would like to summarize is that wherever indicated as seen in the previous lecture, the surgery has shown remarkable increase and improvement in the function as well as the scoring system. But there are certain factors which are not, it is not a determining factor, but it definitely helps in counseling the patient as to how much improvement in function that one can expect. So based on the evidence, moderate evidence can be given only for 2 factors. That includes a preoperative range of movement and the height of the patient, which has a positive effect on it. So this can be used as a guide for preoperative counseling. Thank you.
Thank you, Major Arvind. Any questions?
In a nutshell, tell us who's a good patient, who's a bad patient.
Sorry, sir?
In a nutshell, tell us which patient you should avoid and which patient is going to be a good one.
Sir, any patient in which the indications laid down by a revisor where it fits, we have to do it. Yes, sir. Demographically, male patients slightly worse outcome as compared to female patients, but the moderate evidence is on the patient height. The smaller the patient, the outcome might be less. And the secondly is the preoperative range of movement. Lesser the preoperative range of movement, the less likely the functional scores are going to be. Yes,
Hello.
Yes.
So I think he very clearly gave one statement, the patients who are in depression, we should be cautious for any surgery,
yes,
including this.
Yes. Thank you very much.
Thank you, Major Arvind. Thank you so much. I request the next speaker, Dr. Jindal, to please come and speak on soft tissue tensioning and instability prevention.
Good afternoon, everyone. At the outset, I'd like to thank General Amresh Ghai and Brigadier Chetan Sood for making me capable enough to talk in front of such an august gathering. And today's topic for me is soft tissue tensioning and instability prevention. So, dislocation or instability in reverse shoulder arthroplasty is a devastating complication, and the incidence can range anywhere from as low as 1.5% to as good as in every 1 in 3 patients. So before we dwell on the factors affecting the stability, we should understand what is happening to the shoulder in rotator cuff arthropathy, since it is the most common indication for undergoing a reverse shoulder arthroplasty. The center of rotation moves superiorly and laterally. Now, to negate this, we have to basically, in reverse shoulder arthroplasty, bring the center of rotation down and medialize it. These are the two things which we have to deal with when we are doing the reverse shoulder arthroplasty. Now, initial designs of Gromont only distalized the humerus. Now, because of which there was no medialization, so this resulted in a long liver arm and resulted in a very high torque, which resulted in early failures because of the glenoid loosening. Now, one part of superior and lateral migration has been taken care of by distalization. Now coming over to the medialization. Now, why medialization is required? Once the center of rotation after reverse shoulder arthroplasty is medialized, the anterior and posterior deltoid are recruited, and they take on the roles of the rotator cuff. So as is shown in the diagram that zone 1 and 4 are the main deltoid zones which are recruited after reverse shoulder arthroplasty. But what are the issues with the medialization? There is loss of contour. Although these patients are very old, but sometimes, especially the female patients, can be very chary regarding the same because of this depression. Second is instability because of the cam and effect and reduced deltoid wrapping. Third is scapular notching, and the fourth one is weak active external rotation because of the reduced tension of the posterior rotator cuff. So in this presentation, my main objectives will be to highlight how the component design or the modularity of the components can be used in our favor to increase the stability of the construct. So I'll start with the humerus. First we'll go for the type of humeruses which we have, inlay and outlay, then we'll go for the versions, then we'll go for the neck shaft angles. First we'll start with the inlay. Now, as all of us know that inlay designs result in loss of metaphyseal bone, and it places the pivot within the metaphyseal bone of the cut surface. Since the surface area is more, so bone growth, ingrowth is very good. In onlay design, since there is a preservation of the metaphyseal bone, there is an addition, and the humeral component sits above the humeral cut. So there is additional distalization and lateralization of the humerus, which increases the deltoid tension. And it has proven beyond doubt that there is a better range of motion, especially external rotation, with onlay designs. But this comes at a cost. Now, because of the distalization and lateralization, there is higher tension of the deltoid, which results in higher incidence of scapular spine and acromion stress fractures. Now coming to the neck shaft angle, initially Gromont went for a very valgus angle of 155 degrees, but subsequently we have found out that 155 is not a very good angle for shoulder stability. So over a period of time we have moved from 155 to now 145, few implants offering 143 and 135 also. Now what happens with the varus neck shaft angle? There is increased deltoid tension, because of which there is increased stability. There is lesser chances of notching, which has been proved beyond doubt that in varus angulation there is lesser chances of notching. And this is mainly because of the increase in the distance between the humeral calcar and the scapular neck. Now, the third is the better shoulder contour. Although may not be very important for Indian population, but in Western population they are quite chary about their appearances, so that thing is also there. But this also again comes at a cost. What are the disadvantages of a neck shaft angle? That there is an increase in scapular and acromion stress. These are few photographs showing the acromial or scapular stress fractures. There is another thing, the abduction notching. Because of the increased humeral lateral offset, there is a decrease of acromion humerus distance. These are the immediate post-op X-rays which show, you see these first two X-rays and you are very happy and you feel that, yeah, I have done a good job. But it's very important to get a abduction view immediate post-operatively, because this patient, after 3 months of reverse shoulder arthroplasty, has started to have some lysis at the acromion. 3 months, 12 months, and at 4 years, this patient had a devastating fracture at the neck of the implant. So Koreans have come up with a very nice preoperative predictor for this abduction notching, which is acromion GT angle less than 35 or humeral lateralization of more than 1.7. So if you are contemplating that it is more than that, then you have to keep abduction notching in mind and do not put on a varus stem. So abduction notching is mainly because of less distalization and more lateralization, which results in decrease in the distance between the acromion and the GT, or proximal humerus, I should say. So if you will land up in such a situation, then we should have these eccentric or offset humeral trays to our disposal, and they basically distalize the construct and prevent the abduction notching as is seen in this photographs. Now coming to the humeral version, ideal is 20 degrees, and I'll have to cut short. So up to 20 degrees is usually the retro version which is kept, and again another paper by Koreans which they have found out that keeping it as a fixed 20 degrees is shows lesser range of motion as compared to individualized version for each and every patient. Now coming to the glenoids, glenoid offset, anterior glenoid offset results in better tensioning of the posterior rotator cuff, as a result of which there is better external rotation. And if we go for the posterior offset, then there is a better fitting of the glenoid-based glenoid tray. And inferior glenoid offset is very well known. 2.5 mm of inferiorization of the glenoid is as good as 4 mm of lateralization. And if the glenoid is inferiorized for more than 3.5 mm, then it reduces significantly the chances of notching. These are the few, in addition to, I'll have to cut short. So lateralization of a glenoid improves deltoid wrapping. There is a lesser chances of scapular notching, but there are increased shear forces which results in the chances of increased loosening. So when do we lateralize? There's this paper in shoulder and elbow surgery which shows that if your preoperative neck length is less than 9 mm, then you should go in for lateralization of the glenoid component. So it can be lateralized by the base plate, glenosphere, or bone augment. I'll just run through these because I'm already out of time. So this is the glenoid grafting, and these are the pre-op, immediate post-op, and the CT showing complete graft uptake. But the drawbacks are basically because of the lateralization, there is increased shear forces resulting in loosening, and there is an increased stress over the deltoid origin resulting in stress fractures of acromion and scapular spine. And now the glenoid inclination, we should go for RSA angle instead of the beta angle, and advantages of inferior glenoid inclination are better stability, lower shear forces, increase in joint compressive forces, and lower incidence of scapular notching. Version I'll skip because it's just -15. Glenosphere size, there's a very good paper by Asia Pacific Association which shows that the size of the glenosphere actually is not dependent upon the height or weight of the patient, it is more dependent upon the sex of the patient, and they have recommended that, they have shown that 38 to 40 mm glenosphere size in females has lesser chances of dislocation, and more than 40 mm in males have a lesser chances of dislocation. Sir, I'll directly come to the protocol which we are following at our institute. We inferiorize our glenoids by 3 mm, and then regarding the decision of medialization or lateralization. So if there is a pseudo-paralysis, then we go in for medialization, and if pseudo-paralysis is not there but critical shoulder angle is less than 32 degree, we go for medialization. And for lateralization, our parameters are if there is no pseudo-paralysis but critical shoulder angle is more than 32 degree, we go for lateralized humerus. If critical shoulder angle is less than 32 degree or acromion GT angle is less than 35 degree or humeral lateralization is more than 1.5 centimeters, then we again go for lateralized humerus, maybe with eccentric tray. And in
so Ambrose, you'll have to now.
Yeah. And these three conditions will like to lateralize the glenoid instead of humerus. I'm really sorry I overshot, and these are the final takeaways. I'll rest my case and I'm open to any queries from audience side.
Again, we can possibly catch up with any further questions at tea time, but nevertheless, it's been a very lucid presentation, extensively covered. And thank you so much, Ambrose. We now request the next speaker.
Thank you, sir.
He deserves a big round of applause. Pre-op planning with blueprint software. Now that's something new, interesting. For that, we have Dr. Inderdeep Singh.
Here in the post-lunch session and learning all the aspects of shoulder arthroplasty. So when we know and we are chasing the numbers, particularly in like world of robotics in knee arthroplasty or hip arthroplasty, we already have so many software which have come in to get the numbers right. So there's a software called Blueprint it's for the Tornier Perform, which helps us in planning of the surgery. So as we know, planning is very important. Connected नहीं है वो ऊपर लगाओ चलो वो रखा है चलो perfect.
नहीं आ रहा ना नहीं इसमें नहीं आ रहा
So sorry for the technical glitch again. इसमें एडवांस में जाना है. मिरर करना होगा इधर भी आना चाहिए ना yes
we can have the next speaker in the meanwhile if he's ready. Dr. Dilban Pandher.
HDMI.
Yeah, we can have the next speaker, Dr. Pandher. He will be speaking on successful execution of reverse shoulder arthroplasty.
If you can just give it in a pen drive if it's not.
It's on keynote. कर लो. Okay. So we go back to the pre-operative planning in a reverse shoulder. So this blueprint is a software, and you can use it on any of your laptops. It's an online system. So it's basically a surgeon-controlled 3D planning while you are doing a reverse shoulder or a total shoulder. It's a real-time 3D visualization. You can see your implants, how they are being seated on the glenoid and the humeral side. And in the end, you can also see the movement, the glenohumeral movement. The only problem here is the soft tissues are not taken into the consideration. It's only the bone which we are planning on. So it is designed for all the cases. Even if there's a glenoid defect or there's a deficiency in a glenoid B2, A1, whatever kind of glenoid, and it is reducible, and it can be also used for your revision scenarios as well. So it's important to learn how to use this. The important thing here is when you need a preoperative CT scan, and the CT scan needs to be done in a standard protocol, which has been, you get a handout of it and you can give it to your technicians to do it for a particular machine. So for GE machine, it will be like in some different way, and they need to follow all these protocols so that you get the image right. So I'll directly go on to the planning of a case. So this 76-year-old female, she's a right-hand dominant. She had a pain and restriction of movements of her right shoulder from past 15 years. And she was treated conservatively all over these 15 years with some injections, medicines, and there was no relief to all these conservative measures. So there was difficulty in grooming and doing clothes, overhead activities, and she doesn't have any comorbid conditions. So these were her x-rays, and we can see there were huge osteophytes on the humeral side. The glenoid looked to be eroded, and this was the cause of her pain, and she was still on a conservative treatment. So when we did her CT, there was a lot of glenoid erosion. So it is important from here to know that how much medialized or how much lateralized we have to be so that our implants are at right position and she gets a good outcome. These were the coronal images of the CT scan, and a 3D reconstruction showed a large amount of osteophytes, and there was erosion on the glenoid anteriorly. And MRI again relieved there was some cuff tissue. It was attached to the humeral head, but it was non-functional. So considering her age, so we planned to do a reverse shoulder. So it's doing a planning in a blueprint is like doing a surgery before a surgery, so that you have some image in your mind, so that you place your components correctly to increase the longevity of the implant. So I'll go on to the video. So this comes like this. You log on into it, you upload the case in a DICOM images, and this is loaded here. So you have three columns here: glenoid, humerus, and the joint. You can plan your glenoid here. You can look at, you can choose the size of the glenoid. You can choose the offset of the glenoid, and you have various options here. So to start with, whether you want to do a reverse or a total, you can choose an option here. And the kind of implant you want to use. It's not an open system, it is a closed system, so you can use only tornier implants here. And you have different options for the base plate, central screw, and the glenosphere. So once you look here, you can turn around and look at the glenoid face and face here, and on the axial cuts here, look for the version and the seating of the glenoid base plate. So if you see here, it's like around 40%. The blue means you have a good contact of the base plate to the bone. So around 70%, 65 to 70% means you have a good contact. And you can also check the tilt of the implant. You can change the size. Once you change the size, you get a good contact here. And I have chosen an offset of 6 mm because it was very medialized kind or a medially eroded glenoid. And then I can change the tilt, move it medial, lateral to adjust the best fitting of the glenoid. So this gives me an idea where I'm going to do intraoperatively. Same on the humeral side, you can take out all the osteophytes in this planning software, and then you can place your humeral stem into it. You can choose different kind of length of the stem, the short stem or the long stem. They don't have a trauma stem as of now, but it will come in some time, maybe this end of this year. And then you choose the positioning of your humeral component. So once you are done with this, you look at the joint mobility, so to check for any impingement. So it will also show whether your components are properly placed or not, and how is the impingement of the components to the bone. So in case there is some impingement, there will be some red mark over here, and this will give us the entire range of movement you will get post-operatively. So these were the intra-op images of the patient. So we chose the implants as per the planning in the software. These are the post-op CT. So we can see there was a good around 6 mm of offset which was done, and the screw were in the bone, and the length of the screws were also dictated by the CT scan with the pre-op planning, whatever we did on the software. The post-op movements were really good, and she was very happy to do all her activities and all the activities of daily living. So this software did definitely increase the efficiency and improve the ease of creating the same numbers. Whatever we are looking at, whatever we have planned for, we can do everything intraoperatively and execute it nicely. There are many papers which have told us about the same thing, that pre-operatively and the intra-op planning, it definitely helps to give a good results. So however, at 1 year the results remain the same, and it doesn't predict the movement at 1 year. There's a missing link here between planning and the execution, so which needs to be done. But again, always plan your surgery well, because if you are failing to plan, you are planning to fail. So there is some learning curve to it, but it definitely aids in proper execution and planning, and again giving us the good results of a reverse shoulder. Thank you.
I'm sure this must be extremely intriguing for the audience. Any questions from the audience? There would be a few burning ones.
Not many.
But just today in the afternoon before the session started, me and Dr. Shubhang Agarwal were discussing about having used this software and about the availability. It is an eye-opener, I'm sure it is an eye-opener. And in times to come, this will probably revolutionize the reverse shoulder arthroplasty.
Yes, it's like the knee and the hip arthroplasty, like we have learned over the years. So same for the shoulder now.
Thank you so much. Thank you so much. It's been a very informative talk, and he deserves a big round of applause. For the last speaker for this particular session is Dr. Pandey. Since Dr. Manit Arora is not available for the last talk, Dr. Pandey will wrap it up with you, and thereafter we go live to the theatre. Successful execution of reverse shoulder arthroplasty is his topic.
So good evening. It's an honor to be here for the Iaa-Nhs surgery workshop. I'll be discussing the successful execution of reverse shoulder. By now, most of the things have been covered, but I'll still stress upon that it starts with patient selection and preoperative planning, to operating room setup, and goes on till we have the instability check. Glenoid is the basic workhorse of reverse shoulder, so optimal fixation will give you optimal survival, and optimal positioning will give you the optimal function. Indications we have already discussed. Deltoid palsy used to be an absolute contraindication, but recently there are reports where the pectoralis pedicle has been transferred to compensate for the deltoid deficiency. So it's no more an absolute contraindication. You can still offer a reverse shoulder if you know that you can transfer the pectoralis. So today a new contraindication has added, that is lack of adequate skill and sole dependence upon the company personnel. So many times they'll come and tell you, okay, it is simpler than fellows, doctor, you can do it, just don't do it. Learn it, master it, then only do it, because if you mess up, it is a disaster. Preoperative assessment, like Idea has covered a lot about the role of planning, but basic thing is you must know the classifications, because if you know all these erosions and classifications, you will make it out on the X-ray itself that something is wrong, this glenoid is not looking good. So we want to get a central screw in the best purchase in the glenoid, and it is not similar for both these cases. And once we rotate the glenoid a little bit, you know that you have to take off lots of bone from the anterior aspect to get your central screw in position. So for all this planning, you simply need the CT scan. Again, for part 3, if you don't have the CT and you don't know your glenoid is looking up, you might put your glenosphere in a wrong position and that will fail very early because of the excessive rocking. Similarly, for the erosions and for this kind of glenoid bone loss, if you have the CT and you have planned your case well, it will definitely be like very comfortable inside the operating room. CT again has a role in this patient-specific instrumentation that will help us achieve this, but now this has been very elaborately explained. We have this platform, and it is not only with Stryker, it is with Smith & Nephew, and other companies are also giving you similar softwares. And the good thing about this is that you don't need to buy anything. It is an online platform. You just register for this, they'll give you your ID and you can upload your CT and play with it. Even if you do not intend to use it for their case or for that specific case, you can do your planning. Patient positioning, like recently I saw a surgeon in Japan who operates the patient lying supine on the table, but we are trained to operate with the arm hanging out, and this is very useful if you tell your patients or if you have this kind of a video that you can share with your OT staff and guide them that, okay, I want my patient to be positioned like this. Because a slight mess up in patient positioning will give you lots of struggle inside the OT. Deltopectoral approach and the anterolateral approach both have their own advantages and disadvantages. The biggest concern about deltopectoral is the glenoid exposure is comparatively tough, but with anterolateral approach we have risk to damage the anterior deltoid, and we can put the glenoid in a wrong position just because you are looking at the glenoid from top to bottom, which we are not used to. But it is helpful in acute trauma cases because your tuberosities are scattered around. So know your approaches, you should be versed with both and then decide what to do. Next is to place the retractors. So little bit of anatomy is important. You can place your first spike over the coracoid process. It is far away from the suprascapular nerve and it is safe, and clavicle is there, which has been removed in this video. Similarly, you should be aware that axillary nerve is sitting around 5 centimeters from the angle of acromion. So be aware of all these nerves, and you should know where to place your retractors that you don't have an unexpected nerve palsy. Brachial plexus is sitting right under the conjoint tendon. So if you have an assistant, just make sure that every time the retractor is out, you place it rather than he pushing it under the conjoint tendon. That way you'll displace it. Preparation of humerus and glenoid, just be very clear with the steps. I'll not go into the details. Level of osteotomy is important, version and removal of osteophytes. So osteotomy, we generally do it at the junction of cartilage with the greater tuberosity. Use the guides, keep the cut minimal. You can always recut. We don't want to like augment the humerus just because we have cut extra. Proximally migrated humerus head, you have to be careful. Partial osteotomy of the head can be done in case of difficult dislocations. Version is variable, patient specific, demands and native version to be considered. Try to measure the natural version. So now, as has been discussed previously by speakers, that it is not always 20 degrees of retroversion. So if you put it neutral, just know that you will have more of external rotation if you put it in retroversion, but you have to see the patient and look at the demands, whether the patient wants more of internal rotation or external rotation. Similarly, you can play with the version of the humerus and you can have a happy patient by just changing the version a little bit. And the posture of the patient again affects the position of the scapula and the glenoid. So if the patient is stooping, or if the patient has kyphosis, and if the scapula is like displaced anterior medially, there is lots of change in the like overall anatomical location of the scapula. You must be aware of this and adjust your versions accordingly to get the best function in that given scenario. The removal of osteophytes is important because you get better exposure. Glenoid preparation, we all know that from anatomical to reverse, we have to change the angle and tilt it a little bit. Place your retractors well. This has been demonstrated in surgery, so I'll rush through it. If the head is migrating high, you have to release the long head of triceps, but use a blade because axillary nerve is sitting very close to it. So avoid cautery and prefer a number 15 blade close to the glenoid, and you can release the long head if you want to. Similarly, the posterior releases can be done if the shoulder is tight, because this is what we frequently struggle with. The shoulder is tight and we are just pulling it around, struggling to reduce it, struggling to push the humerus away. So you can put your scissors parallel to the glenoid, and it is far away from the quadrilateral space. So you are safe from the neurovascular planes if you keep your scissors parallel to the glenoid. 50%, the smiley face has been discussed well in the surgery, so I'll skip it. Just place your guide accordingly, palpate the anterior and the posterior margin, because we know the glenoid can be retroverted, anyverted, and you can probe it, or even you can take out the retractors and put your finger around to actually conceptualize where your glenoid is sitting. Optimal fixation, the central screw should have maximum length, minimal reaming to obtain the matching surface. So we don't ream like acetabulum that we have to expose the whole glenoid. Minimal reaming is done. Up to 50% of the seating is something that is required. We aim for 70% at least. Don't do it less than 50% of seating on the glenoid. No superior tilt should be there, because the moment you have a straight or a superiorly tilted glenoid, there is lots of rocking and it will result in loosening. Version does not matter. As far as the glenoid is concerned, there is lots of literature that you can put it in less than or more than 50 degrees of version. Up to 25 degrees of version, it does not matter. Screws, you should again be aware of the anatomy. The one going into the base of the coracoid is good, but posteriorly you are sitting too close to the suprascapular nerve, so be careful when you put your drill over there. Last two things, the optimal positioning. So we have already discussed this. We have to lateralize it, we have to tilt it inferiorly, we have to get it flush with the inferior rim, or even if it is slightly overhanging on the inferior rim, it does not matter as long as you can get good purchase of your screws. And for this, we have all these options in the glenoid now. We have half or full wedges available, where you can use the simple glenoid, single glenoid base plate, and give it all the tilt and everything that is required. Version I have already discussed. I'll rush through this because there is not much difference. There is not much difference if we use the center line or the alternative group. Just be careful that anti-version versus the conjoint tendon impingement adapt to the version of the humerus. Optimal positioning for larger patients. This question was asked today. So larger patients, we have larger glenospheres and we lateralize it more. For intact cuff, we restore the anatomy and distalize it less. For cuff arthropathy, we have to distalize it more. So we use the greater angle. The neck shaft angle has to be slightly greater when we are doing it for the cuff arthropathy, and restore the anatomical pre-morbid position of the glenoid. And finally, you have to check the stability on table. We have all these again options in the inserts where we can increase the constraint whenever we come across the instability. So if the scapula moves with abduction, it is tight. Shuck test 2 to 3 mm is good. Over tensioning can cause periprosthetic fractures, axillary nerve neuropathy, even fracture of the acromion. Check for the conjoint tendon that was demonstrated in the surgery. And nurse's maneuver is something like you try to lift the arm as nurses move the patient in bed. And if it is stable there, your reverse is stable. Thank you.
I guess he's not left any doubts or any questions. You covered it up so well, so fast, and such elementary manner. You've covered such a complicated subject. Hats off to you. So very, very, very nicely presented. So are there any questions? I don't think so. Anybody would have any questions? Sir, Dr. Shubhang?
No questions.
Thank you, sir.
Thank you.
Thank you very much for a lucid presentation. We now take leave. We now go live in the operation theatre, where we'll be seeing a robotic total hip replacement. Thank you.
Yes. And we apologize. We will be giving a formal token of regard to the moderators a little later after this thing, because they are ready with the surgery in the OT. So OT, can you hear us, and can you shift the signal there, please?
Now we are going to begin with our second live robotic hip surgery. It is my pleasure to introduce our operating surgeon for today's live case, Dr. Rakesh Rajput from Kolkata, who will share his practical tips and decision-making strategies. With that, let us now proceed live to the operating room. I would request the moderators for the next session, Dr. Ashok PS, Dr. Ravi Gupta, Dr. Sandeep Gupta, Dr. Sanjeev Gupta, Dr. L. Tomar, and Dr. Narendra Parmar, to please come and take their place on the dais and moderate the live surgery.
On it? Hello?
Yes, we can hear you.
Yeah, Dr. Narendra.
Yes, Dr. Narendra.
Yeah, I will explain. Yeah. 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 These male 45-year patients, bilateral avian hip, moderately built, large size head. On templating, we have just measured the acetabular size. It is between 54 and 56, and stem size is around 2 or 3. This one is full length X-ray. Okay. Yeah. And this one is a spinopelvic mobility. That lateral sitting and lateral standing X-ray. Okay. Today, this surgery we are going to do on Cori robotic hip. And now I will demonstrate that how spinopelvic mechanism will help us in that. Now kindly focus on the screen. Now I will just do the planning. Yeah. Yeah, okay. The screen is visible. Dr. Sanjeev, can you hear me?
Yeah, we can hear you, sir.
Okay, now I am measuring the sacral slope. And this is pelvic tilt measuring, midpoint between the pubic symphysis and ASISs. Yes.
So for the benefit of the audience, this is a RI hip modeler software from Smith & Nephew. So before doing the robotic hip, you can take x-rays of the pelvis sitting lateral and standing lateral. And LS spine, just for, like he said, for spinopelvic. And then he's explaining the points where you mark it on the x-ray. The x-ray is taken by a simple photograph on the iPad from the screen. And then it does not need to be digitized or anything. It automatically picks up and converts it into this.
Okay. Okay. Just now save the screen and move forward. Okay. Okay. Now see the preoperative planning. We have selected the R3 3-hole cup, liner option, is lip posterior, is I think 52, 54 cup, so ball size is 36. Neck length we have chosen at present 0, and stem is polar standard. Okay. Okay. We focus on the APP. Now this will show the cup inclination, anteversion and stem. If suppose we keep the cup inclination is 40, anteversion is 30 and stem. So there is little bit impingement of implant in forward bending is there. Suppose we just change the lip liner from posterior to neutral. Then everything come within the range. So there is no impingement between implant and anything. Okay. Suppose we want to compare anything between this, then okay. Blue one is that lip liner is posterior 20 degree lip. Okay. So there is no need of posterior lip liner. Either you put it anteriorly or it is put, either you use neutral liner. Okay. Otherwise you can also compare with, Kalpesh? Yeah. This modular dual mobility. Yeah, 30. See, whether with normal implant and with dual mobility, the graph shows the same range of movement, both inside the circle. So there is no need of any costly implant. We can go standardized hip with normal implant. Okay. So this one is our. Now I will show the inclination and version. Suppose we increase the version, then what will happen? Okay. See. Suppose we are increasing the version, there is more chances of impingement. Okay. So here selected and sir, are you going to use for a posterior lip liner or no? Neutral?
No, neutral, yes.
Neutral. Neutral or anterior?
I think we can use 36 head.
Okay.
Exactly, this is above 50.
Okay.
And zero neck, because this is already slightly longer.
Okay.
We are going to be either minus or zero.
Okay.
If we're going to use ceramic, then we can't go minus, but with auxinium we can.
Okay, doctor.
So we can end up putting our auxinium in this.
Okay, Dr. Rajput's plan is cup inclination is around 35 to 40 between. Antiversion is around 20 to 22. And stem antiversion is fixed, almost 15. And sir is going to use neutral liner and neck length is 0. Here true shortening is approximately 0.6 to 0.8 mm is there. Okay. Now go ahead with the live surgery.
Sir, before we go to live surgery, may I, with the permission of the moderators, can you show, in the previous screen?
Okay, can we come to this screen now?
Yeah, quickly just show this pink thing.
Now focus on the pin placement. Yeah.
Yes.
Is it Ashok?
Okay, we'll discuss that later.
Ashok and Dr. Sanjeev is there.
No, Dr. Ashok has not yet reached.
Yeah, Dr. Sanjeev is there.
Dr. Sanjeev is there, Dr. Ravi Gupta is there, Dr.
Ravi
Tomar
is
is there, Dr. Sandeep is there.
One more person I'm not able to recognize from here.
Yeah.
So anyway, I will carry on. So
Can we increase your volume, sir? You're not audible, it's muffled.
Okay,
That's all.
yeah.
No, no.
You just ask your question here.
Dr. Rajput's mic volume can be increased.
Okay, okay.
Dr. Rajput, for the sake of the audience, can you just delineate the numerical values of the standing pelvic tilt, sitting pelvic tilt, the delta P from standing to sitting?
Sir, Dr. Rajput, I think the mic needs to be put closer to the mouth. Just थोड़ा सा उसको मोड़ना पड़ेगा.
Okay, okay, just give me.
bring it inside the. Hello, can you hear me now, Shubham?
Still the volume, was IT team in the OT.
Yeah.
One mic, Dr. Narendra's mic is audible, Dr. Rajput's mic is not audible.
Hello, Shubham, ये sabotage किया है वो.
हाँ, ये नरेंद्र ने किया है.
Yes, yes. Right. You can ask the question. I will just pass on to Dr. Rajput.
I think we should patients are under anesthesia.
Yeah.
Now.
Okay.
So Shubham, I'll just show the markers if camera can focus here now.
Yeah,
so
here.
length wise, we are actually slightly longer than the other side, but I think that was tilt also. So, and there is some collapse of the head. So there will be natural lengthening of about 5 mm, and I'm going to accept that. We're not going to lengthen any more than 5 to 6 mm. But we'll see. Whatever lengthening happens is natural. I'm not going to lengthen this leg.
Doctor.
And the other side, when we do, we are going to equalize to this side.
Dr. Rajput's plan is that here going to use 0, maximum 0 or plus 4. Yeah, it's 0.6 to 0.0 mm shortening is there on affected side.
First tracker here on just around the knee. So when you put this tracker, you got to make sure that the knee is still able to bend and it is visible to the screen. So this is a pinless tracker. Now we're going to put 2 trackers on the iliac crest. So pin, please. So first pin can go freehand.
Between the two table of the
iliac crest, about 2 finger breadth
behind the
antispheric spine.
Yeah. Dr. Rajput is pelvic surgeon. For him it is very easy. For normal hip surgeon is also easy. You can just palpate and put it.
Okay, so
yeah.
So the next one can go through the jig.
Can we swap the 2 images? PIP को robotic कर दो और main screen पे please can you take the pin? We can't see. There is the assistant's shoulder is coming in the way.
Yeah.
Yes.
Assistant,
now
please.
it's better. Yeah.
Yeah,
so can you please explain quickly once again where did you put the pins?
Yeah, they put the pin just 2 finger breadth behind the anterior superior iliac spine and second pin with the help of the jig. Okay? Okay.
So you need couple of markers here. So one was putting for the pin and these two. The next marker will be on the GT. And before we start the OT, we've got one marker on the L5 spinous process in the midline. So it's very important to be in the midline, right? So you shouldn't err on one of the lateral sides. You can err, instead of L5, you can be on L4, you can be on S1, but don't err on sides. That's very critical.
Marker should be pinned in the line.
Somewhere
there should
in the
be
midline.
no mediolateral movement should be there. That is not acceptable. That will give error in your readings and everything. Okay. Better way is always ask your anesthetic. When they give the spinal, they can put the marker properly at L5 or L4, whichever the point is there.
Sir, was a CM used to check the marker before the positioning?
Yeah, no, there is no need of CM. Usually anesthetic will guide us, and they will just give, after giving the spinal, they can just put that marker over L5 is there.
In this case, was the CM used?
No, CM was not used.
But the electrode sticker was used, two of them.
Yeah, electrode sticker was used. That ECG lead marker that we use.
Yes.
Dr. Rajput, what is that anterior stab incision you have given for?
That is for proper marking of that ASI. Sometimes the patient is little bit fatty and obese, so it is very difficult to palpate the ASIs. So this system will work on triangulation system between two ASIs and L5, and that following the interfossa distance. So suppose your ASIs will move little bit here or there, then your reading will come and some error will come in the last next stage. So it is always better just put the step incision over ASIs and properly palpate it and then fill it. Before going for surgery, you just make sure that this point and during surgery, same point will be there. So here in system we are putting the that will show you within few minutes that between ASIs distance, between two ASIs distance.
Camera needs to go up from up.
Kalpesh, just show the ASIs. Now Kalpesh will show the screen. Yeah, just focus on that screen. Yeah, PIP. Okay. Now make that screen big little bit. That PIP.
Kalpesh,
yeah.
Get the camera this side.
Okay. Now show the workflow. Patient orientation, that is lateral position.
Okay.
Okay. Next.
Can they see the camera?
Distance between two ASI is around 232. Yeah. Pelvic tilt is around 6 to 7 degree.
Can we increase the AC, please? This is getting warm.
Okay.
We reduce the AC, please.
Yeah. Okay. Now screen show the ASIs and pelvic marker. Okay.
Right. So you can see all the markers down here.
All the
marker
that
marker.
Dr. Rajput had apply all the markers is there. Pelvis. Okay.
Right. So just
now look at the screen.
So there is one marker here on the GT.
Yeah.
Right. So that will be used for the leg length.
Okay.
So we'll try and start now. It's very nice to hear this voice. This is a bit of trickiness in this.
Humming sound. That humming sound you should. Okay. Now Dr. Rajput is palpating that ASIS point, registering that ASIS point. Yeah, ASI is done. Now L5. Take deep breath and be calm while registering L5 point. This is the most important point. Okay.
Okay. So now
registering
you need to
GT
get the
point.
leg length. It's very nice to know where you start off. So this leg is straight, knee is bent 90, and there's no rotation. So if you can just hold here.
Yeah,
and
focus that on
the leg length. Pointer, please.
Cameraman. Yeah. Change. Yeah.
So we are going to give the.
Okay.
Right. So that is got its leg length now. Now we need to. So we approach till the hip. We are going to dislocate it now. So Homan, please.
The point on the greater trochanter was.
So we are going anterolateral approach. So remember, there is little bit of version change, little bit of inclination changes based on your approaches. But here I think we are going to change the version a little bit. So we don't be too anti-version. So if you're going to like aim for 40 combined anti-version, you would aim for 30 here. Right, so one more.
Here Dr. Rajput has planned combined NT version is approximately 30 to 35, between 30 to 35.
Okay, so can we rotate this now? So go in.
And GT register point should be at the junction of neck and shaft, and highest point of the greater trochanter, just below the flange and in center. Okay.
Okay, diathermy please. So just fire me any questions you have, I'm happy to answer, or even Narendra can help you.
Yeah.
So, Rakesh, are you going through the Harding's approach?
Yeah, it's a modified Harding's.
Yeah, it's modified Harding's approach.
Okay.
So you saw from the templates, I think, I don't know whether
we had done the
Narendra
templating and everything. Yeah. Now Dr. Rajput is cutting the neck. Okay.
Narendra, can
Have
you
you
show them
measured the cut, or you just roughly cut it?
No, we had measured from the template also, but here we don't have a chance to measure actually in millimeters. So if you just show the lateral view of the hip joint, it's very important for this one. So Dr. Ravi, if you just have a look at the lateral view of the hip joint, or lamba view right now. So this is very important to have, let's just hold this. So if you just look at the lateral view, can we focus with the camera on the actual? So the lateral view, and very well taken lateral view, so it actually tells you where your entry, when you're going to make the entry.
The camera is,
So very important to know that you want to be in the middle, you want to be slightly anterior, you want to be slightly posterior. And this changes. But you need to have a good lateral view for this.
Yeah,
so if you see here, even if you start in the middle, you're okay. You don't want to be starting posterior.
Okay.
That's the only thing from this X-ray you can make out. So please.
In AP view, canal look like snow type A. But true lateral view show the canal is actually bigger one than AP view.
Okay, I think we can have a look at the head, and you can make out that this head is, I think there's nothing left.
Camera.
We normally do template from the head so that get an idea about the acetabulum, but this is, I think, it's got plenty of osteophytes, so we'll still try and do this.
Yeah, just measure the size of the head.
Measure the size.
Yeah,
Dr. Rajput, you can see in the OT what he is showing us.
Can the camera go onto the hands of Rakesh?
Bring it here.
Can the camera show us?
Yes.
So basically you're going to go...
And the assistant in front of you is blocking the camera view. So
55 is going through. This is 53. Just getting stuck. 51, where is 51? 51 is here. So 51 is not going through, so it's more likely to be 52. So if it wasn't arthritic, you would think that maybe 54 would be a cup size, but this is arthritic, so you're looking at 52 to 54 cup size. So this gives you a rough idea, and even in our templating it was 52. So we know that if I'm heading towards 56, I'm going on the larger side.
See, our templating size is also showing 52. So better pre-operative planning, that definitely help you, then reduce your OR room stress also. Okay?
But I would like to know, like, why are we so bothered when we have the robot and the precision chances are much higher?
Okay, so
why do we need to fix that?
Or shall I take it? So the reason you are bothered is your technology will occasionally fail you. Your clinical guide and your technology should match to each other. If they are not, then your apprehensions will start. So even if you have technology, you should be always hands-on. You know, your pin can get loose, your things can go wrong. This is technology. Glitches can happen. But your clinical skills which you have developed over the years should still be put to use.
I will answer this question in another way. This is basically image-less system is there. So slightly error will be there, little bit sizing is there. And when we are doing acetabular sizing, it will measure with articular cartilage. So actual acetabulum will show little bit smaller size. So it is better to template it and on table measure it. So you will know the exact size of the acetabulum, and you can plan exactly what to put on modeler. Whether you want to put 52 acetabular cup or 50. If you will put 50, then head size will be 32, and 52, then head size will be 36. So your NT version, inclination, neck length, everything will be changed according to your stability and that wise. So it is always double check on the system and our clinical assessments.
So we go femur first. You want to know exactly, because you can't really change much in femur. So you want to be sure.
Can we request the assistant on the front side toward the foot, because his head is coming time and again in between. Yeah.
You can't chop off his head, but we'll try and.
Junior, those who are not using the system and those who are very much not trained for the system, always femur first will help you. Average femur anti-version in male is between 14 to 16 and for female is around 15 to 16. So you can't change your version in case of femur. So for a combined version, acetabulum is the only option where you can play. Whether you want to put little bit more anti-version, more inclination, whatever you want to put, that you can change. So ideally, femur first. As Dr. Pachore is always saying that doing femur will give you a lot of freedom to you. Wherever you want to put your acetabulum, you can put it.
So Rakesh, when you are doing without robot, you are again doing through the anterior approach?
Through what?
The anterolateral approach?
Yeah, that's my go-to approach unless I have to go posterior for some reason. I'm okay with all approaches actually. I've done even direct anteriors. But this is my go-to approach for majority of patients.
Okay.
The advantage of this system is those surgeons who are not familiar with the direct anterior approach, this system will give you definitely guide and protection. So your hip implant is not going to impinge your, not chances of getting dislocated, leg length, everything. So routine approach, the direct anterior or direct anterolateral or posterior, you can go same result for just like direct anterior.
What size of broch you are already in?
Yeah, so I think there's a bit of struggle because I don't want to lengthen it. So with 2, I might end up slightly overshooting. Just give me back 1.
Our templating size is showing between 2 and 3.
No, we are going to go lower size actually. So this is an issue I think we debate a lot these days about the AP diameter not matching to the lateromedial diameter.
Oh yes.
So we may have to go back. This is कितना दिया? अरे यार 1 चाहिए बोला आपको.
Would you like to ream, sir, little bit?
I'll check.
So was it size 2 or 3?
No, we are going back to 1.
Okay.
Shubham, the issue here is we don't want to lengthen him. Just the natural lengthening which comes. Otherwise, yeah. So that's gripping quite well actually, and I'm
but this
absolutely flush.
But it's a bilateral avian, and you are luckily doing the first hip.
So you don't want to be unnecessarily lengthening
yes,
here
that's true.
and then lengthening too much on the other side. So one good thing about this stem for elderly population is this. It's got a female taper. You see there's nothing attached to this. So if you want to leave inside the canal, it helps you 2 things. 1, for an osteoporotic bone when you are doing twisting and turning during acetabulum, this won't break. The femur won't break. Number 2, it stops bleeding also. So we'll carry on now. So I think from where the femoral anteversion, this is not even 15, this is closer to 10. So less than 15 anteversion we already have on
femur anteversion is average is between 14 to 16. Okay. So here maybe it between.
So you are final with stem 1, right?
Yeah, most likely we'll be going to 1. Yeah.
Okay.
So let me know if you guys need to see better because normally I don't use the Charlie.
Can you tell the placement of the spikes, please?
I will in a minute. Do you have strong acetabulum के लिए क्या लेते हो आप यहाँ? ये वाला? इसमें तो जोर ही नहीं है यार. इसमें जोर नहीं है.
We take the 90-degree spike. Yeah.
अच्छा ठीक.
So this is inferior to the transverse ligament, right?
Yeah, it is right, but then this is not really nice. Do we have something straighter so that we can pull the...
Dr. Rajput, are you doing minimal invasive or this smaller one incision or is standard incision?
About 12 centimeter incision.
Yeah, it is 12 centimeter.
Yeah, this is like...
What is panel's opinion regarding incision? Small size matter or a comfortable incision is always better?
If you can take this. आप यहाँ आ जाओगे तो instrument कौन देगा? So I'm going to cut some soft tissues. So can we have a bigger diathermy now? And a forceps. So is this visible? आप वहाँ से दिखा पा रहे हो?
No, it is not visible deep. It's only
So
visible
can the
from
camera
side.
come from your shoulder?
Overhead.
It needs to come. This
Overhead.
camera needs to show.
Camera should come
If you can just
From
show
above
this
his
angle.
shoulder, yeah.
Shubham, I can't make out.
Yeah.
Are you able to see?
Yeah, it's much better
If you
now.
can zoom in a bit. Just show the wound. You don't need to show any of us.
Yeah, zoom in more, yes.
Zoom in. So I'll just take away a few soft tissues. I think you'll see better. Okay, there's a bit of struggle with the retractors I have here, but anyway, we'll manage.
Okay. Is it visible, Dr. Shubha?
I'll just give you a bit more. I'll get my retractors in a bit.
Shoulder से focus करो camera.
Knife, please. So try and take away as much labrum as possible. You get a good idea about what your acetabulum is like, and also, but some of it comes out when you're reaming.
Can you do a saline wash so that we will be able to see better?
Just give me 1 sec. Let me just cut out whatever I have to first. I think this is the time for wash. You're right. Okay, nibbler, please. आपके पास लॉन्ग हैंडल है? Okay, wash the neck. But is this on?
Maybe okay for him, but for us,
Okay. Mop. Okay, I think you might be seeing a bit better now. Just hold this.
Yes, now it is better.
Right. So one question was where we put our retractors, right? So
Yeah.
once you can see here, like this is superolateral, posterior superior. One is anterosuperior, and one is actually in the acetabulum. But this is not the retractor normally I use, because this is not really pushing the femur away a lot, so I may have to keep doing without this from time to time. Okay, आप ऐसे रखो.
So can the camera go up a little more towards the shoulder and then look down? It's looking oblique, so we are not able to see the inferior part. Antero-inferior we can't see.
Just pull the leg a bit. Pull the leg. Pull.
Rakesh,
So take away a little bit of capsule from the inferior side.
for the sake of this demonstration, do you mind you slightly increase the incision so that the femur can be mobilized better?
It won't really, the incision won't give you any more exposure.
No, sir, the visualization, I think it will be.
I don't think even visualize, because this is where the soft tissues are.
Okay.
So even if I incise, I'm sorry, this won't give you any more. Let me just see if I can use a better retractors here.
The cameraman shows, needs to show the hip. We can't see the acetabulum.
We can't see the acetabulum actually.
Okay, just give me 1 minute. We are
IT
focusing. Yeah.
IT team, can you readjust the camera position?
So, can the cameraman go above the left shoulder of Rakesh?
Yes. Now, yes.
Okay. So next is to again have a, this is, can we put the pelvis X-ray back?
Better, much better.
Yes.
So this is when you
now it is okay.
Preparation.
Yeah, this is better.
Yeah, okay. Now just focus on this X-ray. Yeah.
Right.
Okay.
So what you have to look at is, do you have a fovea or not? If you don't have, this system can give you a bit of error because it has to calculate the outer cartilage fossa and an inner fovea. If you don't have, you need to make a small fovea first. So can I have the gauge please?
This system we
Not gauge,
can't use
gauge.
in case of
Hammer.
CDH, protrusio.
Gauge. Gauge.
But this may be actually not really a protrusio if you see both the obturator foramen are
It's not
osteophytes have
protrusio.
covered the
It
fovea.
is not protrusio, it is normal.
Yeah. So it's flexed pelvis, so that's why.
So, what were you looking at the X-ray? Is it the protrusio which you are looking?
No, if there's a fovea visible or not. So
Okay.
if it's not, and you are confirming it here, that you are slightly away from the inner table.
Okay.
So that way you know that you have to create a fovea here now. And you can just see, gauge please back. So I can ask my assistants, can you see a fovea coming up now? Right, so you can even see the fat now.
So, is it by the fat pad you will see?
So fat pad is what you're looking at.
Yeah.
You see this? I've created a fovea here. Huh? So why you want to see fovea? Because this system doesn't tell you the actual depth you're going in. It will tell you this many millimeters you've gone, but after you've gone. So I think you need to have a fovea on which you're going to template your reamings. This will give me the inclination, this will give me the version, but the depth. So if you see here, we are slightly lateralized. So you want to be slightly medialized, so you might see that at the end we might be about 4 mm medialized once we finish. And that is what's going to tell me about the offset. So the combined offset, okay, can we have the, so we are going to give our markers now. So point
Preoperative on templating, there is our horizontal offset is around 6.4.
So I think you have to be very careful in doing this system here. You have to mark the whole anterior, which is sometimes difficult because your point, so you might end up about 4 mm short. So if you were aiming 52, you might think that you've got about 48. One, there's a cartilage, and number two, you may not be able to map the whole lot. So let's try this now.
Yeah, this system is measuring the articular cartilage. So actual acetabular size, this system show it will be little bit smaller than actual
Sound
size.
please. Kalpesh kahan gaya? Sound karo.
So, now your marker is inside the acetabulum, right?
Yes.
So, you will rotate it in the acetabulum to see the size of the cartilage.
Yes.
यहाँ से आके करो, यहाँ से करो, ये आप ले लो.
Now we'll, yes.
So, you will take different points in the acetabulum cavity.
Yeah,
and
around the ream from the anterior to posterior.
And then the final one with the fovea.
Yeah, final one is the cotyloid fossa.
So you will come to know the thickness of the cartilage, right?
Yes.
Okay.
Okay, let's see what readings comes up. So 53, I think this is given us because there's plenty of cartilage loss in this one, so it's given us very close to what the acetabulum should be. So
Yes, system show the 53 and our preoperative templating also shows around 53 to 54.
So maybe the cartilage is already worn out, right?
Yes, so that's why they give the system actual size.
So I'm just going to deepen the fovea which I had created.
Dr. Rajput, are you doing regular sequential reamer or only 3 reamers?
No, sequential. As I told you, this one.
So what size of reamer you are taking now?
is around
This
38.
is just getting to the depth.
Yeah, it's 38 reamer, smallest
I'll
one.
just show you how.
So that will be vertical kind of reamer,
Yes,
right?
yes. Little bit medialization. That
Okay.
routinely and standardly we are doing every time. Just medialization.
थोड़ा blunt है सभी ऐसे हैं या कोई sharp भी है नहीं as long as you tell me कि it's blunt.
It's 40, 41. You just give it 41.
If all of them are same, I'm okay. But suddenly कोई sharp मत दे देना. Okay, so we can go a bit longer now, a bit bigger now. So 45 के आसपास जाइए आप. या एक और बड़ा दे दो मेरे को.
So sometimes
ये
the
31
set reamers start
Give me
working after
41.
54.
Yeah, 41. We'll do one more depth and then we'll go up.
In Punjab,
Uske
usually
baad-
they will find the little bit bigger hip.
Oh, I love
So-
coming to Punjab.
Yeah.
Seriously, this is my
Dr.
fifth
Dr.
life
Rajput
surgery
is
in
working in Bengal.
46
so
is my
there
average.
He is 46 and between 46 and 48.
What about Gujarat, Navsari?
Gujarat is almost 80% cup we are using between 48 to 50.
Okay, now 45. And now you attach the.
So Rakesh,
Yeah.
when you are using posterior approach and this anterolateral approach, doing acetabulum in which approach it is easier?
I think they're both same. What you're used to is more important.
Okay.
So sometimes in this approach there is one issue, the femur can come in between. And so I actually keep offset reamers for overcoming that, but here we don't have. Otherwise it's not an issue. Or you can actually clear up more tissues just medial to the femur, slide femur out and do that.
For the sake of the audience, I am just telling, for demonstration purpose, it is always posterior approach is best one because your looks better visualization. So when you are seeing any surgical demonstration between anterior approach or anterolateral approach, don't think that this approach don't give you proper
Right.
exposure.
So I won't
Yeah.
look at the figures
Yeah.
now. So just why is this showing up?
Yes,
Okay.
this reamer is
Yeah.
showing the figure.
So I'll just tell you what I would normally have done. So if I wasn't using a robo, this is
Just-
my upper shoulder. Can you see this upper shoulder?
Yes, in the PIP we can see.
Yeah. So if you see the upper shoulder, for that your hand should be 90. So this is your upper shoulder. So I would be aiming for that to give me about between 10 to 15 degree anteversion. So that would be mine. And about this here would be the inclination I would be going. Now let's see with the robo what is it showing. So it's showing me 45. So which means I need to go down a bit. And instead of 10, I think so I need to antivert a bit more. So this is the finer tuning you can do with robos. But even with normal, you're only 5 degree off. So that's a good thing about anterior approach. You have a well-defined point to aim at. In posterior, you don't have a point. You just think that you have to antivert more and more. But there is no well-defined point unless you're aiming from some corner of the room. But here you have a shoulder and you aim at the shoulder and this invariably gives you that 10 degree or 12 degree antiversion.
So,
Okay, so if you see
can,
here,
can you tell again about the shoulder thing?
Yeah, so you have to see this here.
Please expand the
So if you
surgical
can zoom
field.
out and just show this reamer aiming at the shoulder.
Shoulder of the patient, right?
Yeah, shoulder, upper shoulder of the patient.
Okay.
For that, you have to position the patient very well, and we check that pre-op because the arm also has to be 90. If the
Please
arm is
change
down,
the
then shoulder
picture.
moves.
Please change the picture. The camera people change
Can
the
you
picture.
show this bit here?
Swap 1 and 2.
Yeah.
So this is something very good about the anterolateral
So
approach.
this is
They're
at the
actually
shoulder
aimed,
of the patient.
well-defined aim. So
Okay.
this is where I think we'll be reaming. So it's about, so if you just come out a bit, let me just, so I think I need to go down a bit. So this is 44, 42. So I need to come to about 42, if not even less.
Our preoperative planning is between 40, 38, 40.
So do you take any time indication from the transverse acetabular ligament?
I would, if I didn't have robo. Normally you have to trust your gadgets also to some extent.
Yeah.
And this is coinciding with my normal way also. So if your gadget and your normal alignment coincide, you know you're right on dot.
Okay.
There's no issues here. So let's go a bit over, 47. So you go on odd numbers, huh?
In routine posterior approach, we are very much afraid of the dislocation. So every time we are putting cup more and more antiverted. So our reamer is always towards the OR rooms doors, facing toward the OR room doors. that will give you
49.
more and more anti-version. So ideally it should be not, reamer should not facing toward the door of the OR room, but
maybe I'll give you a demonstration at the end why I choose this approach.
Yes.
So that is, unless you see it, you won't believe it. So again, so we are slowly getting down now where we want. So what 40 is what we are aiming for. Remember, what you see here is what you're seeing on the table. When you measure on the X-ray, you are quite likely to lose 5 degrees. So what 42 here would become 47. Generally, not always. So you got to show that you are well below 45.
For the sake of the audience, why is that so, Dr. Rajput?
That's just the way X-rays are taken. Yeah, 51. The study's been done about this.
The study has been already done regarding that on-table version and post-op X-ray version. There is no difference more than 2 degrees there. So the system showing the actual version and actual inclination.
How much is this?
What size of reamer you are using now?
So we are already, this is 51 going in. I'm already getting the grip.
But
So
it's all contained inside the acetabulum,
yeah,
right?
yeah, all contained, and you can, if this can focus, can you see the grip here? I'm getting the grip on the reamer. You see this?
Yeah, very good.
Yeah. So that's the grip you want to see. And you don't really need to go any higher. Okay? You see this?
Yes.
It's not moving. So that's what you want.
Dr. Rakesh, do you ever use Siam to confirm what inclination you have?
Siam?
Yeah.
In lateral position, you know, we do pelvis a lot. So you never get a true AP actually. So you're never very sure. But I think the depth you can get some idea. But about the inclination, roughly you will get, but not really a true inclination.
52.
52 ka just outer de do mujhe. So can we open up 52 cup, please?
Your head was also telling 52, right?
Yeah, head was also telling 52, and that system is also telling 52, 53, and very good grip at the reamer size 52.
So one more thing you can do, if you take 51 reamer and reverse ream, you'll probably find it disengages. So that's another way of knowing that you're at the right size.
Yes, very good point Dr. Rajput has said. When you are not very much confirmed, you just reverse your drill and check whether your reamer will get disengaged or not. If your reamer will get disengaged, then that will be the final size, probably.
35 screw 1 and 25 1.
Yeah.
Dr. Rakesh, Dilban's here. Hello.
Sorry?
Yeah, Dilban's here.
Haji, Sat Sri Akal.
Sat Sri Akal, sir. So my concern is, like, as it was looking very sclerotic in the X-ray even, so if we have reamed to this one final size, but still we don't reach that punctate bleeding bone, so should we?
Can we have a look inside? Mop, please.
Focus on the acetabulum.
Let me just wash this, sir, please. Dilbans, have a look. And if you still can't, then I'll have to get the assistants. So can we focus inside the acetabulum? You can see plenty of bleeding bones out here.
Yeah, no, my
go inside, zoom. So maybe just pull. Just a minute. Now Dilbans, see if you can have a look. Can you see that?
Yeah, it's looking good. My question is beyond this
it's
case.
Absolutely bleeding bone here.
My question is beyond this case. Like sometimes we have a situation that the reamer is holding very well. We know this is the
but
size.
you should see bleeding bone. That's true.
Yeah, if it is not the bleeding bone, like should we move to the next size or deep it little?
Yeah, when bone is little bit
So you
more
can ask
scleros.
the assistants if
Yeah, scleros is there, then there should be.
Cup kholo yaar. And 35 screw and 25 screw.
Yeah.
So taking the thread from Dilbans, in that scenario, would you deepen it with the same size reamer, or you take a higher size reamer?
No, you actually take one size lower.
One size lower.
One size lower, you deepen it and then you expand with the other one.
So that's what,
never go higher.
yeah. That means the deepening was not good.
Yeah. It can happen, when you don't have systems which will tell you. I think only Mako gives you the actual depth beforehand. Others will guide you because from the fovea.
Just focus the camera on the cup.
Screw khol diya humne? 35 and 25. Or you want me to do without screw?
Their system, they are using the R3 cup. This system has an excellent hold. that
gap ke
grip.
to bade bade
Just,
hain,
sir, just show the system, this enlarge.
Yeah,
Very good hold is there. Focus the camera on this.
yeah, isko.
Yeah.
Okay, so you see the back part, very good
Back part
porous
of
cup.
that-
You have 3 holes, which are very good. And the best part of this cup is, you know, this is a scratch mark. You see the laser marked here. If you keep this on 12 o'clock, you are automatically, one screw goes absolutely superior and one goes posterior superior. So the 2 screws you want. And the other bit is that you can always tighten this way. But if you want to open, you open up this way. So when you go with the cup inside, don't go here, because you can never rotate back the cup. So better to go in this way.
Yeah,
you can
so-
always rotate gently if you want this side, because that will tighten.
So that notch is actually for liner removal, right, sir?
Yeah.
And-
So liner
and-
removal, and also I think the other version which you have, modular,
Yeah.
that is very, very essential, because if you put modular here, your one screw goes into pubis and one goes into ischium automatically. If you use those 2 holes at the bottom. So
Yes.
for the modular version of this, it's even more beautiful, real value.
Yes. We have that. cup
So
on
you
table.
never use the trial?
Sorry?
You never use the...
You want to see the trial? Okay, fine. No, I was so happy that I didn't use the trial. Can we use the trial 52?
So the modeler is also available at your disposal in the
No, I think this is an
disposal
important
in
step
the
we
OT.
shouldn't skip. Sorry. We go back with the trial. So, hammer please.
What size trial you are using?
52.
So you reamed up to 51 and you...
No, we reamed gently,
Ream up
we
to
reamed outside
52.
52.
Okay.
No, that's okay. So you just hammer it. So now when you put the trial in, you should be able to toggle, but you can't rotate, right? So you can't rotate, but you can toggle. Can you see that? Can we focus here? So I'm actually putting my force. I can't rotate.
Yeah.
So that's the importance of the trial.
Would
and
you-
that it's going in. That's more important.
Sir, would you use the one size up, 1 mm more and do the mouth ream at this point, or would
We
you
have done
just
it. No, not over, but with 52 I've done it. If I find there's a struggle, so this is somewhere I think you have to judge. Shubhang, can I have the reamer? Just show me the reamer. I'll show you something what is something different from what we see in Indian systems and foreign systems. Our systems are quite worn out. When this, is that visible? When this reamer rotates,
swap.
You know, there is a slight, you see this with drill bits also. There is a slight lateral movement. So
Wobbling.
yeah, wobble. And you have to be very careful about that. So always try the undersize first. If it doesn't go, you can go one size up. So be
Okay.
very careful with Indian systems.
Dr. Rajput has done very good one point before starting that trimming, that remove almost all labrum. So once you remove all labrum, then there is no need of doing, majority of the time there is no over rimming of the mouth. Majority of the time that labrum come in between the way of your cup, that will preventing your inserting your cup. So remove labrum, soft tissue surround and make clean dissection there. That will help you more.
So this is the final cup size 52,
Yeah,
right?
it's 52 and the screen, now focus on the screen also, that's they is simultaneously showing the anti-version and inclination also.
Oh yes.
Yes.
So
Yes,
you need to
enlarge this screen.
Slightly. So kholo yahan se.
So you want to match the yellow line, right?
Yes, want to match. Our on modular planning is between 40 and 12.
Right. So I think that's what we are aiming for.
So this one is our plan between 40 and 12 or 13. So see, now is impaction is going on.
Can you bring the main surgical picture into the field?
Sorry?
Yes.
Yeah, that's good.
Can somebody else? I'll have to hold it. Just hammer this.
So change of voice for the audience of the hammer, right?
Yes, now it is sound, little bit change on the sound.
Yeah.
Dr. Rajput, can you please focus on the computer screen and let the audience see the anterior pelvic tilt angle which is being reflected on there, because that's very important. And what was the anterior pelvic tilt angle on the standing X-ray?
Is around 6 degrees.
No, 6 degrees is on the lateral, is the intra-op anterior pelvic tilt angle. What was it on the standing X-ray pre-op?
Pre-op it is 6 to 8 degrees. Are you always using screw, Dr. Rajput?
Can you bring the main surgical field on the screen?
Okay, 25?
Main surgical field.
25.
So now you are using the screws, right?
Sorry, is that
Screw.
Yeah, you can
Are
answer
you
that.
always using the screw or not?
Always, always. Grown up with screws, still not able to leave this bad habit.
But was your final implant well fixed or was still moving a little bit?
Even if it's well fixed, I am always worried.
No, in this case.
This case reasonable, I would say. I haven't tested it.
Okay.
What about you, Dr. Shubham? Are you using always screw or not?
Yeah,
Punjab?
always.
Always.
See, using it is always safer because later on someone will say if it loosens that.
Yeah, absolutely.
Yeah,
I've
because
had
it loosened because he didn't
occasionally.
use it.
Oh.
And once we put this, no, I have to tell.
See, if you get a press fit, it is very good, but I mean, most of us, I think, will use 2 screws. And earlier there was about 15 years ago, they used to say that screw will cause lysis.
Yes, yes.
Yes, but now it is, that has been taken off completely. And press fit versus 2 screws, they give equally good longevity. Registry data is there to support use. Dr. Sandeep, any comments on that?
I think the screw and no screw discussion only comes up when you are doing a dual mobility. I mean, for a standard cup, I think using screw or not screw does not make a difference. But when you're going to a dual mobility system, then it does make a huge lot of a difference. And the debate is still not settled.
So, but if you use 2 screws, I mean, it's safer, right? Even in dual mobility, the toggle is not.
The only thing is the moment you use screws, the modular liner comes into the picture, and the jury is still out whether the modular liner would ultimately fail the way the metal on metal failed. So the jury is still out,
Liner?
especially in the younger patients.
Huh?
There is a clinical guidance is there when to use screw and when not to use. When your cup on table is not get toggle and not get rotated, then there is no need of using screw. But when it get toggle, then you just change your screw size, cup size, and when not toggle and only rotating with the help of the trimmer and not getting absolute grip, then definitely use 2 screw. There is no role of using 1 screw is there.
Screw, no screw. Okay, can we have a liner, please?
Liner, at present we are using that neutral one.
Yeah, neutral liner.
Yeah, and what about your neck length, sir?
I always use neutral liner. Just let me make sure that there's artery fossa, please. There's no soft tissue anywhere.
No, this is a ceramic on poly.
ना छोटा आर्टरी था ना?
Okay.
छोटा नहीं है कुछ? यार पंजाब ये तो आपके हाथ में तो सब बड़ा बड़ा ही होता है इधर.
Okay, okay. This one is better.
So again, no role of trials here.
Which head do you use, Dr. Rajput?
Sorry? Just give me 1 sec. I don't want to get this liner wrong.
We have long artery on table. OT staff, what is wrong?
There is some soft tissue here. That's it. Okay, gone in. Hammer, please. Impactor and hammer. Yeah, bhi maro. I'll have to hold this. No problem. Kariye. Okay. Aarti dena वापस. Right, so Narendra, are they still around?
Yeah,
So I think what you need to check when you put liner, and we have had a lot of issues with liners in a lot of discussions recently, you need to check that every part of the liner is in, if you're zero liner, and particularly in the inferior part. So this is where visibility is poor and you need to make an extra effort to see that the liner is well seated, which is here pretty good. So can I have a roller pack you have? नहीं ये नहीं इसके अंदर डालने के लिए कुछ है रोलर पैक छोटा गॉज पीस गुम हो जाएगा यार नहीं छोड़ दो नथिंग फिर लीव इट चलो लेट्स कम बैक टू दी साइज 1 देना बट आई नीड सम बड़े गॉज होगा बड़ा गॉज कुछ रोलर गॉज नहीं होते आपके पास
Okay, let's go back inside.
Just focus on the computer screen. Till the time Dr. Rakesh Rajput will take that trial, we just focus on the screen. How modeler will
Size
help.
one.
Suppose we just put the liner on the posterior size, posterior, okay? And just focus on that movement circle. Your all movement inside the range. There is no impingement between the implant. Is there? Now just focus. Is there?
Yes, one movement you can show at least. Yes.
Yes. See, this is forward bending movement that we are showing. Okay.
So if it is closer to the center,
Yeah.
that means it is not going to dislocate. It's not. There is no edge loading.
It will not directly give the dislocation idea, but not impinging. at
Yes,
present.
not
Yeah.
impinging, yes.
Yeah. Suppose we use the posterior one.
Give me minus.
Okay.
So in the same movement, you are now showing the posterior
Lip. Yeah.
Yes.
Okay.
Amardana?
Yeah. This one is anterior lip or neutral, or this one is posterior. See,
Yeah.
putting liner posterior, there is, still there is chances of little bit impingement in forward bending is there.
Yes.
Suppose what happen if you are increase the inclination or version. Normally in posterior, you usually put little bit more version, anti-version.
Okay, sir,
See.
please.
When
Yeah,
you are
so-
increasing your version, there is all chances of implant impingement is there in forward bending.
If it is showing red, it is 100%.
Yeah,
going
it is
to
100%. There is 100% chances of
Watch piece
impingement.
पूछा है, बड़ा सा?
So this system will give
कितना बड़ा
actual
है?
guide, and you can also explain to the patient also pre-operatively.
yeah,
We are going to put in this direction, and post-op report will also come in the same.
छोटा ही है।
So once suppose accidentally will patient get dislocated, then also you can counsel the patient. We have done the everything rightly. There is nothing, and medical legal purpose also that will help you a little bit.
Can you show that squatting position on number 3 on the right side?
Number 3 on the right side. Yes.
Pusher. So I think they can have a look now. We are going to just reduce it.
So
Push
it
up,
is
please.
not impinging.
So
Yeah,
you're going
and
to pull
staircase
from
climbing
here
and everything.
And slowly rotate. Now push. Thank you. Okay. Yeah, so it's gone in pretty okay. In
So
fact,
there is
quite-
no need of putting more anti-version.
So we are on minus here.
Yeah, now focus the camera on.
Right, so
that side.
we put
Yeah.
back this here. Put this femoral tracker. So I have a feeling we might be slightly short and maybe 4 mm medialized. So that's the hunch. Let's see what the
system will
readings tell
show.
us does.
Okay.
So you
Okay.
put a trial now of what neck length?
So this is minus.
Minus.
So if I have to go minus, it will be oxynium.
Yeah.
Ceramic will not have it in minus. So let's pointer please.
So they have up to 8 sizes
Aapko,
plus 0 to 8.
On karo. We are going to go leg length.
Ceramic will come in Smith & Nephew 0, +4 and +8.
Depu used to give a plus 12 also over the.
We need to see all of them.
Okay.
Right. So we are putting a thing on the GT marker here, which we have put, right? And now the leg has to be lifted up, please. Leg lifted up like this, bend, like the same position we were in when we checked in the beginning.
So that
You
yellow.
need to mark that with this. So
Yellow target.
Slowly put it down.
Yes.
Big screen करो. Screen
Okay.
big करो.
Just
Computer
if
वाला
somebody
screen
comes-
बड़ा करो.
ये पकड़ो.
Yes.
यहाँ पे. हाँ.
Yes, yes. Abduct it, Rakesh. Little bit abduct.
Sometimes I feel at this time it is like landing a plane. So you
थोड़ा
know
सा ये
you have
करो.
to go left, right, and land in the. Yeah.
कौन सा पेन नहीं आ रहा है? फीमर का नहीं आ रहा ना?
All 3 are red now.
अब आया?
Right. Tracker is red. GT is red.
GT is okay. Now tracker. Pelvis is also showing. GT is showing.
ये साफ कर देना एक बार. Can you clean this one? और पूरा करो इसको, पूरा वेट मॉप से करो. Take a wet mop and bite.
Here computer screen is showing
Come on, this is
that
the most
horizontal
important
offset
screen.
is also showing. Look at this screen.
Take care.
Okay, ready?
Yeah. Okay. Let's see if all are visible. Mop देना, एक fresh mop देना. Okay. नहीं आप ऊपर आ गया. आपको ना थोड़ा सा ऐसे रखना पड़ेगा क्योंकि वो पूरा ले नहीं पाएगा. ऐसे रखना पड़ेगा एंगल में, हैं? So that वो दिखाई दे, हैं?
Yes, now all three markers are showing. Yes, again. Just abduct and match it. Color will change from yellow to green when it will match the circle.
आप थोड़ा हिलाते रहिए इसको. आप हिलाते रहिए सर.
Yes, yes. You are near to. Just rotate it little bit.
Good.
Yes.
Right. So we are 2 mm lateralized. In spite of our trying our best, we are still lateralized. And 12
This
mm shorter.
1 centimeter is short.
So we were close to 1.5 longer. So we want to, but we want to lengthen slightly because there is some distraction on the other head also, which will lengthen up later on.
Yes.
So now we have to balance these two legs. So what should we do is the question. One, we are lateralized, so that has given me 2 mm, maybe 1 mm extra, and 12 mm shorter. So I can come back to neutral. I think that probably would be the best to come in. Then
neutral will
we
give
were
you
1 centimeter longer. We will be overcoming that.
Neutral will give you 4 for reading plus. So then final 8 mm will be shorter and your 6 mm will be
so
lateral.
from 12 we'll get to 4. So that will be 8 mm.
Yeah.
Right?
Suppose you will use plus 4 head, then it will be, I think, perfect.
Absolutely.
Just try with plus 4.
Okay, come. So let's
Pre
try
of
with
horizontal
4.
offset is 6.5.
So give me plus 4.
Plus 4.
No. I think going up on the stem size would help you a lot, Dr. Rakesh. Yeah.
Going what?
Going up on your stem size.
So that will be the next option if I have to leave it out. But
yeah.
coming back to 0 on neck always helps.
Plus 4.
Going up on your neck from minus to 0 would increase the lateralization, and we are already on the borderline of the amount with which we can lateralize the hip more. I mean 2 to 3 mm and about that. More than that, it would cause a lateral trochanteric pain. The easier option would be to go up a size on the stem and keep the lateralization where it is. That's my guess, I guess.
Right. Let's see what happens. Okay, push up please. Okay. Already feeling a bit of tightness.
Dr. Sandeep, if we go up
So,
a size up on the stem,
straight.
there will be some effect on the lateralization also. We'll
Right.
get the length,
Okay.
maybe. Yeah.
So let's get back to what we've seen. Let's see what happens or not. Okay. So that was a theory that whether we add neck length. Yes, neck length will add to some length, but also slight to offset. That's very true. Let's see what happens.
Neck length and offset both will increase simultaneously.
Let's see what happens.
Yes. If suppose you go plus 4, then it will increase 2 mm lateralization and 2 mm length almost. Yes, yes. Activate your.
Hila, yeah. Is this new one or the older reading?
Yes, just rotate your limb.
आप हिलाते रहिए.
Just
The
rotate.
old one, is it? Yeah.
See, previously it was 12, and now when you're using that plus 4,
So-
approximately we are 3
So I
mm
think there was a
shorter.
comment from the thing that lateralization has happened.
Yes.
So now
7
we have to
mm
judge
lateral.
what we do. So we take this one out, go for 2, leave it up a bit, and that will be okay.
Yeah.
Chalo,
Okay.
come.
So just for the sake of discussion, what is the upper limit of the horizontal offset that you can safely increase without causing any functional problem as per the literature?
I think if you were at the right offset, if the hip itself was at the right offset, then I think you can probably, maybe 2 to 3 mm more, even up to 5 I think you can go. For revisions you can go longer. But if you are already short, like if you compared the offsets on the left to the right here, this hip is already on a shorter offset because the head's destroyed. So I think in this one, 2 mm lateralization probably is slightly less.
Our pre-op horizontal offset is 6.4 or 6.6.
Okay.
So here it is 7. So I think it is
Give me retract.
okay.
Hurry up. Thoda speed badhaiye. Arey wo Homans.
So have you changed to sides 0?
We were on.
So what is the length and offset now?
Sorry?
3 mm shorter.
3 mm shorter and 7 mm lateralized. Horizontal offset.
So I think if you see here, we are absolutely flush. So when we go with the other one, we might be 3 to 4 mm longer. Okay, extractor please. Hammer. So give me the next size up, which is size 2, is it? Size 2. So Shubhang, I'll just do the trials.
Yeah, do you think you should clinically also assess whether the hip is getting too tight?
Yeah, you can. So this required a bit of push.
Yeah.
But I think if this was short, I would accept this. This hip is already long. So we are now.
So my concern is that we have just put a +4 head. That should change the lateral and the distal both by 2 mm. And the figures have changed by like 9 mm and 5 mm. So
doesn't fit in.
Yeah. So might be some issue with the leg tracker which is pinless.
Give me minus again, and this one. So we'll go back with the minus.
That is a fallacy of this. Sometimes you can, if you
So
don't tape
if
it
you remember
properly.
from memory, when we were minus with the size 0, or size 1 actually, rotate out please. Out. अच्छा ये दे दो मेरे को पहले.
Reduced or not?
एक मिनट इसको रख लो. मेरा हाथ एक मॉप देना मुझे. ओके. थोड़ा नीचे करिए. हाँ. Okay, head please. आप थोड़ा सा इधर आइए.
Moderators can share with us what they are.
They are actually try to reduce the.
What we were discussing was,
yeah,
if you keep the stem a little out by changing it from 1 to 2,
let's go back.
Okay.
Then only the length will increase, not the offset.
Okay.
Okay, so we have got it back. So this time we have slightly bigger size stem. We have kept it proud, close to 4 mm. And again gone back to minus head. Let's see what happens. I think this is the beauty of this system.
Minus head actually looking very much stable, ne?
Yeah, it's looking quite stable.
So now your offset will also remain the same.
But
yeah, so we should probably go back to maybe slightly longer of lateralization. We need to get the camera. Feel blood like can wipe this. blood लगा लेकिन it's showing अच्छा नहीं femur tracker ये this needs to be wiped out.
Yeah, it's okay now.
Okay.
Show the screen.
Right. वापस करिए. Okay, so we are now 6 mm lateralized, 5 mm shorter. So this is where you got to make a judgment. What are you going to leave at? So we'll just check our stability also. Can we have some artery forceps please? And Langenbach, so we can show.
Dr. Rajput, do we have a measurement of preoperative neck shaft angle?
I don't have a goniometer here, but I think if you look at the X-rays, this is more than 135 or maybe just about 135.
So that explains the problem actually. The neck shaft angle is 135 and the standard stem of Polar
127
has the neck shaft angle of 131. The high offset has the 127. So the moment you go with the neck stem which has a neck shaft angle of lesser than the native neck shaft angle, you would have the similar sort of discrepancy which is being shown right now.
Absolutely. So Corel would have been a very good stem for this.
Yeah, so a stem which is 135 degree would have sorted a problem here.
Absolutely. So Corel is one, but I think you do best with what you have. So we'll just...
This is just for the discussion, obviously.
Absolutely.
Yeah.
So we'll just look at the stability. So there was this question about different approaches and all that. So I just want to show the stability which this approach provides. So we're going to probably accept this as our final implants. So if you just... So the stability is not like the posterior approach where you twist the leg in 90 degrees. This is the most unstable position. This one here. So it's an extension. It is slightly adducted and externally rotated. So this is the most unstable position for a anterolateral approach. And you can see that nothing is budging out here, right? So if I have to dislocate, I may have to literally pull it out.
Enlarge this screen, surgical side
So
screen.
if you just show this, you can see, or maybe I can let one of you do. Who's the doctor out here? You? So try and pull this out. Sir, you have to pull this out, right? So you can't dislocate just by the leg. So can we go out? So we are going to go back to the actual implant. So if you can open up size 2. And we'll go for oxynium head.
You can put a ceramic head also.
Ceramic won't be in minus.
This is mine. You're now
You'll
finally
have terrible
decided.
trouble when you come to operate.
Yeah.
The other one you're doing, isn't it?
Yes.
Size 2. So can I have a gloves, please?
So now I think that we should off the screen. Sir, Rajput sir?
Yeah.
Off the screen now?
Let them, whatever they
Yeah,
decide.
now, okay. So final implant is stem 2 size, head size -4. Okay, sir?
Yeah,
Yeah.
oxynium.
Anything you want to ask Dr. Shubham?
I think we are very good here. The moderators, is there anything?
I
Shall
think
we
you
close
need
the
a
session?
big applause, that's all.
So I think we want to thank you from the anesthetic team. Shubhang, you got a fantastic anesthetist. I
Thank
asked
you.
for 100 systolic, she gave me 90. That's why you found almost no bleeding.
Thank you. Thank you, Team Moti.
Dr. Rajput, very good, very good.
Thank Narendra also for moderating the outside bit quite well. And we got Dr. Ashish and Dr. Ranjit from the Smith Nephew side. And I've got 2 other people.
Yeah,
So
very
thank you
good.
all from the team.
Yeah.
Thank you, everyone.
Yeah.
Thank you, sir. That was such a mesmerizing demonstration.
Ek mop dena.
Now, I would request
Again,
moderators
need a
for the
fresh
next session, which is on the talks total hip replacement. I request the moderators, Dr. G.S. Sheena.
Mop.
I would request Dr. Shubhang Agarwal to come on the stage and please honor the live surgery moderators. So please be here. And Dr. Nilesh,
Very warm.
please, sir, please come on the stage.
I request Dr. G.S. China, Dr. Chetan Sood, Dr. Dilbans Pandey, Dr. Vikas Pada, Dr. Deepak Joshi. Also, I request the speaker of the scientific session to kindly be ready to come on the stage afterwards.
Okay, with this we'll start the next session, that's on total hip replacement. And we call upon the first speaker, Dr. Narendra Parmar. He's speaking on pre-operative planning and templating in THR. Dr. Parmar is there? Okay, we go on to the next speaker then, Dr. Sandeep Gupta. He's there. So, Dr. Sandeep Gupta is talking about cup positioning and safe zones versus the functional zones. That's a very interesting topic because the functional hip is now coming into the limelight.
Good evening. Good evening, everyone. Thank you, Dr. Shubhang, for this wonderful gathering. So my topic would be on compositioning, safe zone versus functional zone. And I think there cannot be a better topic after the live surgery than this. So why we are talking about this? Dislocation still remains the leading cause for early revision, accounting up to 18 to 20% of early revisions after total hip replacement, and this incidence hasn't changed much. Why are we questioning safe zone? The answer is very clear. Multiple studies across the board have shown that around 60% of the cups that dislocate are actually positioned in the safe zone. So safe zone actually is not safe as far as dislocation is concerned. Now, what was the safe zone? Levnik described safe zone in 1978 on 300 odd pelvis, and his measurements was based purely on supine static AP view. And he described safe zone as inclination of 40 degree plus minus 10 degree and anteversion of 15 degree plus minus 10 degree. Now, what was the fundamental flaw with this sort of a safe zone position by Levnik? Obviously, in 1978, the science was not that advanced. We are in 2025 and we have the wisdom of 47 years. So looking back, the fundamental flaw with the Levenik zone was that it discounted the pelvic motion in routine activities. So what it was measuring was a static measurement, and thinking that this static measurement would lead to a safe cup in all the physical activities, discounting the spinopelvic mobility, which has come into a huge focus in last decade or so. And it forgot that the ideal cup target is based on actually the standard spinal sagittal orientation. Every patient on a lateral view would have a different sagittal orientation of the pelvis, and that would change the native cup position in that patient. So these two fundamental flaws were there with the Levenik zone. Now we dive deep into it. So what happens? Now all of us now in 2026 know that the spine and pelvis and acetabulum are joined like two liver system, and both movements go simultaneously. So in a normal majority of the patient, when we go from standing position to sitting position, the pelvis rolls back. So what does that do? On an X-ray you can see the pelvis rolling back as we go from standing to sitting. So what it does is it opens up the acetabulum, and what are the objective numbers to this? Every 10 degree of change in pelvic tilt changes the acetabular anteversion by 7 degree and changes the acetabular inclination by 3 degrees. So that means if a cup was positioned in the standing position of 40 degree and 15 degree of anteversion and 40 degree of abduction, when the patient goes in sitting and the pelvis is rolling back, so the moment the pelvis tilts by 10 degree, the anteversion actually becomes 22 degrees and the abduction becomes 43 degrees. So these are the numbers. Now, based on this, we have to know that the safe zones now become functional safe zone. So what was defined was a supine static safe zone. So actual safe zones are functional safe zone, and what are those? The standing target of anteversion is 15 to 25 degree. The sitting target of anteversion is 30 to 45 degree, and to achieve these targets, we make sure that we have a mandatory dynamic increase of 10 to 20 degrees. So 3 caveats: the targets are different from standing and sitting, and to achieve that, we need to have spinal mobility. Now these are the factors on which we are talking. So safe zone would become functional zone. Levenik still has a role. Safe zone is equal to functional zone provided patient has all these parameters going for him. He has a pelvic tilt standing of 5 to 15 degree, APTT. These will be dealt in detail with the spinopelvic lecture, but you can have a screenshot of this, and if you have a patient who has these parameters, then your Levenik safe zone is equal to safe functional zone. But there is a problem. The problem is that the spinopelvic mobility across the population is very variable. It's not always that the pelvis would move from standing to sitting, rolling back posteriorly. It varies from anterior rollback to posterior rollback, and there are certain parameters which are actually considered to be dangerous for dislocation. And what are those? Number one, the normal population, when they get up from the supine position, the pelvic rollbacks by average 5-6 degrees. The moment pelvic rolls back by more than 13 degrees from supine to standing position, the Levenik zone cup goes into a unsafe zone. Just have a look. Now you have a cup which is positioned in 40-20. The patient has a paradoxical movement that the standing pelvis rolls back more than 13 degree. That cup becomes an anteversion of more than 30 degrees and goes out of the Levenik safe zone. Now the second paradoxical movement is when from standing to sitting position, instead of posterior rollback, patient actually has an anterior rollback. So if the patient has an anterior rollback, the cup anteversion actually goes from 20 degrees to 8-9 degrees and the hip dislocates posteriorly. Now these two paradoxical movements are present, and they are present in 13.3% of native population. So your 13.3% patients are at risk of dislocating if you just target the Levenik safe zone and you do not delineate their spinopelvic motions preoperatively. Now the problem statement number 2, this was spinopelvic movement, that it can be paradoxical, it can be less, it can be more. Now the second problem is 6% of the patients who come to total hip replacement have a stiff spine, and 80% of these are not the spines which have been fused. They are just non-fused degenerative spines, and all of us see hip patients with a degenerative spines, and this is the problem statement number 2. Now what happens is, the moment you have a stiff spine, the total potential of spinopelvic mobility decreases. So actually the patient can get stuck in one position, and there are 2 common morphological variants. One is stuck standing. Stuck standing means that the pelvis does not rotate backwards when you go from standing to sitting. So what it happens is, when you're going from standing to sitting, standing is stable, but once you go in sitting, it is not rotating backwards. So there would be chances of anterior impingement with posterior dislocation. And there is a second variant which is stuck sitting. So what happens in stuck sitting is that the patient remains in a sitting position pelvis. That means the pelvis is rolled back even in the standing position, and patient has a chances of posterior impingement with anterior dislocation when patient tries to walk, get up and walk. Now, what are the red flags to look on AP X-ray? You are getting an AP X-ray of the pelvis. Look carefully. If the AP X-ray looks like an inlet view, that points toward potential of a stuck standing patient. And if the AP X-ray of the patient looks like an outlet view, just go forward and evaluate. It might be a stuck sitting variant of a stiff spine. Now, summarizing all this, the safe targets still remain. Standing target 15-25, this is non-negotiable. Sitting target 30-45, non-negotiable. This is anteversion. Abduction has not much role. Once you dial in 38-40 degrees of abduction, you are sorted for all the normal variants. And mandatory dynamic increase of 10 to 20 degree posterior rollback from standing to sitting, which may or may not be present because patient may have degenerative spine with a stiff spine. So these 3 things you have to remember. How you go from safe zone to functional zone now. You do a pre-operative standing and sitting lateral radiographs. You have to do it in all your total hip cases. You have to match the cup orientation to pelvic pattern of that particular patient in standing. That means if in his standing view, his pelvic tilt is abnormal, you have to dial in for that when you are dialing the safe anteversion for standing. Because you will be doing surgery in supine or lateral. So you have to dial that delta into that. Now once you have done that, you judge how much mobile the spine is. And if it is abnormal mobility, you cater for that also within that dialed anteversion. And once you do that, you need to know whether it can be actually achieved on table with your standard implants or not. And if it is not, then what special implants do you require on table? Just to delineate, the most difficult spinal patient which can go horribly wrong in almost all hands is a patient who has a flat back with a stiff spine. So this is a patient who is very difficult to manage even with advanced bearings like dual mobility. So be on the lookout of this particular patient. So this is an algorithm which I follow. You can take this algorithm from me later on. This is how I dial in the things when I do a pre-operating planning. Robotics. Now the question of robotics. We saw a robotic hip. You have to understand, robotic can execute what you tell him. But what to tell him is your job. It is our job as surgeon to know what is the specific orientation of the cup we are targeting in this patient based on our preoperative evaluation, and then we tell the robot to do that for us precisely. Robot cannot plan for what we can. So for final message, there is no safe zone. There is nothing called as a safe zone. There is only a patient-specific right zone, and that is a functional position of the cup, and surgeon defines it, robots achieve it. Thank you so much.
Thank you, Dr. Sandeep. And of course, the topic is open for discussion. And I can't understate that how important it is, because of course you already mentioned that the commonest cause, the biggest complication is dislocation. We all dread it. So is there any question from the audience? Okay, if there's no question, then I have one question. Do you think this makes a serious case for use of technology in every hip case? Or you have some criteria that you will use this, use technology only in such cases?
So for me, technology begins with a good radiograph and a good radiographer. So yes, using technology pre-operatively, I need to have a good standing lateral and a sitting lateral. That's absolute must. I have to teach my radiographer to give me those parameters because those are my starting parameters. Now once I have defined my starting parameters, now the surgery again is neither done in the standing nor in the sitting. The surgery is either done in the supine and the lateral position. Now based on those, I define my I get my registration done on table with the robotics, and once the robotic gives me those parameters, I was repeatedly asking about the anterior pelvic plane tilt, right? Now the APTT, PT and SS, they are mutually, they can be interchangeable. Now the moment you have the intra-op and tilt when you are doing the registration, you can dial the standing pelvic tilt with that and dial in your anteversion. Let's say, for example, I have chosen on the standing X-ray a cup anteversion of around 15 degrees, for example, right? Now, if my anterior pelvic tilt on a standing lateral was 10-degree rollback posteriorly, and on my on-table anterior pelvic tilt is 5-degree rollback only. So there is a difference of 5 degrees, right? So now my safe standing anteversion is 20 degree when the pelvic tilt is 10 degree. Now on table it is 5 degrees. So I dial 0.7 into 5, 3.5. I obviously have to decrease my anteversion by that much for me to be able to translate the position achieved on table into a standing safe position. So this is how you work around it.
So I think there is definitely a case for use of technology.
Absolutely.
Compared to the knee, even the leg length and the offsets add to the hip. So the functional hip is now the real thing.
Yeah.
But do you think there is a case to be more cautious, or any approach which, is the approach adds another dimension to functionality? Muscle cutting and muscle sparing?
Absolutely not in my practice. Approach is immaterial as long as you do a good job of it. I think there are 4 things which are absolutely must. It's a mechanical surgery, and you need to recreate the neck shaft angle. The moment you recreate the neck shaft angle, you are very easy to recreate the horizontal offset and the vertical offset, which gives you the limb length and the function. And the rest of the dislocation depends on the PT, delta PT, and the stuff like that, which you can achieve with pre-operative X-rays. And robotic just adds another dimension, that it can increase your precision. And you need to know what your native acetabulum is. So another thing which I would like to tell you is that most of us are operating our hips, whether anterolateral or posterior, in a lateral position, right? Now, with all due regards to everybody, I, in my practice, find it very difficult to stabilize the patient perfectly in a position for my external guides to be of any use, right? So every surgeon who's doing a total hip needs to know what are the local anatomical landmarks which would tell you how to position the cup. It's all said and done very easy that you put a guide, it is 15-degree anteversion, you look at the leg, you look at the shoulder, but that is very difficult, especially in the lateral view, and there are a lot of errors. So defining your 360 degree of the acetabulum, knowing if there is any abnormality pre-operatively by having a high index of suspicion to get a CT scan done, that there may be an intra-articular acetabular abnormality, and then dialing your acetabulum according to the native acetabulum and using technology based on the pre-operative lateral X-rays to exactly target the position which you target is the way to go. Thank you so much.
May I invite next speaker, Dr. Tanveer Bhutani from Ludhiana, for his talk, Achieving Leg Length and Offset Accurately.
So a request from the organizers, at 6 minutes we'll give you a reminder of last 1 minute. Please try to be in time. And the bell is your only guide. You don't have time in front of you.
Good evening. I'm Dr. Tanveer Bhutani. I thank Dr. Shubhang and Team NHS for organizing this wonderful event and for giving me the opportunity to speak here in this august audience. Following up on the wonderful talk given by Dr. Gupta, my talk is going to be on achieving leg length and offset accurately. So why this matters? It matters because it is the #1 cause if we don't meet any of these two criteria for patient dissatisfaction, obviously limb and gait disturbance. It causes symptoms like low back pain, and of course litigation is one of the major things that we are all worried about in today's time and age. And offset errors also contribute to instability, which is the nightmare that all of us have, dislocations and instability, but also early wear and symptoms like trochanteric pain. And it can cause compensated or true Trendelenburg's gait. So the core biomechanical principles remain the same, whether we are in the age of templating manually or in the age of robotics now. So an ideal femoral offset would increase the abductor lever arm, decrease the joint reaction force and improve stability. Whereas if we decrease it, it causes weak abductors, can potentially lead to instability, and also the joint reaction force increases. Whereas an excessive offset will cause symptoms like trochanteric pain and soft tissue. So the abductor force is inversely proportional to the lever arm. Small reductions in offset can significantly increase the joint reaction force. And definitions are very important because clarity is critical. So leg length, femoral offset, acetabular offset, and global offset are the things that we have to keep in mind when we are planning or templating a surgery, including the initial X-rays, including the initial CT scans if required, and that also includes the global offsets and the FOAO quota that we have. So the interplay of length and offset. So this is the delicate dance. Increasing the head length increases leg length significantly. It modestly increases offset. Whereas lateralized stems can increase the offset but have minimal effect on length. Length and offset are not interchangeable. So medial offset and vertical offset both have to be achieved in order to give not only a stable but a functionally comfortable hip and a successful hip to the patient. Preoperative planning is very important, and one of the most important factors, as previously pointed out, is the neck shaft angle. We have to start with restoring the hip center of rotation, measure the native femoral offset, plan the neck cut level, predict stem geometry, and then also assess the contralateral limb. Whether it is normal, abnormal, that's a secondary issue, but we have to take it into account. And failure to template definitely increases intraoperative variability, and we might be caught up with a couple of surprises. So the errors in hip center cause apparent LLD, altered abductor mechanics, and increased joint reaction forces. Hip center restoration is step 1 before leg length restoration. Inclination, depth, and height all have to be, the teardrop remains our go-to reference point on preoperative X-rays on which to template. There are lots of softwares available, a lot of things available in the current robotics generation in the era and time that we are in. It is very important to have an intraoperative control of leg length. So the techniques include the manual techniques in which there is a suture tied and then there is a manual. So an intraoperative measurement from not depending on an external factor, but things that are inside the field and which we can measure. But the most important thing at the end of whatever device we're using, whether it's a caliper, whether it's pins with the distance being measured between them, or even robotics, we have to be able to reproduce the limb position. Measurement without reproducibility is unreliable and it will fail us in every way. Intraoperative control of offset can be adjusted by stem geometry, neck shaft angles, modular neck length, and head sizes. And different kinds of offsets give us different kinds of results, and one has to be selected, but it has to start at the hip center of rotation first. With technology and robotics, real-time leg length change and abductor, the offset change is visible, as was shown by Dr. Rajput in his surgery. And it does have the improved reproducibility and reduces outliers. But technology without variability does not eliminate conceptual error. It will help us reproduce something, like Dr. Gupta also said, it cannot plan for us. We have to be the one at the helm and planning. And common causes of error include pelvic tilt intraoperatively, inconsistent limb positioning, excessive medialization, or failure to restore the hip center, ignoring preoperative spinal imbalance, as was very well spoken about by Dr. Gupta previously, and failure to consider contralateral deformity. Many femoral discrepancies are actually acetabular errors. So that's where we should probably go back and look. Under restoration causes symptoms which we are well aware of, and over-lengthening usually is also not well tolerated. And anything beyond 5 mm in a very functional patient sometimes is not taken very kindly to. So I think a practical algorithm that we can all follow is to template thoroughly, restore hip center first, reconstruct femoral offset second, then fine-tune the leg length last, and confirm stability dynamically. Of course, look at the numbers, but don't rely on them. Offset length, offset is always before length, and stability is always before symmetry. And I think precision begins with planning. Technology helps us improve accuracy, but not judgment. These are my references. I thank you for your time.
Any questions from the audience?
So I would measure the neck shaft angle first, and then make sure that I have a stem which offers me all those things available. I will always have stems available with different neck shaft angles also available to me going in, so not just one stem. And I would rely heavily on that inventory rather than just the technique. So starting again, the first point should be the restoration of the hip center, and then the offset. So once I'm sure I've achieved the offset and the abductors feel right, only then do I go to the length. And the stability with the shuck test and everything, of course, it helps us. If the contralateral hip is normal, it makes life easier. But if the contralateral hip is also affected and it's the first hip that I am operating, then we have to go by judgment and then hope that we do a good job and then end up reproducing the second hip to the first hip.
So thank you.
Thank you, Dr. Pandey.
Great talk. Now we'll call our next speaker for the talk on spinopelvic relationships and its relevance to THR by Dr. Trish Shetty. So by the time they are setting up, like it is really complex topic and we always talk about this. So if you just want to give one brief point, like once you have measured the angles and you know there is a spinopelvic issue and you are not using technology. So what is the very simple way to modify your cup placement? Like if you're doing a manual, so is there something like, okay, if it is stuck in sitting position, we will give it slightly more inclination or slightly more anteversion, and if it is stuck in standing. So in brief, just a straightforward.
Sir, anyway, I was going to keep it brief because most of what I wanted to say was already covered by Dr. Gupta, sir. So all I want to stress on is that what we used to think used to be the safe zones as described by Luminic back in the 70s, this turns out that it's completely unreliable. What we thought were safe zones were actually as displaying in the dark. So now, with the current trends and with spinopelvic mobility coming back in vogue, we should look, once we've done a complete assessment with all of these additional radiographs, like the few of the ones that I'm going to be showing ahead, also the ones that were used in our live case. Once we've got all those radiographs and we've got our planning and we've got our all the parameters established, we can go straight to the classification which has been put forth by Fan, Steffel and Viktorczyk, which describes these 4 grades, which is 1A, 1B, 2A and 2B. Especially of importance is 1B and 2B, which we see in ankylosing spondylitis. So when we see such cases, we should keep in mind to place our cup in relation to their described recommendations. So I'm going to skip all of this because most of this was covered. Yeah.
And that's good understanding of a second year postgraduate. Okay, so Dr. Trish is a second year postgraduate MS Ortho. So, and he is going to present review of literature.
Okay. So this was my simplified version of everything that sir said. This was for the residents in the back actually. hoping that they understand better. So I'm actually also just going to quickly touch on a few of these. So these are the kind of X-rays that I'm getting done at my institute. It's a rural institute in Maharashtra. I think it can be replicated even here in Punjab. It's universally applicable. So this looks complex, but when you try to break it down, we can also make it into a very simple line diagram. Looking at the lumbar lordosis in standing from the end plate of the S1 all the way up to L1, we can assess the condition of the lumbar mobility. Along with that, this anterior pelvic plane, which can be formed by the anterior superior iliac spine and the pubic symphysis. So this dynamic relationship, it's actually very difficult to balance, which brings us back to this figure. So why this is important? There was a notice that there is a very, very high rate of dislocations in those patients that have spinopelvic imbalances. So that is how this entire discussion came up. Biomechanics already has been very well explained. So going from standing to sitting to allow for hip flexion, the rotation of the pelvis, the posterior tilt of the pelvis, all of that has been touched upon. I'm just going to stress on these figures for the residents as to how we can calculate these with these special X-rays that we take. So going first talking about the pelvic incidence, we established the biofemoral axis and the center of that. So since we're looking at a 2D view of the X-ray without EOS, we don't have availability of that. If we're looking at it, we can just consider the center of the femoral heads wherever they overlap and connect that point to the center of the end plate of the sacrum, and drawing a perpendicular to that is where we can find the pelvic incidence. Once we have that value, we can also take sitting and standing lateral radiographs of the pelvis, including L1 to L5 along with the proximal femur and both femoral heads. And once we've got both values, we can read the sacral slope as SS1 or SS2, maybe we can label them that as such, and calculate the delta value. So that delta value falling between 10 to 30 degrees can be considered as normal. Anything below 10 degrees of motion, a delta less than 10 degrees, we should know that it's a hypomobile spine and start thinking about placing the cup accordingly. And anything over 30 is a hypermobile spine, which can also lead to instability issues. So these are all of those technical terms described in short. The important ones being sacral tilt that I've already explained. There is the spine pelvis hip axis, which just goes to prove that all of these three function as one coordinated unit. And spinal limb balance, we do know it has been already established. So a simpler workflow to what Sir described already. I would still might just disregard this entire box and say that we could do these views for all patients. Why not? They're just simple X-rays. And just rule out maybe we missed it somewhere, and then go ahead and find out the optimal cup placement. In fact, my dissertation is based on the same topic. So this was the grading as I described earlier. And especially for ankylosing spondylitis, group 1B or 2B, these are the few modifications or adaptations that we can make to improve outcomes in such patients, where we can increase the cup anteversion to 25 to 30 degrees, or make use of a dual mobility prosthesis, or even sometimes for spine surgeons, pedicle subtraction osteotomies can be done before the total hip replacement procedure to improve post-operative spinopelvic mobility. That's all. Thank you.
Good. Any questions? That was in time. Thank you.
Wait. Yeah, I have a very simple question to ask. That if the native hip is not dislocating and we are putting probably a large diameter hip, why are we so worried about prosthetic hip dislocations? So what are we doing to our hip replacements that they are dislocating if the native hip is not dislocating?
So native hip is not dislocating because one, there is a ligamentum teres, that is strong thing that is holding the thing back. Second is a labrum that is having a negative pressure. So even if when we do a hemi for fracture neck femur, it is tough to take out that.
So I feel that there is a role for the soft tissue restraints which are not being discussed at all. And I heard that, the approach doesn't matter. I think the spare approach will definitely reduce your dislocation rates. If you can repair the capsule, that will also definitely reduce your dislocation rates. And that also has a role. I'm not saying that this doesn't have a role, but that also has a role.
Yeah, so I'll probably cover it in my talk. That's on DA. But I personally feel, since I started doing the DA, that I now put the acetabulum face on. I don't do any anteversion influence. Like you want to just, the native hip. And then I realized that we actually create a instability by going posterior, or by muscle cutting approach. We create the instability. To cover for the instability, then we give anteversion and inclination. That's required. And the posterior patient, of course, anybody who does a good posterior is very good. But the way the posterior patient always has to go for some kind of a dislocation precaution almost throughout his life, that's also another advantage. So these are, I'm saying, we'll probably bring it out.
You have to put, let's take that the femoral anteversion is what is native and acetabular anteversion is what is native. So actually the anteversion which you get in the cup and femur is the native one only. So we are talking about that only, that you have put the cup in the native anteversion. So that by default in most of the patients is between 10 to 16, 17 degrees. So 15 degrees would be your average. And similarly on the femoral side it becomes around 15 degrees. So combined becomes 30 degrees. So we are talking of the native, we are not anteverting with respect to the native anteversion. So that comes into picture only when the spinopelvic parameters come into picture. And as far as the approach and soft tissue repair is concerned, it is absolutely must that the soft tissues have to be repaired the way they have to be repaired, even in the posterior approach also. And all these talks come after you have mastered those techniques, and then only you talk about these. If you are compromising on those, there's no way out of it.
Thank you. And we'll thank Dr. Thirish for a wonderful effort to explain something that I failed to understand. The next talk is managing, I think Dr. Vijay Goni is not there. Yeah, so we'll call about managing complex primary dysplastic hips, Dr. L. Tomar from Delhi.
Yeah, good afternoon everyone, and thank you Subhang and NHS team for inviting me here. So my talk is THA in complex dysplasias of hip. So these are complex dysplasias of hip. I would like to know whether we can do total hip replacement in these cases, robotics does have any role, and what is the role of anterior approach and dislocation of the things. So we are going to discuss about these cases only. So this is sequelae to CDH, post-infection and post-trauma in early childhood. And there is gross anatomic abnormalities, acetabulum and femur are underdeveloped. Femur gets displaced out of the socket and there is grossly altered hip biomechanics. Hamstring, adductor, quadriceps muscles are shortened and weakened. Proximal migration of femoral head is there. Hip capsule is grossly thickened. And sciatic nerve is shortened and vulnerable on limb lengthening more than 4 centimeters. So Krauss classification is for these deformities, and this is based on the displacement of head out of the socket. Grade 3, more than 75 to 99% displacement, and grade 4 is completely dislocated head out of the socket, and these grade 3 and grade 2 are the complex hip dysplasias. So surgical consideration in these for doing total hip arthroplasty in these cases are evaluating the preoperative limb length discrepancy, relocating the hip center, predicting the use of shortening osteotomy, choosing appropriate implants. So rather than the normal arthritic hips, the things are different here. Templating is done, which is a must, but it is always done on the pathological side, never on the normal side, because we have to reconstruct the stable, we have to make a stable construct on the affected side with the available bone stock and the available soft tissues, which is not like that of a normal hip. So assess acetabular cup size, depth of the true acetabulum, determine femoral shortening. Limb scanograms are taken to identify the limb length discrepancy. On lateral view, we identify the anterior angulation of the femur, determine the cup size, and the site of osteotomy is planned. CT has got a great role in these hips for prosthetic selection, predict acetabular cup and femoral stem size, predict the graft and osteotomy consideration for acetabulum. And it tells us about the anterior posterior column deficiency in the acetabulum, about the socket size, thickness of the anterior posterior columns, and the medial bone stock available in the acetabular roof for the acetabular implantation. So reaming should always be done on the most posterior side. The CT can show us that there is more bone in these cases on the posterior column. It gives us idea about the grossly changed version of the acetabulum and the proximal femur also. The surgical steps. So ideal approach for this is posterior-lateral approach or the posterior approach for grade 3 and grade 4 dysplasias. And in a usual manner, we identify the external rotators, identify and tag, visualize the sciatic nerve, then release the adductors and iliopsoas muscle, excise the capsule all around. Capsule is grossly thickened and big capsule side we have to identify, but we have to simultaneously protect the abductor group of muscles and the other muscles we don't touch. We have to be careful about the other neurovascular structures also. Identify the inferior margin of native acetabulum. Then come to the proximal femur, neck osteotomy is done, reaming of the proximal femur, only the proximal part, never perforate the cortex beyond this deformity, and then fix the trial sleeve in the proximal femur. Then we try to pull down. If we are able to pull down to the native acetabulum, then it is okay, but if it is difficult, we don't do further dissection of the soft tissues, and immediately we plan the osteotomy at the deformity site, which was predetermined in the templating. So after osteotomy, acetabular exposure becomes quite easy. And the acetabulum, then we prepare the acetabulum. It is shallow and hypoplastic with deficient bone anteriorly and laterally. And biomechanically desirable is to place the cup in the true acetabulum, native acetabulum. And high riding hips are also acceptable, but never in the lateral position because they don't survive for longer periods. Acetabular deficiency is usually in the superolateral part, cup remains uncovered. So at least there should be minimum 50% coverage of the native bone, which is desirable, preferably 70%, and this is achieved by acetabular augmentation with bone autografts or porous metal augments, and sometimes with medialization of the component with or without medial wall osteotomy, that is cortiloplasty. So the pulse for acetabular reconstruction it should be reconstructed always in the true native acetabulum. Smaller cups, usually 40-42 size cups are used, and there should be minimum 50% host bone coverage, preferably 70%, and cemented cups have better survival in these cases. Then come to the proximal femur. There is excessive neck anteversion, posteriorly displaced greater trochanter, valgus neck shaft angle, hypoplasia of the intramedullary canal, and rotational metaphyseal diaphyseal mismatch. So to take care of all these abnormalities, we have subtrochanteric derotation osteotomy, which rotates the proximal fragment to bring metaphyseal flare and greater trochanter in a more anatomical position and restore the function of the abductor group of muscles, and it corrects the femoral shortening and anteversion also simultaneously. So hip arthroplasty can be achieved without sciatic nerve stretching, and it simultaneously can correct the proximal femoral anteversion. So the ideal implant for this are the modular implants, and its modularity is these are SROM implant allows us to adjust the femoral medial offset, vertical height and version, even in excessive neck shaft angles, and proximal sleeve give greater initial flexibility, and the stem is also fluted, they gives rotational stability. So pulse for femoral reconstruction, if more than 60% anteversion is there, always perform osteotomy to optimize the trochanteric position. Abnormal anteversion also can be corrected by derotational osteotomy. So this was 38 years old female, sustained fracture neck femur in early childhood, and this was done with small size, 42 size, uncemented cup without using any graft, and the modular stem derotation, subtrochanteric derotation osteotomy, did very well. The patient was able to walk the next day. And this is another patient. This was 27 years old female with the septic arthritis in early childhood, underwent 6-7 surgeries. And this was the kind of the picture on X-rays. So I would like to know about my robotic colleagues, whether there is any role of robot on these cases. So this was again done. CT scan showed all deformities and smallest cup size with anterolateral graft taken from the iliac crest for use. This was 42 size cup only. And on femoral side, the modular stem, subtrochanteric osteotomy, and this was stabilized with the graft and this way. And I was never happy seeing the X-rays. However, peroperatively, this was quite satisfactory. And these were the X-rays after 6 months. And this is the patient was able to walk the next day or within 48 hours. Another one is at the stitch removal, and the third one is at 6 months' time. This is 27 years old female. Thank you very much for the patient hearing.
Thank you, Dr. Tomar, and house is open for any questions. Any questions from the audience? The question that you asked, Dr. Tomar, that is there a space for robotics? Anybody would like to take a call on that?
Yep. You don't have space for cups because you're going to do something very different to what you actually have.
So I think true robotics doesn't have a role because you need a lot of experience on something, but definitely technology has a role in that. IntelliJoint being one of the products which is available in the market, and you can use the balancing part of the robotic, not the true reaming part of it, to balance the hip. The advantage of that is that to find the center of the hip, you can kind of mirror image the opposite side, which is always a problem to find the real center of the hip. So you can mirror that with something called IntelliJoint or the imaging part of the robo.
In dysplastic hip, you don't have the mirror image of the opposite hip because the hip that you have to taken care of is
you image the hip by a CT scan and you mirror it.
Okay.
Yeah, so you can actually get the center of that also.
I think 3D printing has got a lot of good role.
Yeah, 3D printing.
You can do 3D printing and sit with it and actually find out, and it tells you the anti-version beforehand, how much anti-version you have. But you have to ask the guy who's doing 3D printing to give you that data also, otherwise they don't give you.
Actually, anti-version, finding out the anti-version, we have an idea. But here our aim is to fix the cup on the available bone stock. Yeah. So,
not about this thing, femoral anti-version.
What? Femoral anti-version, yes, we can, when we fix the cup and then we do either osteotomy, then we check for the how much we have to derotate that osteotomy has to be done. And of course, a little bit of that, even after that, can be taken care of with the SROM stem.
So I totally agree with you that technology in this situation will only mess up your life more. So there's no debate about it. We can just push the robots anywhere. Yeah. The concern is that when you are doing this kind of dysplastic hips and you are doing the subtrochanteric osteotomies, so the limb is shortened and we are like shortening it a little bit further. So what are the actual consequences in these patients? Like
we are not concerned about the shortening. We are not concerned about the shortening because we are trying to bring down that hip from higher up to the lower side in the native acetabulum. So in fact, we are increasing the length. We are increasing the length of the limb, right? But then our hamstring muscles are shorter. So hamstrings will not allow it to come further. So there is no way we can't excite the hamstring muscles. So that can't be released. Otherwise, it will become absolutely flail kind of limb. So to overcome that, the maximum length that you can achieve is around 3 centimeters. Yeah. But beyond that, the hamstrings are too tight that we can't do that. We have to do osteotomy. But once we do osteotomy at the subtrochanteric level, so then you can easily pull it down. Then you can construct the acetabulum also, and after preparing that, then you have to decide how much shortening you have to do. Even if you are gaining say 6 centimeters of length, hardly you have to resect 2 centimeters of bone, not more than that. So in fact you are going to gain length, but not bilkul ideal length you can never achieve. But already the patient was doing well with the pelvic obliquity, compensating with the pelvic obliquity. But again, then you are gaining length after bringing to the native acetabulum, and whatever left lengthening is left, that again can be taken care of by the pelvic obliquity.
So like we can say that they are actually overcompensated and they do well.
Yes.
Even after the osteotomies.
They do very well after osteotomy. The gait is improved.
Yeah.
The X-ray I showed you, the video I showed you.
Yeah, she was walking quite comfortable.
Yeah.
Thank you, sir.
Thank you.
Thank you. We'll
Thank you, sir.
Call the next speaker.
Yes. After excellent live surgery, may I call upon Dr. Rakesh Rajput for his talk on dual mobility, indications, benefits, and failures.
Right. So first of all, Shubhang still here. Thank you so much. I'm like a bad penny who keeps dropping in here. So dual mobility, indications, benefits and failures. So I think for revisions, there isn't much of a debate. Should we do dual mobility or not? And majority of you might be quite inclined to use it. But is there a role for primaries or not? So that's what I think we'll discuss most. So when Charlie was doing his low friction arthroplasty in Wrightington, and he was very successful with it, where he had a small head and a plastic which was not very good, and he managed to reduce the wear rate. But what he was having was dislocations, and this was an issue. On the other hand, in the same country near Nottingham, in the Norwich, they were doing with big head, and they were also getting good result. They were not dislocating, but they were wearing out more because the metallurgy was not very good at that time. So this guy, Bosquet, sitting in France, was trying to see if I can get hold of both this. France and England don't get together. They don't get along. So he wanted to do something in between, that somehow I can have the low friction of Chanley and the big head, and then prevent both the problems, one of the wear and the other of dislocation. So he got hold of this dual mobility. And so what you basically have in dual mobility is that you've got one head on which, let's say current day and age, you have a poly, which then articulates into a shell. So that was the original dual mobility. So you now have improved hip stability. Large diameter head will of course give you that. Jump distances increase. You have excellent range of movement and reduced impingement. But the DM also has gone through various phases, generation 1, generation 2, generation 3. And each one of them have improved to such an extent that I think wear has become very less now. And why do we want dual mobility? So first of all, we have to accept, do we actually have an issue with dislocation? And you ask surgeons and they'll say, my hip never dislocates. So I don't know then why then we keep talking about in the conferences. So the majority of fact, if you look at the English literature, which is I think one of the most honest literatures, there's 5% dislocation rates. And no surgeon will accept that he's got more than 1%. So either we are lying or some of our dislocations are not coming back to us, they're going to somebody else. I think that's probably the second part is I think very true. So we do have an issue with dislocation, where whatever approach you use, even direct anterior approaches have dislocations. And you got to accept that. And I have very funnily seen direct anterior dislocating posteriorly. I have myself tackled with 2 of them, so which is even more funny. So we have an issue. And if you look at even revision scenarios, all over, even this is I think Australian registry, dislocations are there. And even if it's crossing 2%, I think it's a fair thing, red flags are there, we need to worry about. And what is the issue with dislocation? First time you may get away by just relocation if you have a standard hip joint which is put in. Second, you may or may not get away. Third, I think you're not going to get away. So if you have repeated dislocations, you are ending up with a revision. And what's the worst thing about revision? If you have, let's say, septic revision, at least taking out the implants are much easier. If you have a well-fixed implants and then they are dislocating, on one hand, your mind's not very good if you've done it. Second hand, you spend plenty of time actually taking these out. So again, big nightmare, and you end up destroying more tissues than which were already destroyed. So today I think we need to think about giving stability to our patients, and these are our patients. So no more 70s and 80s, we are now beginning to get 30 and 40-year-olds. And if you look at the newspaper, anybody from Delhi, I think Dr. Tomar is here, 14-year-old, 15-year-old, 16-year-olds, and from Mumbai. I'm sure your state is also printing these newspaper articles, and even Nilen's state is doing about 18-year-olds, 14-year-olds. We've come to teenagers now. Imagine what these guys are going to do with these hips. So we got to be really worried about this. And then of all this, the beast we just heard about, and I think Dilban still doesn't understand this. So hip joint done very well, and looks absolutely perfect in every way, till this patient goes and has a spine surgery. And this is not anecdotal. This happens to all of us. I have got another patient who's basically 16 years ago had a hip joint and gradually developed back pains, and 5 years later he dislocated. So his back now has become absolutely straight. So it happens. It's not just it happens to Americans, it happens. And you bail this out just by a dual mobility. So dual mobility has a role in bailing you out from where the implants are well fixed. Just a small surgery might bail you out, but not all the time. So you need to make sure that everything is good. But this is what you're beginning to face this now. Look at these spines. So this is going to become more and more common to you now. So the use of dual mobility is increasing. So you see from here, 2013 to 2019, you have just gone from 5% to 12%, and look at the other one. So revisions, you've gone up to 30%. So 1/3 of your revisions now are DMs, and which is very rightly so. Again, look at another paper. So if you see, the constrained liners have got increased, the dual mobility have increased. This is 2019. Since 2019, the constrained liners are slowly going down and the DMs are going higher and higher up. So this is something we got to keep on track. This is the common DMs which are now available, and this is the market-driven forces from the US, because they want to put screw everywhere. So like, if the DM is going to be put in a revision scenario, your cup is not going to be fixing very well. So you require screw options. The original French designs were not giving it. So they have screw holes. Now when you put screw holes, you need to have a very hard shell. But then the DM, from inside you want hard, from the outside you want soft. So inside hard, another shell goes inside this one. So your liner goes in this. Then you have a plastic, and then you have a ceramic. So these are there. So this is, but remember, in all this you still need to have a good hip, a good functioning stem, which was functioning before. So you cannot have just a DM and having a badly designed stem. So these are the fair examples. Again, a hip, you don't know what is actually doing it. Bail yourself out. You don't know what the spine is doing. Now there is a disadvantage to it, particularly in the previous generations. They used to dislocate. So intraprosthetic dislocation was common. Wear was initially double, which has now reduced. So how are they doing? So at this moment, I think the wear rates are pretty good, but they were not very good just a generation before. Long-term follow-ups, I think, are coming now, and the French have got very long-term follow-ups. I think most of our hips primary is now about 20 to 25% are DMs. In France, it is about 80 to 90%. So you can imagine if those guys are doing it so many, they would have picked up problems if they had. French people have not picked up too many problems. So I think we probably are using the other generations which are coming from US and beginning to pick up these problems. So risk stratified, I think I'll just go quickly about it. So a lot of issues with dual mobility. And I think I'll just give you a few case examples. This is Iaa-Nhs pond, and this is a female. So female with neck femur actually becomes a candidate, and female with neck femur with hip fracture, elderly, becomes even more of an indication. So I'll just give you one more example, this one here. So this guy actually came to us and said that he is getting married, and the father-in-law has actually said if he doesn't sit down and actually get married, he won't be given, his daughter won't be given. So here we were actually ending up with matchmakers. So I don't know whether this is the right way to go, but this is what it is. So I think I'll just skip over now. So this is again a very dysplastic hip from a previous, this guy has got previous fracture, basal fracture which was treated. Again, you can see the implants falling off. And that's what. So this is acetabular fractures, very good indication for DMs. So I think I'll probably stop. I think I've gone overboard now. So I'll just stop here. Thank you.
Any questions?
So there was one article about the stability of these dual mobilities, and they have very specifically mentioned the same thing. The French cups that did not have screws, they were actually giving the good advantage of dual mobility. The moment we put in the liner, we are actually lateralizing the center of rotation, and their graph showed that up to like 36 mm head is giving almost as good a stability as the dual mobility with these modular systems is. Only if you have the 40 mm head, then your stability goes haywire for the sizes. So what is your take on this for these modular systems?
So my take is that if you see, you have to work with what company you are with. So if your company is only going to give you this American designs, then you have to accept that. Abilities used to give us that original French design, gone out. They're trying to come back to India now. That has been copied by Indian company. One or two companies have copied that, so that's available if you're okay with using that. Otherwise, you are, like if you're using Stryker, you're using Smith Nephew, Dupuy, you just have to go back to this, what I just said. So even if you don't like it, you don't have a choice.
I think the jump distance is the basic, like there is hardly any...
Because the moment you put liner, your head's getting smaller.
Yeah, it is getting...
So you're defeating the whole purpose for which you were originally doing it.
Yeah, that's...
But then the advantage is you can put screws, so you can make your cup stable.
Or you go size bigger than that.
Yep. Sorry?
If you have to go a size bigger.
Yeah, but... No, but you can't put
keep
a
bringing
bigger...
at the, that is not, I think, that is not possible. That shouldn't be the message.
There's one question from the audience.
Narendra.
Yeah. When modeler show there is an equal graph in dual mobility and standard. And when you will, whether you prefer standard hip or a dual mobility.
Sorry, I didn't understand this.
Yeah, when RI modeler hip is showing, in live surgery we have shown that regular hip and dual mobility both are showing the same stability. And then what you use?
So, see, you should only use dual mobility where it is indicated. For our patient today, one small indication could be hypermobile spine. We were at 33 difference between sitting and standing lateral, sacral stroke. So that becomes a small indication, but that's only a small indication. I'll tell you how stable the approach I did was. If I put a dual mobility trial, I can't get it out.
Yes.
So if you're going from anterior approaches, you put dual mobility trial, you can't even get the trial out. So that's why you have to put it one shot, all the implants in, then you don't know whether leg length you're okay or not. So I think you use it only when it's essential. Otherwise you'll struggle with leg length. Yeah, neurology, weakness, Parkinsonism, muscle laxity, elderly females. Yeah, so use only for indications. It's not for all. I had a slide, but I've gone short out of time, so I didn't use it. Where it's indicated, you use. Don't use it for all. Thank you.
Thank you, sir. Thank you.
Yes, circle.
I invite the next speaker, Dr. Chetan Sood, for his talk on DDA video, How Do I Do It?
Okay, good afternoon everybody, and thank you Dr. Shubhang for the opportunity. Before I just start the thing,
एक डॉक्टर अवतार ने एक लेक्चर देता सी मुझे काफी गंदा डेब्री निकलता है तो रिवाइज करो
just a question for the audience, how many of you are doing a DA or likely to do a DA? Okay, so then we have some people to talk about it. So I'll just talk about Sir, I started this about 2017 when I got some training on DA, but that time I was not a believer in DA. But now I do, but I don't do for every case. It's only for selected patients. But prior to my, presently I had the medical education effort by Merrill, but prior to that about 30 years I was in the army. And so common questions, couple of slides, then we go to the video straight away. That what's in the approach, we've already talked about that. There are so many approaches. Whatever works well for you is good. So I was doing both the posterior as well as the modified anterolateral Harding approach, and there was no reason to change. But still, there was an opportunity. I did the training, and then in my practice, I kind of found that there is a little bit of a mismatch. After doing the hip, I was not feeling like I felt like after having done a knee. So that was the kind of a thing I had in me. So see, the expectations which I expect from what a surgeon has from a THA technique, let's say if you want to shift, is what? It should give you stability, it should take care of your leg length issues, the outcomes, if you are superior, it should be reproducible, you know. That reproducibility was always lacking when I was doing a posterior approach, you know. And too much of expense or investing in a table. But the patient's expectations are always the same. They don't want pain, don't want leg length issue. This issue is also growing in our country. It's the largest cause of litigation in the West. And faster recovery, early discharges, these are there. So I thought that maybe DA, is the middle ground for all these things? So definitely the literature now, there's a little old one which I've quoted, but the literature now is very well clear that it has less soft tissue damage. They have done CRP levels and all that, but I don't believe in that, but definitely soft tissue damage. The pain is less and the dislocation rate, this again is a well done surgery, it doesn't. But in the learning curve or in multi-centric, there is a difference. Second big issue about the DA was, I think there were some barriers in DA. There were these barriers put by surgeons who wanted the tables or attachments to be bought, and these were the real big barriers. But now the US, it's about almost close to 45% where the DAs has been done by the surgeons. In my case, I use ordinary table. I don't need any of the costly table or attachments. And I feel it's far easier. It's very quickly to set up. That one takes a lot of things. You need to have a specialized assistant. You can check the stability. In that, you have to disengage and check the stability. So I think it's a far better thing to use a normal table. You can check the leg length. That you have to take an X-ray to check the leg length in the special table, right? So there is definitely a disadvantage, which is you need a second assistant, and there is a learning curve for the entire team. So if you have the good DA instruments, so when I started, we did not have. We got them imported from a company called DGO, which never launched in this part of the world. But definitely, if you can, so I'm trying to impress upon certain things that even if you don't have the proper instruments, you can still do it. But there is definitely a little bit of issue. So I'll just go to the surgery. So this DA on conventional, and some of the snippets are from the earliest times when I was doing with conventional instruments. So this incision is a small incision, 2 centimeter below and lateral to the ASIS. And if you have to keep it MIS, the advantage of DAS is if it's muscle cutting, it should also be less soft tissue cutting. So once you see the fascia of the TFL, and this incision you can place, but as you see the TFL fascia has to be preserved. This is the most important step. If you are careless with this, then probably you will never get there. You will probably do a Smith-Peterson approach and come out, right? So that's the most important part. You dissect the fascia, do a finger dissection, and in this thing you can create the interval between the rectus femoris and the TFL. Once you do that, you develop further, and this incidentally is a woman, so a lot of fat there and a lot of bulky muscle. So we'll come to the positioning and all, just a few photographs, there's a paucity of time. So I highlight a few things. You have to put the retractors first above the capsule and then shift them below the capsule, right? So that's the first retractor which goes in. You have made the gap, you put it and reflect the rectus femoris straight away. That's the leash of the lateral circumflex vessels. You see this is very important to ligate it. You can ligate it or kind of tie it out. And incision, now you can relook at the incision and make the incision bisecting this leash. The moment you do that, you'll see some fat pad. You remove the fat pad and then that capsular incision. You can do a T inversion or you can do the other one. So this one is one that now I do a inverse, the proper T. This was the invert T. After you have done this is the head. But if you try to dislocate now, that's the disaster. That's the reason when you fracture. Okay, so this step is very important. That's called the inferior release. And the end point of this release is when I can put my finger inside that pouch that I make. And this another release, this is a superior release, which is also important, and this helps you to dislocate the hip. The entire complications of fractures, which are very notorious in this case, this is a guide from DGO, but now it's not more used. So as you see, I took a measurement and I'm going to take a wafer cut. So I'm routinely doing a wafer cut. Whenever I have not done that, it was if the bone was very soft or a fracture neck, otherwise I've never done that. You take a wafer cut, that makes your life very easy. And while taking out the wafer cut, if you're not careful, then you'll probably tear the TFL. And this is another thing, this is the earlier days. So if you're again not very careful and don't snub that neck part, you'll again rupture the TFL. That's with another instrument. So I'm bringing this out that if you don't have the instruments, but it's better to have the instruments, there is little trauma more to the TFL. But if you don't have, you can still use the straight reamers. And there's a little, the problem is going to be when you go to the higher sizes. So there's a little snippet on that. When the higher sizes are there, then probably you have to put the reamer separately. So that's the modification you have to do if you don't have the offset reamer. But if you have an offset reamer, you may not need this step, right? So now we don't need the step. So if you do it, you can at times, and this is all to keep it small. Otherwise you can, even by increasing the incision size, the exposure doesn't increase, by the way, because it's a muscle sparing approach. So you probably have to do this kind of a technique if you're using a second. So that's the cup, and this is what we were talking about. There is, I do not do anything, just put it right on the face of the acetabulum, right? So impingement, I think last 2-3 seconds. That's the acetabulum, and that's the easier part. Now comes the difficult part, that is the stem. Delivering the stem is the problem, and if you are, again, this is the fracture risk again here, all right? So the release is, this is the most important release. You release the capsule, and the end point is when you see some fat there, otherwise you are going to cut the piriformis there, right? So, and this is usually the position, as you see, this is not a very good one, but you have to deliver the frame out. You can see the hormones kind of a thing, and the position of the leg, you have to bend the leg and break the table, and you can easily do that. This again without the offset broach, right? So, but if you have it, I think it's better to do that with the offset broach, right? So we go ahead and finally put the stem. The break required will be less if you use an offset stem. And I can confess, in one of the cases the patient had a bit of a spine issue also once we broke the leg, broke the table. So that's the corail stem being used. And finally, the proof of the pudding is in what you do. The stability, the way I feel about after DA is, I feel so good about it, you know. And the leg length, you can actually see the entire leg length very well in this. Okay, so last 2 slides. So this is one of the cobbler. Now this again, like one of the speakers said, his requirement was to sit on the ground, and that was his livelihood. And see, this is the patient on the first day. He's happy, he's not really limping. And this is in 3 weeks. And the guy sitting behind him is the one ACL tear at 3 weeks, same day they were operated. So that's one of the things. And with that, my confidence to do bilateral hip in the same sitting is now even more. Now this patient, he was a ex-army guy but joined the police. To the same sitting, bilateral THR with and you get bang on the same length, everything is kind of possible, especially because the bleeding is much less. So the functional is, this is the final function that he gets. And he is not given, or he never follows any dislocation precautions. So with this, I think from my perspective, it's not for, again for everybody, there is a learning curve, there is a complication rate. And the learning curve is for the entire team actually, not for the surgeon. Otherwise the complications rate is high. I do it for the younger people, and certainly they are quite happy so far.
Any questions? Questions?
Do you use Siam also, or you are happy just doing on your own?
No, I'm not using. Though I particularly make sure that the patient has come down, because you know there is a limitation. If you use it on an ordinary table, the patient, the break of the table has to be at the high level, just below about 5 centimeters below the trochanter. Then only to lever the hip up when you break the table. So the question that I'm not using the X-ray unless I suspect some fracture on the acetabulum side has to be. Otherwise,
we are on the learning phase. We find that the depth of reaming, the Siam gives us a good idea. Because we are not used to it, but you are used to it. But I think if you're a beginner, you always use Siam, because you can get the depth of reaming is very nice
but
impression.
But if you use a table, so you have to use a Siam. And in fact, where I got trained in the US, they had made a template. They used to just put that template on the Siam on a OHP sheet, and then find the leg length for TA. That's another thing. But acetabulum view, maybe you can cut the soft tissue or something like that.
Yeah.
Another thing is that we don't use the
nice presentation, excellent presentation that you have done. I just want to ask only one question. Why did you switch over from posterolateral to an anterior approach? Why? What makes you to do this? Because once you are accomplished, you are very good at doing posterior approach, good results, and then this approach has got a difficult learning curve, the specific instruments, and very difficult, and in the early stage of at least 100, you have higher complication rates. So what did you make to switch over from posterior to the anterior approach?
So as I said, sir, I have not switched over. I do it selectively. I do it for the younger people, and I think the benefit is for them. I've never done it for anybody less than 60 years as of now. And the reason that I started doing, as I said, when I went for the training, I was not really enthusiastic about DA. Once you start doing it, and I was in the public sector, you have the leverage to do a lot of things and you experiment. So you started doing it, then I developed that there is a case for this. And three things which are really solved with it: stability, leg length. On table you can see the leg length right there because both the legs are draped. But there is no issue. You can and the other advantages we had a discussion about robotic. When you're in a situation that you have to either use a high offset or lateralize or leg length, so that because it's a muscle sparing approach, even when I find that the leg length is, let's say it was 5 mm, which was bigger, I cut the neck again, I go back, and the stability doesn't change. I don't have to use a high offset. There's a high offset imposed on you because if you use the posterior approach, if you cut the leg length, and the same stability will come with a high offset, then the protracted pain will start. This gives you that leverage. It doesn't, the shock doesn't change.
In my opinion, whether it is anterior approach or the posterior approach, the length of the limb is related with the offset management only. Because limb length, if you have to have stability, stability has a greater role over that, only then we can achieve offset management, whether the approach is anterior or posterior. And by the way, just I would like to mention the dislocation related with posterior and anterior. I have been doing posterior lateral approach since beginning. The first case of THR I had done in 1994. And in 2002, I did bilateral THR, 2002, with posterior approach, 2002. It was not accepted then, 2002. It got accepted in 2003. And since then, I have done numerous cases. With my confidence, I do posterior approach, changing the position in between, no dislocation, never dislocation, and your limb length, and this thing is based on your templating prior to this surgery, and then offset management. If you have got the adequate kind of implants and the various offsets you have, so there won't be any lengthening. But if you don't have that and in a very shape and you try to do that, then you have to have limb lengthening, otherwise it will dislocate.
That's agreed. So I was trying to make the point that if the native is not a high offset hip, then in any other approach, it will be imposed on you to put a high offset. If you screw up the leg length, you probably have to get the stability by increasing the offset, and that's the teaching.
Thank you, sir. Thank you very much. The debate goes on, and I
think there is one more issue into this is the peer pressure.
No, so, I'll put it another way.
Because if my neighbor does it,
some people stay,
I'm imposed to do it.
Some people stay young for a longer time. Like we have the enthusiasm to do new kind of surgeries in early post-PG days. So I just envy this group who still have the energy to experiment a new approach when they are doing excellent with the old one. And this must live on, because then only we invent new things and do good things. So we'll call upon the last speaker for today, Dr. Narendra Parmar, for the preoperative planning and templating in THR.
So, by the time Narendra is coming, I'll tell you, just day before yesterday, I had a patient who came in, said, sir, I want a DA approach and I want from a bikini incision.
Oh.
So, even the patients are well read now, and they are looking up all this Google, best tip, and then this is what comes up. So what will you tell that patient? I don't do it?
On social
it's
media.
happening.
Yes.
So
on social media platforms like Insta, it is being promoted like anything.
So I have started doing DA, and I still can't tell her that I can't do with a bikini.
Yes.
But are the patients who are now, even in their 55, 60s, they want to play sport, they want to play tennis, they want to play golf. I mean, how right are we to put them dislocation precautions?
No, I think after 3 to 4 months, all approaches come back to same. So I think it's only in the beginning we are talking about. There's enough evidence now that after 6 months, they're all same.
Sitting there. So it is not the head size only, because Chanley was using a smaller head size. But it is based more on the inclination of the cups and the stems.
Yeah, I think
So since
surgery is almost over and now we are just going reverse.
So since we are clubbing the next session, I'll just request Dr. Sandeep Gupta to join us for the moderator.
I think I will not go little detail. Everything is discussed in spinopelvic and everything. I think dislocation is multifactorial, as Dr. Nilen Shah has told. Why primary hip is not getting dislocated and replaces it getting dislocated. So only soft tissue will only not act. Only implant will not play a role. Only spinopelvic mobility will not play a role. Each and every factor has certain role in dislocation. So whether direct anterior, sometimes direct anterior is same, sometimes is FOMO. Many people in direct anterior approach showing video that patient is doing this and this, but posterolateral approach patient are also doing same thing. That I will show you few of my patient. And as Dr. Rakesh Rajput has already told that whether you are telling that your AP is not getting dislocated, then you are telling lie. Each and every surgeon had a hip getting dislocated, whether your numbers are lie, because our general hip registry and knee registry is not favoring our data.
So I beg your pardon, but your time is on.
Yeah, as this institute where I am working at present, the Nirali Hospital, the one first presentation of the patient with hip complaint, what all thought came to your minds? Whether this is true hip pain or whether it is spine related pain or something else or what. So just I think, aged patient around 75, 80 years, primary basicervical neck femurs, what preoperative thinking we should do? Whether templating, whether this X-ray is enough for us or whether we want to take further more X-rays here. Okay, what Dr. Rakesh Rajput is doing in primary hip replacement many patients. Whether you want to take anything.
For me, this is bipolar.
Bipolar is there. Yeah. Surgeon has done these things. Is it okay? This looks okay. But I think we should keep lateral abductor reconstruction for plate also should be keep ready. That should be keep in mind, that my idea. And ideally we should take the full length X-ray. So whether Doe type canal A, B or C, that should be finalized. Primary we are taking X-ray in such size. After ending, not taking full length X-ray. So we miss the canal diameter, door A, B or C. So it's door A type canal. So reamer should be required on table or either go for cemented. This will be early failure after a few years, maybe. Same year, full length X-ray is not taken. So always take preoperative full length X-ray, AP and laterals and avoid this complication. Again, full length X-ray is not taken the surgeon. See, stem remain out the canal. Yeah. Again, full length X-ray is not taken surgeon, not done preoperative planning. It's Doe type A. Surgeon on table started struggling, getting more fit and fit stem and ended up with this. So, again, surgeon revise the hip, not keep every instrument ready on table, lateral plate and everything. And surgeon does this, not reconstructed abductor mechanism. So my idea, before when you are looking on the X-ray, you should plan everything, not only hip center, abductor mechanism, what implant you should plan, canal diameter you should plan, everything, same year. Doe type A canal, surgeon has not planned properly. See the outcome. So, why THA still fail? Instability, accelerated wear, limp and dissatisfaction or early, maybe lead to early revision. So as I told, THA is biomechanical reconstruction, center of rotation, femoral offset, leg length, soft tissue balance, everything should be reconstructed. Imaging,
static to function, spinopelvic, I think very much described, so I will not go into the details, everything. But take standard AP view, standing pelvis and a sitting pelvis lateral view. Issue with the door type A. This is slide from Dr. Vijay Bose I have taken. This diaphyseal catch. This is nowadays a big issue. Diaphyseal sketch. Metaphyseal undersizing and diaphyseal sizing. That will lead to failure after 4 to 5 years, sometimes 7 to 8 years. Early aseptic loosening, many times. This funnel type canal is there. So always keep the reamer when you are sizing. When you are choosing the size, stem size A, B or a smaller one, always look at the canal and look after that, whether it is metaphyseal fitting or not. Metaphyseal loosening and diaphyseal fitting is there. Spinopelvic parameters, I will not go in the detail. Acetabular safe zone, everything that we had discussed already, that zone. And femoral offset is the key to make the patient happy. So offset restoration is the main thing. Stem version, that is fixed and cemented, that you can't play a major role in that stem fixations. So, and templating, that is the most important part. Templating is the preoperative planning process where prosthesis size, position, alignment, offset, LLD, everything should be planned accordingly. Today in live surgery, we plan cup around 52 and on table it is same, almost 52. Stem size is almost 2 and on table it is always 2. So that is how templating is helped without using any technology. Imaging requirement, standard radiogram, AP pelvis and lateral APU, calibrated marker also required. Key image in principle, true side X-ray is mandatory. And calibration marker, reduced magnification error, consistent patient position and calibration processes. Nowadays digital templating workflow is also available, TraumaCAD, Medicad, hip match, and digital has some comparatively superior outcome with accuracy, reproducibility, calibration, everything. So, and system also will, robotic and Cori system, Mako system, all will be in planning and computer assisted technology. This modeler will give all idea regarding clinic. And so ultimately from implantation to restoration, planning at the end of day help. This is my post-op X-ray, robotic THR has done. This is I can't, video is not playing I think. So it's okay. The bilateral hip done same setting, posterolateral approach. My surprise, this patient is walking without stick on the day of discharge and doing staircase climbing and everything. But all patient will not do like this. So, thank you. Ultimately, combine approach matter, not approach, not implant, everything matter. Thank you.
Thank you, sir. Thank you very much.
So join.
We'll request you to join for moderation of the next session. Dr.
Now, we begin with the session 3, which is on the talks, complication and decision making. I would like to invite the session moderators, Dr. Sandeep Gupta, Dr. Narendra Parmar, Dr. G.S. China. Also, I would request the speaker of the scientific session to kindly be ready to come on the stage afterwards.
The first speaker is Dr. Iqbal Singh Hai, and he'll be talking cementing techniques in THR. Get it right the first time.
ये तो अनसीमेंटेड का ज़माना है, तो ये सीमेंट कहाँ से आ गया? So this talk is mainly for young surgeons who have not seen the cementing one and going for the uncemented always. In these 7 minutes, I will be covering a basics cement, bone bed preparation, mixing and delivery, preservations, then safe working environment, expecting the unexpected, then cement other uses. And for a good cementing, the three things they are there. One is the technique, other is the bone bed preparation, and third is the surgeon. If all the three things they combine together, they will give you a good result, good fixation. And anything short of that leads to failure, and the surgeon is blamed for that. Coming to the basics, this is two things. One is the polymer, other is the liquid monomer, and zirconium or the barium sulfate is added for the radio opacity. Coming to polymerization, there are the four stages: mixing, pickup, working, and the final sets. And important factor for cementing is, number one, temperature of your OT, humidity in the OT, then type of mixing you are using, either this is as such or this is vacuum based, then how you handle the cement, either you are handling manually or you are using the gun for that. Variation in the setting time, it all depends on the company person, how they are storing the cement, what's the shelf life, and in theater where they are keeping in the open or keeping in the refrigeration. So there are two types of cements available: low viscosity and high viscosity. The low viscosity, they are more fluid, they are running, they have longer liquid phase, require waiting for the duff stage, easier to inject through the narrow nozzles, better integration due to lower viscosity. They have less control on the application, may require the more careful pressurization. Then risk of cement leakage is higher as compared to the high viscosity, and this is used in vertebral plastic where the high viscosity is not used. Coming to the application for the first of all bone bed preparation. This is only effective if there is micro interlock between the bone and the cement is proper, then the things will give you the result, otherwise no. Use of the pressure pulse lavage and the brush system to reduce the incidence of aseptic loosening. Then curettes and the knives, they are going to help, but the results are not that as good as that of pulse lavage and the brushing. And in that, first of all, we go for that reaming, we go for brushing, lavage, cement restrictor is used, that is up to the femoral canal system. And coming to the acetabulum side, for the cement, we are to give the holes for the cement to go in and fix there. This is, and key is to preserve the cancerous bone to provide you the good micro lock. Reaming, shape of the femoral canal and the acetabular cavity, it will give you a better, you can say, picture and better fitment. Preoperative planning is, helps. Then preserve the cancerous bone. Don't remove the cancerous bone as such. Go on removing, go on, that this is coming out, then you will lose everything. And last of all, in the acetabulum, must preserve the tail. Then brushing, both the acetabular and the femoral, this will reduce the loose, this will remove the loose cancerous bone and the soft tissue. High pressure lavage produce the clean surface, and this prevents the circulatory changes also. Both these reduce the high risk of lamination in the cement that can decrease the strength of the mantle by 8 to 16%. And this I am giving you the picture. Are you having the? On the left hand, we put a restrictor and then brushing is done. Okay. On the right side, you can see the picture before brushing, and on the left is, on the right is after brushing. So if there is some cancerous bone, the cement will go inside and this will give you a better interlock. But on that left side, the red one where the blood is there, everything, this is not going to give you a better interlock. So this will result into failure. Same way,
coming to the femoral side, when you give a restrictor, then you put the cement with the gun. That gun, when the cement goes in, the gun will automatically come out, and this should be so. Then the pressure is exerted on all the walls of the canal where the cement goes in and gives you the interlock. And on the acetabular side, we create the hole. Minimum 4 to 6 holes are required, and the diameter hole should be minimum of 4 mm. Then how you prepare the cement now? You put that monomer in the that powder form. Initially, in initial 30 seconds, it looks that your liquid monomer is less, but no. Wait for another 30 seconds. Then hairy strands starts forming. Then this liquid is glistening type. After 2 minutes, the strands are no longer formed and the shine disappears. This is now, you can say, dewy consistency, and this is the start of the working phase. Now, vacuum mixing, this prevents the air entrapment in the cement. This reduces the cement porosity, and so it increases the strength of the cement. How you now take it? One is the hand picking, other is the gun. In the hand picking, you made a rough cylindrical mass, then pack it. The mechanism is called thumb and the finger maneuver. You put that cylindrical cement inside, push the thumb this way, it will push the cement again. Remaining part of the cement is covered with your index finger, then the thumb pushes that. That's the manual thing. And the gun, this ensures the delivery under pressure. Inject the cement in the retrograde fashion, then pressure of the cement that pushes the gun out. Swedish hip registry has shown that the retrograde cement filling using the cement gun in the femur, this reduces the risk of revision. Then pressurization, this involves the use of cement gun and the special pressurizers and the centralizers. Afford the greater penetration into the cancellous bone. Then optimal viscosity is a key to the greater pressurizing. In the femur, the sweating trochanter sign should be seen, means that you are giving a proper pressure to the cement and the cement that goes into the cancellous bone. So this is the mechanism of putting the pressure in the acetabular and putting the pressure in the femoral side. And this is a step with the gun, first put in, then giving the pressure is given, then implant is taken in and pressure is applied till it gets hardened. So it can be used in tumor cases, TKR and antibiotic loaded beads also. Safety, this is very important. Liquid monomer is very volatile, it's inflammable, and it's a powerful liquid solvent. So avoid contact of the liquid with the surgical gloves, skin and the mucous membrane. The fumes, they are coming after polymerization. They irritate the respiratory canal, eyes, liver, hypersensitivity and the contact dermatitis. Even contact lenses, they are having problem with the fumes coming from the polymerization. So word of caution, premature insertion of the bone cement that leads to drop in the blood pressure, arrhythmias may or may not be there, or ischemia of the cardiac elements are there. Then expulsion of the bone marrow in the osteoporotic bones, this is also seen. Then inform the anesthetic prior to the cementing that the minimum 30 seconds to 5 minutes before going for the cementing. Thank you. And I invite you to the CCT 2026 that is to be organized by our department in 1st, 2nd, 3rd May. Please come there and enjoy our academics and the hospitality. Thank you.
Any questions?
Okay, thank you.
So, do you have the brush with you?
Yeah.
The brush?
Yeah.
What brush is this? The company doesn't supply it.
It's a local made. Yeah.
Because they break and stay inside if you're using very ordinary brushes.
Till now, we have not suffered any problem. We have seen the brush. After the brushing done, again we inspect the brush. The bristles are there or not. That's just you can say bottle brush. Have you seen? That's a minimized form of that. Bottle brush.
So is that commercially available?
Actually, I haven't get it made from a person.
How many
It's not-
cement reaction are there in your cases?
So that is there. They are there. You
How
can
much-
say
how
5 to 10%.
How much fatal is there? On table, any mortality?
One. I'm fair to say this thing, one.
Because I had stopped doing cementing that just because of that. I had
But,
2 or 3
but that was a very old lady of 87, 88 years.
I asked the Exeter guys once, in India we are getting cement reaction. Then they answer my question in one word, change your anesthetic. But I think...
But sir, frankly speaking, the cemented hips, they are still working very well. That was done by my boss, my guide, Dr. Sunny's father, Dr. J.P.S. Sheena, and that was the Charlie hips. And till now, the people who are live, they are doing well.
Without dislocating.
Yeah.
Nayendra
Because
sir.
that was done by a great surgeon,
So-
who was my mentor.
I'll come back to your cemented hips. So for all this elderly where we used to put cemented hips and BCIS as the term was started, yes, there is a small incidence of BCIS, but it's been overplayed mainly by the American literature because those guys don't want to put cemented hip, and to promote their own uncemented hip, this was being subjected to. That's why a lot of guys all over the world moved to, like you, moved to uncemented stems. Now, first of all, the BCIS has been taken down because of the anesthetics. That is exactly what the Exeter guy said. So if you maintain your systolic, not 100, but 120, when the cement is being going in, well hydrated and well oxygenated, these patients don't get BCIS. Number two, that when you are moving to uncemented stems, you see the amount of loose stems you will actually put in these wide canals. And another one, that you cause periprosthetic fractures. Now the revision surgeries will definitely kill some of them. So you actually outweigh the balance which you have lost with a cemented stem. With the type of uncemented stem, it's balanced out. But the grip and function which you get with the cemented in elderly population, you don't get. Now if you see the current American literature, slowly again moving back to cemented stems. And some of them put their hands up and say, I have never done it, but I really want to do it because there is a trouble with uncemented stems.
Very well put, Dr. Rajput. I think the debate can go on. Let's move on to the next speaker, Dr. Anupam Mahajan. So he will be telling us about intraoperative fractures in THR
So
and
we
its
have been
prevention.
talking since morning about dislocation, but 5% rate. How many have had intraoperative fracture?
I think all.
Everybody. So we are not lying there. Okay? So why is it important to know? Actually, it is the revision THS goes up to 30%, 4 to 30% is the literature which says, and in primary also it is around 5%. So 0.1 to 5% is what literature says is the fracture rates, intraoperative, not post-operative. Periprosthetic fractures, we are talking intraoperative. Ephemeral is the more commonly involved, 2 to 5% with versus acetabular. Why are they important? No, because they are associated with increased morbidity, increased operative time, worse functional outcomes, and higher revision rates. So these are very important to understand. So this fracture, if it happens intraop, is more deadly for us. So what are the risk factors for this intraoperative fracture to happen? We have patient-related factors where we looking at the pre-operative X-ray, so should tell us that it is osteoporosis like type C femur, female gender, rheumatoid arthritis, previous proximal fever surgeries, TH, post-traumatic. Now these are cases, if the patient comes to us, surprisingly female gender, I think there was a dislocation also, somebody was talking about female gender, I don't know what is there, but these two, osteoporosis and female gender, causes these things. Then that was patient related. Now surgical related factors, Anterior and lateral approaches are more commonly involved because of the learning experience. Inadequate exposure. We keep struggling through smaller incisions. My teacher, mentor used to say, bigger the surgeon, bigger the incision. Now we go to bikini incisions, like sir said. Bigger the incision, bigger the surgeon, bigger the incision. So aggressive broaching, undersized femoral canal. So these are the surgical risk factors. Then there are implant-related risk factors, which are cement lens stems, taper wedge stems, extensive metaphyseal fill, and on the acetabular size, large press fit acetabular cups. So we tend to under-ream the acetabulum and press fit with a bigger cup. That can lead to fractures. So what are the prevention strategies? First and foremost, we said osteoporosis. So we do the bone quality assessment. We see the DEXA scan, cortical thickness index, and also see the DORS classification, whether it is a A type, B type, or C type. So whether it's a champagne flute or the stovepipe. So based on that, we should before surgery also think in mind that yes, this can have intraoperative fractures. So how do you manage this osteoporosis? Consider in a DOR type C cemented fixation rather than an uncemented fixation. Keep prophylactic cerclage wires on table. Many of us do not have that armamentarium on table. We just get the hip and then we are searching for plates and cables and everything there. And avoid aggressive press fit. Pre-operative planning, there was an entire session on this. It is everything in the game. Unless you plan, you fail to execute. So digital templating is now there. You identify narrow canals, assess for the bowing. Many of us have seen the tips touching either the anterior cortex or even perforating the anterior cortex or the lateral cortex when we fail to assess the bows. Then there is a leg length planning and anticipate need for cerclage. In templating, avoid oversizing, check metaphyseal versus diaphyseal fit, offset planning, identify stress risers. So when we are seeing, we should not overstuff the femur because those are more commonly fractured. So what are the management strategies or prevention strategies for the femoral side? Surgical approach, we said lateral or DA or versus posterior is relative risk is 1.5, that is literature quoted, with a confidence interval of 1 to 2. And this is mostly because of learning curve impact and exposure quality. Femoral exposure principles, the first and foremost principle, whether it is any approach, adequate soft tissue release. Unless we release, we saw that in the direct anterior approach, sir also showed, unless you release, you will lead to fractures. And proper limb positioning, avoid torsional stress during broaching. What is a broaching technique? Do not skip broach sizes. We can't say, I am a great surgeon, I know, I will not do 1, I will start with 2. Do not, even if you have templated, start from sequential broaching, avoid skip sizes, avoid mallet overuse, right hammering technique. We all have a habit of using our shoulder. It should be just the wrist which you should be tapping. And stop at change in pitch, respect resistance feedback, and avoid varus positioning. Think of cerclage wire if there are cracks during broaching or severe osteoporosis on dysplastic femur. Do not think that there is a crack, then I'll do it. If it is severe osteoporotic, there is no harm in doing a prophylactic wiring. You can either use cerclage wires, stainless steel wires, or dial mount cables. Then avoid varus malposition, which increases calcar stress, leading to predisposing to calcar cracks. Trial reduction, once you have tried to reduce it, check with manual traction if the tip reaches the center of the acetabulum. If it is not reaching, then you need to release further. That means if you try to reduce the hip, if the neck is not, where you are putting the head, it's not coming into the center, it will tend to cause force and causing intraoperative fracture. Avoid excessive torsion. In the implant insertion, stop if there is sudden give way. Confirm the seating depth, check with fluoroscopy if required. Check for the tip. Many times we have been surprised finding, we thought that the stem is in, but it has been out. Check in both the views. For the acetabular fracture side, again, adequate exposure. Here, what is more important is the retractor types that you should have on table. Today we were saying, Dr. Rajpur sir also struggling, saying, "Mere paas wo anterior retractor is not what I use." Right, sir? Even morning, Manit was saying, use this type of retractor for the glenoid. So, unless we have adequate, proper instrumentation, we have this intraoperative fractures. Now, what is the problem with the normal human? When you could give excessive force to, especially in the anterolateral or the lateral approaches, if you use excessive force, the human pierces into the acetabulum and causes wall fractures. So this is very common. And I have seen one of my own hips, bipolars got dislocated because it caused a posterior wall fracture, which we missed intraoperatively. So reaming principles, we should follow what is the native acetabulum. Do not over ream, because jumbo cups may be in fashion but can cause pelvic discontinuity, and preserve subchondral bone. Cup insertion, avoid excessive impaction, avoid eccentric seating. Wherever it is proper in the centric position, do that, and use screws in poor bone. In revision THA cases, they are higher risk because of cortical thinning, stress risers, and previous screw holes. Do not hesitate to do a proper trochanteric controlled osteotomy in a revision case. Protect the distal cortex and use cerclage cables. And principle of long stems are there. Bypass the cortical effect by 2 cortical diameters at least. Avoid hoop stress concentrations. And intraoperatively, always recognize a fracture, sudden loss of resistance, a crack sound, stem instability if you are not finding it stable, even with 1 or 2 if you go size higher, or unexpected subsidence. So you've hammered it in, but it suddenly goes in. So that is why you suspect an intraoperative fracture, and there is no harm in revising it. So immediate algorithm for treatment: undisplaced crack, cerclage, continue the surgery. Displaced, revise the stem. Instability, longer stem. So this is a simple algorithm that you do. Many times, I don't know how many, I can vouch for 1 or 2 cases of mine where I've often missed intraoperative cracks, but if they're just cracks, you can just delay the weight bearing and just think about it. So 10 commandments to avoid fractures: respect osteoporosis and DOTS classification, template every case, avoid adequate exposure, never skip broach sizes, listen to the pitch change, avoid varus, protect the osteoporotic bone, use cerclage wherever you feel necessary, avoid forceful reduction, be cautious in revisions, and when in doubt, revise safely. So I just end my talk with these 10 commandments to avoid an intraoperative fracture causing problems to us.
Thank you, Dr. Anupam. That was a very comprehensive lecture on intraoperative fracture management and prevention. I don't think so there would be any questions on this. If anybody has a question, we can have a time for one.
Just like you said, in femur you'll delay weight bearing. What if you have a small crack in acetabulum, like you sometimes see on the anterior column? What do you do with this?
Sir, there are, acetabulum again has classification. There is a unified classification now. So if there's a wall, or if the column is there, you can just put a percutaneous screw if you're feeling it is unstable, because most of the weight bearing is from the posterior column, not the anterior column. So even when we fix pelvis, so even if we do a good posterior column reduction, even with a transverse fracture with a posterior wall, even if there is slight anterior the alignment is mismatched, we don't do anything, sir. And column means if there is no instability of the cup. If there is a cup instability, yes, you have to revise, sir. Instability will mean there will be transverse fracture or a T-shape.
Dr. Rajput, I get a feeling you're getting to something. I would like you to delineate yourself. What are you getting to?
It has happened to me.
I know, I have seen that case.
You can put an retrograde screw.
Once you've done actually cup inside a acetabulum, you've reamed out inside, so there isn't enough space left to actually put a screw. There is no space left anymore.
Sir,
so you need to, if you have just a crack and it's less than 2 millimeters, you observe these patients, delay weight bearing. As just you said with the femur side here, and you watch this crack very like a hawk. If this crack starts opening up, your cup is unstable. You need to go back and revise it. But
Sir,
if it stays like that, you're okay.
Sir, can I just add? Because we have this habit of putting bigger screws into the anterior ramus, the superior ramus. We can even put a 3.5 mm screw. That equally holds good. I was in Thailand doing the fellowship there. And when I saw them, they used to bend the 3.5 is a beauty. It bends and goes into the...
But Anupam, they put the screw before they put the cup. That's for fracture cases.
Afterwards.
You created a fracture and then you're doing it.
Yes. In normal acetabulum also, pelvis also, acetabulum fracture, if there is an anterior column injury.
Oh, that's a different thing. But once you've reamed the whole thing,
yes,
there isn't space left actually. That's what I was saying.
Yes, you can do it. Sir, 3.5 is hardly a small screw. It can bend and go in.
I think we can discuss it in the dinner, Dr. Anupam and Dr. Rajput. We move on to the next talk, infection prevention strategies in arthroplasty, Dr. Sanjeev Gupta from Jammu. This should be interesting.
Thank you. It's just going to be basic talks.
That is always his first comment. And then you see what he says.
I work in a government sector, and the way we do things is a lot different than a private sector, where everything is very well organized and everybody knows what his role is. In government sector, I have to do a joint first, then maybe a trauma case. So all the cases need to be done. A lot of confusion is there. NO nahi aaya. Like yesterday only, I had to do a knee replacement. MTS ki strike thi. So the problem was the people didn't know how to organize the table. So these are small things which we keep facing. And then there's a lot of problem of overcrowding of the staff. We have a lot of PGs, interns, trainees, MTS, everybody wants to come into the OT and without actually knowing what the OT discipline is. Then we have the reps keep changing from time to time. The wards are not very well organized. MRI Sekha, there is no concept in the hospitals. So this is one case I did, 75-year female, fracture intertroch, straightforward. PFN was put. So this is 3 months down the line. So some surgeon tried to remove the implant, failed to do it. So came back to me and she wanted only the implant to be removed, nothing else. I said she needs a THR. They said no, we don't want it. So I removed the implant. Before this, there was a lot of discharge from the wound, so I thought it's good. We removed the implant and debridement was done. So then after that, the patient, as usual, left to another colleague who did a debridements, 2-3 debridements, and then he said, let's go for a hip replacement. So after this hip replacement surgery, there was a fracture there. Then that was revised. Then the patient had a dislocation. Again revised. So this is the final picture after so many surgeries. Patient has been deprived of all the money and all that stuff, and she's lost faith in the system. And this is what she is now. She remained in the ICU for a month, and now she is stable, having a Pseudomonas infection. So, and she is having her wound care being done regularly, and doesn't want to come to the hospital. So a simple fracture ended up with this disaster. Whole family shattered. So I think a lot of mistakes. The surgery was not planned well. I think most of the surgeries. Implant removal is not easy. We tend to remove the implant without actually many of us knowing what company implant is there, and we struggle in the OR. Then team involvement is never there in the private, in the government sector especially. There is no team involvement. We hardly call the microbiologists, pathologists or radiologists. Stent implant removal protocols are not followed. Implants are put for various reasons, even when the infection has not been eradicated. And many of us don't refer to a colleague who can do a better job. So we don't need, we should know our limitations and refer accordingly. Anyways, so joint infections, their treatment cost becomes enormous when they get infected. Infection is the most expensive complication in hip arthroplasty, and it revises lives actually. So infection rate is low but devastating for the surgeon, especially he has got sleepless nights, and patients lose trust and their mobility is reduced, and financially also they're down. So prevention is a continuum, not a step. Most infections are incubated before the incision is actually made. So the basics, especially government sector में किसी को patient आता है जैसे वो THR without any workup, इससे पहले कि patient कहीं और चला जाए भाई operate कर दो जल्दी से. So they are optimized, even without optimization they are operated. So basics have to be followed. Diabetic control should be there. BMI should be good. Anemia should be corrected. Malnutrition should be addressed. and remote infections should be looked for and treated. Screening and decontamination is again very important to prevent problems in the future. Antibiotic timing is very important. Again, many times surgery has been started but the antibiotic has not been given. So timing of the antibiotic before the surgery is very important. OT discipline and traffic control, preferably a laminar OT, limit door openings. This is very well established in the corporate sector, but in government sector this is a big problem. Personal restricted, we don't end up restricting the personal movement. Unnecessary equipment is there in the OT. The team members need to know the roles very well. Again, the team members keep changing, so the surgeon should be humble enough to discuss with the team members exactly what his plan is. I worked in various kinds of sectors. In private sector, surgeon he doesn't even have to put his hand behind. Everything is coming to his hand. Whereas in the government sector, पीछे देखना पड़ता है, staff को पता ही नहीं चल रहा instrument कौन सा कहाँ पड़ा है. Then the implant is not ready. So multiple issues are there. The implants have to be arranged very well, as Dr. Anupam rightly said. The company rep also needs to be briefed so that the things are arranged well in time. All these things actually end up reducing our surgical time, and that is how we invest in prevention of the infection. Again, white drapes are important to be draped. Skin prep should be proper and it should be allowed to dry. Again, we tend to just prep and immediately drape. Double gloving, again very important. We should respect the implant sterility, minimize the implant exposure time. The tray, the OR table, the trolleys should be covered. No implant handling should be done without the fresh gloves, preferably, and gloves should be changed at regular intervals. Avoid contact of the implant with the skin or drapes, and as I said, backup implants is a must. We should respect time, tissue, and the technique should be good. We should reduce the operative time. Gentle soft tissue handling, adequate hemostasis, avoid dead space and hematoma. The layered closure should be very meticulous to avoid dead space as it becomes a space for the bacteria to grow. Use drains and dressings wisely. They should be removed, if at all the drains are put, they should be removed well in time, at least 24 hours. I have seen in my working, sometimes the drain has not been removed for say 2 days. So I'm sure it must be happening at many other places as well. So maintain sterile dressing protocols, because every extra day of drain is an extra risk of infection. Maintain vigilant post-op surveillance. Continue antibiotics for 3 doses. Monitor wound soakage, erythema and discharge. I am very particular on this, especially the dressing should be seen by the senior persons. Many times the early signs of infection are not picked up, and then that ends up as a disaster in the follow-up. So early detection prevents deep disaster. So just to summarize these various points, behind every infection there is a patient who has trusted us, a family who has invested hope in us, and the surgeon does not want to replay the surgery mentally by facing these complications. Periprocessor infection is the only complication where even a technically perfect surgery can still feel like a personal disaster to the surgeon. In hip arthroplasty, success is not when the implant lasts, it is when infection never begins. Thank you.
Thank you, sir, for a wonderful presentation. Any questions?
It's always wonderful to listen to you.
Thank you, sir.
Because I think you speak from heart. It's a very few people actually pick up these topics and speak the way Sanjeev does. Just want to ask you, there was this saying when we had this international consensus meeting that potentially every wound is contaminated. It is just that some of them luckily or unluckily actually become infected, but all of them were contaminated. What do you feel actually in your own heart? That is it that only few get contaminated and infected, or all of them are potentially contaminated?
I feel all of them are potentially contaminated, especially again I refer in my government setup, sir. We get patients who don't take care of their hygiene, wearing the same clothes, they're using the common public toilets, using the wards, एक bed पे 10 लोग बैठ रहे हैं. So I believe that all of them are having bugs on them, and I actually segregate them, work them up for the surgery, and admit them only a day before surgery.
Another thing that I would add on to it is, if you see, many of the people have their masks below their noses, and the commonest source of MRSA carrier is a nose. So when I see my anesthetist or somebody say with a mask down their nose, I say first put a swab in your nose and get it tested with MRSA. If it is MRSA negative, then you can come here.
So literally I end up, मेरे OT में से crowd को मेरे को push out करना पड़ता है हर बार. Every time the anesthetists, most of them are females, they are flaunting their hair. You rightly said, उनको बोलना पड़ता है कि please अपने बालों को cover कर लो. So these are technical problems we face. We end up making enemies there many times. Yes, sir.
Excellent presentation, Dr. Sanjeev.
Thank you, sir.
One comment and one question. Like you said, 7.5 HbA1c. So what is your limit? Like if some patient comes with 10 HbA1c, what will you do if patient needs surgery, if a replacement surgery?
Sir, I involve the endocrinologist, at least get the sugar right. I delay it for a few weeks and try and avoid it, sir, as much as possible.
No, patient wants surgery. Like our protocol is, like we send the patient to endocrinologist, the treatment for 2 weeks time, and then they check for serum fractional level rather than HbA1c level, whether it is 10 or 11, whatever. But if serum fractional level is well within control, we safely can take the patient. Number two, comment is for OT traffic and laminar airflow.
Yes, sir.
So laminar airflow is not very good because OT environment is never bacteria free. There are bacteria always. We can reduce the concentration in the environment. We can reduce the concentration with the number of people there are inside the operation theatre. But whenever there is one entry inside the laminar flow, so there is a gross turbulence in the air and it settles down in 6 minutes. 6 minutes. If you continue, traffic is continued there. So laminar flow is even worse than without any laminar. So whenever there is continuous air traffic, so we should refrain from the laminar flow, because laminar flow will cause more infection than if the doors are not properly closed or doors are frequently opened at the rate of like 6 minutes. Because it takes 6 minutes to set for the settling down of the turbulence.
I think all the points are well taken. We can carry on this discussion at dinner and drinks, and only Dr. Shubhang is between us and dinner and drinks.
Can I
Yeah,
ask
yes,
one
sir.
question?
Please, the last comment, sir. Hanji.
What is the consensus whether we should have modular OTs or not? OTs for joint replacements.
We should have modular OTs, but modular OT is probably one of the many things which we can do to prevent infection, and is not the only
Sir,
thing.
Yes. It is not just about having them, it is about maintaining them.
Yeah.
You can have a very good HVAC, but we do not see filters getting changed. I am also in a government
That's
setup.
the challenge we face actually.
We have HVAC with us, and you will be surprised, in 1.5 years we could not get it replaced, HVAC filters. So now I have made it mandatory. So these are the problems, sir. And in fact, those who are even working in private, they don't know when the HVAC filter is being changed.
Sir, we can keep on discussing this, and let's move on to the next. Thank you, sir. Thank you so much for a lovely talk. Dr. Shubhang Agarwal with the PROMs and audits.
We are doing it 6 months or 1 year.
Very good evening to you all. Thank you for tolerating.
How do you know?
So far, the post-lunch session, we've had a very good run and 2 excellent live surgeries, and I will not keep you from the liquids that you want to get to. So I'm going to talk quickly on PROMs and audit. So we've spoken a lot about robotics, about we've had discussions on dislocations happening, not being reported, or fractures happening and not being reported. So it's important to see what we do and to be realistic. It's anything like a self-appraisal for any setup. Still not up. Okay. So why measure outcomes? Beyond the X-rays, most hips or knees patients improve, but a meaningful minority remain dissatisfied. We've spoken about robotics to satisfy these patients. We've spoken about other things. But PROMs will quantify the pain, function, quality of life and satisfaction of these patients. Audit links outcomes, our own outcomes, to technique, implants, the pathways and the complications. Patient-reported outcome measures are structured patient questionnaires. They measure pain, function, HRQOL, joint awareness and satisfaction, and complement our clinical review. It does not replace what is being done clinically, the assessment, but it just complements it. Why has it changed the arthroplastic culture? Shift from implant survivalship alone, patient experience and value to arthroplasty is given a lot of importance. Enables Dr. Nilan Shah used to say always that, we convert our patients into as if the truck has hit them. So pain control has been a very important factor. Enables benchmarking with case mix adjustment, makes unhappy but well aligned cases visible. We've all got certain X-rays that we look at like this in the OPD and want to shove it in the drawer. We don't want the patients to take them back. And we've all had X-rays that look excellent, but the patient is in a wheelchair. So we want to assess what we are doing. So what major programs across the world use? NHS PROMs, the ICHOM knee and hip OA standard set. Registries increasingly add PROM modules, which is ePROM, and reminders for these. Pick your PROM set, keep it minimal. The core routine are OKS, OHS, and plus EQ5D, and add on which are high performers are questionnaires with FJS 12. So you have one satisfaction question plus pain NRS that completes the picture. So why would this work? Because it's less than 5 minutes assessment for most patients. It captures quality of life and function. It detects the unhappy outliers, and it scales to SMS, WhatsApp or QR code enabled questionnaires. We follow a Google form at NHS Hospital, but this is what you can do. QR codes are coming in. We are in the process of revamping our HMS also to QR code based, completely QR code based digital paperless systems. Time points that actually work: routine, pre-op baseline, which is mandatory, 6 weeks early recovery signal, which is optional, but it's something which we can do. There are lots of outliers for this because pain, other things, comorbidities, lots of things come in, but 3 months is a good functional trajectory it shows you, and 6 to 12 months it's primary endpoint for most programs. Turning PROMs into improvement. So PROMs without audit is just data collection. So audit without PROMs is incomplete outcomes. So together they will answer what happened, why did it happen, and how can we improve ourselves. So plan, define the PROM set, define the endpoints, do collect the baseline and the follow-up, ePROMs, SMS or clinic based, study dashboards, median change, outlier and your case mix, ACT, which is improve action, okay, prehab, ERAS and technique refinements which a surgeon should understand. What to audit? Case mix, process, outcomes. So case mix is age, BMI, comorbidities, ASA and diagnosis. Process will be implant approach, tranexamic acid, length of stay, rehab pathways. Outcomes will be PROM change, complications, readmission rates and revisions. How to report? It's very simple and fair. The delta has to be reported, not only the post-op scores. Use medians, IQRs, flag outliers, stratify by case mix, stratify by BMI, because you cannot have a 20, BMI, ASA and diagnosis, everything should be stratified. Track the trends over time, how you are doing, how your team is doing. Common pitfalls, so low response rates are short forms, you have to have automated reminders. Selection bias should be avoided, so baseline for everyone you must have. Data without action, so there's no point. So monthly audit huddle has to be there. Once you start collecting data, just spend 2 hours once in a month, and you can go over those data. Over interpretation, so don't change too many things too soon. So start collecting, because it's difficult for us to understand what's happening really. Statistics, as they say, are misleading, and 76.2% of statistics are cooked on the spot. Okay, so implementation in a busy arthroplasty practice. So we have some great names from all over the country and the state today and tomorrow in this meeting. So busy surgeons, baseline QR WhatsApp form in OPD or paper backup, which your team can do. Follow up with SMS or WhatsApp reminders at 3 and 12 months. We are scared to do it, but we must do it. You know, sometimes you wonder if an unhappy patient will just bounce back on you or something, so we don't like to do it. But yes, it is important. One PROM coordinator will be helpful. You can have one coordinator to remind and, you know, look after this data. Monthly dashboard, 5 key performing indices and outlier review must be done. What do we do at NHS Hospital Jalandhar? This is for the hip. We do Harris hip score, acetabular size, femoral stem, head, and planned versus achieved leg lengths. Then we do for knee, we do planned HK, achieved HK, HK error, outliers, which are more than 3% with robotics, yes, and flexion gap, extension gap, femoral rotation, planned versus achieved, and tibial slope, planned versus achieved. Then you have for shoulder and elbow, ASES, FE, external rotation, and implant type, which is anatomic or reverse shoulders. We do for all these 3, hip, knees and shoulders, we do VAS, we do range of movement, flexion, extension lag for knees, KSS knee score, KSS function, okay, and I've missed WOMAC here. We do WOMAC for all of them. Then description, we have the UHID, that's how it's a UHID based, not name based or anything, because that's there's zero chance of confusion there. So it's UHID based, joint, which is just TK, THA versus TSA, side, left, right or bilaterals, robotic or conventional, so it's a binary number. That's how. So this is how we make an Excel sheet, and the variables that we study are the length of stay at the hospital, infection if there was any post-op infection in this patient, revision if any revision surgery was required eventually or in the next 1 year, readmissions within 30 days if they come back for any cause, and then of course patient satisfaction score, which is different from VAS. So this is how the chart looks like. This is our arthroplasty dashboard. KPIs like total number of arthroplasties, robotic percentage, average length of stay, infection rate, all this is auto calibrated. Once you have a Google form and the patient or your team fills the form, it automatically goes to a master dashboard which is populated by the form itself, and then which is uneditable. It is uneditable. That's the very important thing. So you cannot fudge numbers, and so it's also important to get into it with you have to be very diligent while filling it so that there are no mistakes. You can review before you submit it. So it's better to just review it once. So other things, then you have a master index and then you have outcome summary. Robotic accuracy panel, which is the core differentiator. This is the second sheet that we full. It's called, the second form is TK robotic KPI. For all our robotic cases, we do mean HK error and outlier rate. Histogram bar chart is auto-populated where x-axis is the HK error and y-axis is the number of cases that have it. For TK, mean KSS improvement. For THA, mean HHS improvement. And for shoulder, ASES improvement. Safety and quality panel again is maintained for every patient. We do average blood loss, average surgery time, readmission rate, any fever percentage of patients, and then simple indicators. Green are acceptable, amber, which is orange, is borderline, and red definitely needs review. Filters, so we add Excel slices or filters for who is the surgeon, which joint was done, robotic was done or conventional was done, and dates from wherever to wherever. So you can do a 90-day start tomorrow, plan with week 1 or 2, choose your pre-OM set and time points. Week 3 and 3 to 4, build your QR code, WhatsApp workflow and consenting for data collection. And month 2, you can do a dashboard template and the first audit meeting once you have some numbers done. and then the first change cycle, one pathway variable can be changed after 3 months. So that's your thing. So the key references that we have done for this talk, this is it. Thank you for a patient listening.
Thank you, Dr. Shubhang. I think this talk was the most wonderful one for the simple reason because most of us believe to be better than what we actually are, and the moment you start doing PROMs, you realize where you stand, and that's the sure shot way of improving, which all of us can do. Wonderful, wonderful talk. Thank you so much. Just one question from the audience, if any. Just one.
Shubham, do you take surgical site infection also as a criteria?
Yes. SSI is taken.
And how do you define your own surgical site
So there is a parameter.
infection?
So we have superficial wound infection, deep wound infection, culture negative, culture positive, like that.
Shubham, great talk. One other score is the so-called net promoter score.
Net promoter.
Or a friends and family test.
Okay.
So that is described in JBJS. So
Okay.
basically that is a culmination of everything that you have done. So if a patient is referring you more patients,
Yeah.
that means he's happy.
Yes.
Thank you. So one concession for the younger guy. He had a question. Yeah, please. No.
The promoters minus the detractors. So the
Net promoter score, that's interesting also.
So X-ray looks good, but he's not satisfied. First thing is you have to, so this is what the whole thing is about. Analyze why should you have these unhappy patients first. So the whole idea is to identify those excellent looking X-rays that you feel, "Arey wow, what is this?" But the patient is having pain. So there are other, first thing is identify if you have made any mistake. Number two, if there is genuinely, if you've operated, what went wrong in that case. Inside, sometimes it could be just a fantastic looking X-ray but dislocates every time you see him, or many other things like that, especially in knees, well aligned but still painful. So there are, then identify if any other parameters or any other factors you have missed, like spine involvement. PSY is a very big factor also. So your patient assessment, and actually we don't spend time on our post-operative patients as much as we spend on our pre-operative patients. So, that's what leads to unhappy patients. That's what I feel.
Thank you so much, Dr. Shubhang. With this, we end the session. Yeah.
That's true. Sometimes we promise them the sky also. But yes, the idea is to identify, if you think you are doing everything right, there may be many things that you can improve upon. So this is not to just identify what you are doing wrong, it is to how to improve yourself. Yes. It's a SWOT.
I just answered his question. That's a very relevant thing. You can do everything you want. You have to subject them to different PROs.
Yeah.
Go for the SF36.
Yeah, SF36, yes.
So the thing is that I have a thesis on that the minimum clinical difference between the PROs, like the Oxford score is about 5, every 5 degrees the score changes. But in course it doesn't change in 25 degrees. Different, and you make it.
So we do KUS and WOMAC and so SF36 we just recently added, I've not shown here. But that's, we are still trying to organize the system to call them and, telephonic.
So one are measurement based, one are quality of life, what is it? You can probably listen to more of it, different, then probably you can answer.
Indian arthroscopy society had started a registry. I don't know, Iaa-Nhs still does not have a registry for this, like all these scores.
No, we don't have. I think these scores are good to identify the unhappy patients, but what to do with these unhappy patients, we need a different set of scorings, I think,
Yes.
including psychiatric assessments.
Yes. Of the surgeon also sometimes.
Maybe of the surgeon if he's selling it very cheap.
So nothing spoils great results like long-term follow-up.
Absolutely right, Dr. Shubhang. And with
Thank
this
you.
great comment, we end this session. Thank you so much. Thank you, everybody.
Thank you everyone, and please join us for the banquet. Thank you moderators. I would just quickly want to invite the moderators for this and the previous session to join us for a group photograph here.
There is one.
And the speakers you will have to call in.
I would like to request the session moderators of the event, Dr. G.S. Chenna, Dr. Chetan Sood, Dr. Dilbans Pandey, Dr. Vikas Pada, Dr. Deepak Joshi, Dr. Sandeep Gupta, and Dr. Narendra Parmar to please come on the stage.
And then the speakers.
I'll call the speakers.
This is just a small token. It's quite a big token now.
Next, I would request the speakers of the session to please be ready to come on the stage. Dr. Narendra Parmar, Dr. Sandeep Gupta, Dr. Tanveer Bhutani, Dr. Trish Sethi, Dr. Rakesh Rajput, Dr. L. Tomar, Dr. Chetan Sood, Dr. Iqbal Singh Ghai, Dr. Anupam Mahajan, Dr. Sanjeev Gupta to please come on the stage. I would request Dr. Nilen Shah and Dr. Rakesh Rajput to please come on the stage, sir. We sincerely thank all of you for being here today and for taking the time to join us for this live robotic surgery workshop. Your presence and engagement has made the event like this meaningful. On behalf of the entire faculty and surgical team, thank you for your time. It has been an incredible day. Tomorrow, we will explore advanced robotic procedures, live Q&A sessions that promise to push the boundaries of surgical innovation. As we wrap up day one of our conference, let's take a moment to reflect on what an incredible day it has been. So rest well tonight, because tomorrow we continue to push the boundaries of what's possible. Thank you so much, everyone.